Da počnemo. I think that we can start. Good morning, everyone. It's our great pleasure and honor that the fourth Balkan Day, organized by European Association of Hematology in cooperation with the National Hematology Association of Serbia, will held in Belgrade in Serbia. Among us are a very famous expert in the field of acute leukemia, professor, that will hold their state-of-the-art lecture according to the planned session. We are particularly pleased and honored that the scientific meeting will be opened with the state-of-the-art presentation by Professor Constanza Donner, the elected President of European Hematology Association, and we congratulate Professor Constanza once again on the selection. Also, I would like to welcome the representatives of the many Balkan countries who took part in this very famous and very important scientific meeting. I wish you a pleasant time during the symposium, as well as during your stay in Belgrade. Thank you very much. Now I will announce the Professor Cori to talk about our collaboration and the action activities of European Hematology Association. Please.
Dear colleagues, dear friends, good morning. I'm Daniel Coriu, the president of Romanian Society of Hematology, a member of Community and Stakeholder Committee, EHA Community and Stakeholder Committee, and on behalf of European Hematology Association and EHA Community and Stakeholder Committee, I would like to say you welcome, and it's a great pleasure, a great honor to introduce this conference, the fourth EHA Balkan Day here in the beautiful city of Belgrade. I would like to express my gratitude to our host for this excellent organization. First, I would like to give you a short introduction about our history, because we have some history behind. Everything starting in 2004. EHA bring us together as a national hematology societies. And at that moment, we started this idea to organize a common organization here in our area. And we started with 4 countries: Bulgarian Society of Hematology, Turkish Society of Hematology, Hellenic Society of Hematology, and Romanian Society of Hematology. First meeting was mostly due to the organizational facts, take place in Bucharest in 2005. And then we decided to have these events together with the Conference of National Society. And the first one was take place in Turkey in 2005. And after that, again in Turkey, then in Greece, then in 2008 in Romania, again in Thessaloniki, in Greece. In 2011, we had here in Belgrade this meeting. Then again in Turkey, again in Romania, again in Turkey, then in Greece. And in 2019 was a very important. EHA decided to join to this meeting, and we have the first joint meeting in Bulgaria. And I think you remember this nice photo. You can see there Professor Constanze Donner, you can see there Gianluca Gaidano, and some of us were there. The next one was virtually. Unfortunately, in 2020, pandemic started, and in 2021 was the virtual meeting taking place in Romania. The next one was a hybrid in 2022 in Saloniki, in Greece, and now we are here. And finally, I would like to give you a few words about this new community and stakeholder committee. The main mission of this committee is to promote the value of EHA. And maybe the most important thing is to develop close relationship, strong close relationship, and collaborative opportunities with national society and sibling societies. For that we are here. We gather here today as a community of hematologists, united by our shared dedication to advancing in the field of hematology and improving patient care. This conference is an important moment for all of us to come together, exchange knowledge, speak about innovation that drives our profession. It is a moment when take a new step to shape the future of hematology in our countries. And for that, we really need a permanent collaboration. For that we are here, we have to stay together. Thank you very much. Now it's my great pleasure to introduce Professor Constanze Donner. Please.
Yeah, good morning, everybody, and thank you very much, Daniel, for your kind words. So my name is Constanze Döner. For those who do not know me, I'm a hematologist. I'm working at the University Hospital in Ulm, Germany, and I joined EHA as a board member in 2018. I'm currently a member of the executive board, and I was selected this year, yeah, as president-elect for EHA. So I'm really happy to be here again in my role as hematologist, but also in my role as an EHA, as an active EHA member, and as Professor Corriou already mentioned, I've been here for several times, and I always enjoyed my time at the meetings with you, tutorials, the Balkan meetings, and I really appreciated the open communication we already had. I would like to take the opportunity to give you some information on EHA, on our activities, our mission, and our vision. So within the next 5 to 10 minutes, I'd like to show you some data on EHA. So we've heard this already. Together we shape the future of hematology. I think this is really a very important message that Professor Corriou also told us this morning. And the first slide here shows you who we are, EHA. So the European Hematology Association, we are a membership organization, and our aim is to serve the clinicians and the researchers who have an active interest in hematology in Europe and beyond. And EHA brings together the relevant stakeholders in the field to promote excellence in patient care through education, research, and advocacy. So this is slide shows you a little bit the structure of EHA, and I start with our members. So to date, we do have around 6,500 members from more than 100 countries across Europe and the world. And I think this is one of our goals, to also increase membership and to engage the members. And I hope that some of you will be convinced today that it's worth to become an EHA member if you are not a member already. So we have in total more than almost 20,000 people attending our events each year. One of the biggest events, and you know that, is our EHA Congress that takes place in June in Europe every year. And then we have more than 500 individuals contributing to the many committees we have at EHA and the units and the boards. We have a growing executive office. I think 45 people is not realistic anymore. I'm looking to Martin. I think we are more over 50 people, and it's still increasing. And that shows that we have many, many activities and many new ideas and programs. And we do need the executive office, because this professionals map out the strategy, define the goals, and create the business plans. And they ensure that the EHA programs and services benefit our community. Then we have the specialized working groups. These are really groups working on a special area in hematology. And I think we need to increase the visibility. And I think it's nice here to inform you about the specialized working groups, and that you can join and apply to become a member and have a voice in the certain area you are interested in. It's really very easy to become a member, but then you have an impact. And for the young people, it's really nice to have a kind of mentorship from these experienced people working in the specialized working group. So please have a look at our website if you are interested. We are happy to get new members here. And then we have the board, 16 board members that set the vision and the mission and the values of EHA. So this slide shows you our mission, and we discussed a lot about the mission at one of our last board retreats, and we found a common definition, and I'm really happy with that. And our mission is towards prevention, cure, and quality of life for all patients with blood disorders. So this mission is surrounded by four, I would say, very important topics, issues. This is first, connecting hematologists worldwide. And I think this is one reason why we are here today. Supporting career development and research, and in particular for our young people, for our young hematologists, we have really very nice programs. Then harmonization, hematology education, and this is one of my really favorite tasks. I'm chair of the education committee, and we are trying to offer really very interesting and modern programs in our education area. And we have the campus, which is really very attractive, and social media tools for the young people. And here you find a lot of really good educational programs. And we also have the European hematology curriculum, and I think this helps to harmonize education at a high level. And then advocating, I think this is another very important point, to advocate, to represent the interests of hematologists and hematology. So we are connecting with hematologists worldwide, and all the members of EHA, they have the opportunities and the tools to connect and to support each other in clinical work and research. And we connect, and I've shown you the data before, thousands of hematologists globally through our activities. And one important activity is the close collaboration, the close relationship with the national hematology societies. So we have the HOPE meetings that taking place in Europe, but also beyond Europe. We have the joint symposia. We have a number of local partners and joint memberships. I will come back to this later. And we do have our tutorials. DEI, diversity, equity, and inclusion is another important issue that we have to face as a large association. And this is just exemplarily shown here on this slide. As you can see, our members represent a wide range of ages, from the early career to experienced professionals. And as you can see here, approximately 40% of our members are younger than 36 years. And most of our members are from Europe, 77%, and the countries with the most EHA members are Spain, Italy, Germany, and the Netherlands. So I think despite the fact that we have increasing numbers also for the other countries, I think there is still some room for improvement and for close relationship and working together. You can see here the membership in the Balkan areas. And I think this has already been increasing, but I think, and I'm sure that the numbers will increase in the next future. I think it's hard to read, but the message is clear. Joint memberships, that's a great opportunity for the national societies to come together with EHA. The joint membership is, as I said, an opportunity for a member from a national society to also be a member of EHA through one application process and by paying only one fee. So this is really uncomplicated. And the major aim here of this joint memberships is to intensify the EHA collaboration with the different national societies and to strengthen the voice of hematology and hematologists in Europe. So EHA and the national societies, they will be able to offer extra benefits and easy service to their members by providing them with more options and better ways to further learn and to develop themselves. And as I mentioned before, the education program is really an excellent one. And this, as a member, you can use a lot of these courses and programs that we do offer on a regular basis. So this shows you the actual status of our joint memberships, and Professor Corriou has already mentioned the joint memberships that we have with the Balkan countries. So I think this is something that is really a very nice development, and I hope that we can increase the numbers of joint membership in the next future. This is, I think, all I would like to tell you today, not to be too long with my introduction on EHA and its activities and our aims. So if you have more questions about EHA, the cooperation and relationships, in particular with the Balkan countries, the activities, please don't hesitate to contact our staff members outside, Martin or me. Brian Huntley is here today, also a member of the executive board. So we are happy to give you more information if you are interested in. And I'm really happy to be here to see many of you again. And I'm looking forward to a really, really exciting meeting today. Thank you very much for the invitation.
Now we opened our meeting, and I kindly ask Professor Constanza Donner to start her state-of-the-art lecture, please.
Dear Chairman, dear colleagues and friends, ladies and gentlemen, so first of all, I would like to thank again the organizers for the kind invitation to the EHA Balkan Hematology Day here in Belgrade. It's really, as I already mentioned, a great pleasure and a great honor for me to be here. So within the next 25 minutes, I would like to discuss with you novel aspects on classification, diagnostic workup, and prognostic factors in acute myeloid leukemias. And as you all know, since last year, we have two different classification systems for acute myeloid leukemia, the International Consensus Classification and an update of the WHO classification, and also the European Leukemia Net recommendations have been updated. And all three have a major impact on the management of our AML patients. So here are my disclosures. So first of all, I think it is important to note that the ELN recommendations and the international consensus classifications have been developed in parallel and in close collaboration. And many of the ELN panel members, they also have been clinical advisors for the ICC. That means, as a consequence of that, that the ELN has implemented many aspects of the ICC. So considerable changes have been made with the new international consensus classification. First of all, we do have changes with regard to the blast thresholds defining AML. AML with recurrent genetic abnormalities now require more than 10% blasts, and this was introduced due to consistency across the different categories. For the other categories, a new nomenclature was introduced, that is, cases with 10 to 19% blasts are now designated MDS-AML, and cases with more than 20% blasts are designated as AML. So there was really a broad consensus that, that this term MDS-AML much better reflects the continuum, the clinical as well as the genetic continuum of these cases. And this does not mean that all cases with MDS-AML now have to be treated as an AML, but this terminology will allow us to enter our patients or to enroll our patients into MDS trials, but also in AML trials. And that means that the patients have access to novel drugs. Another important change is the introduction of new genetically defined entities, AML with mutated TP53, AML with myelodysplasia-related gene mutations, and I will come back to this in a minute, and AML with myelodysplasia-related cytogenetic abnormalities. And with regard to the ancient AML history, the classification now describes prior MDS or MDS-MPN and prior therapy as qualifiers to the diagnosis rather than as separate categories. And as a consequence of these changes, AML with myelodysplasia-related changes was eliminated from the classification. So coming back to the blast thresholds, so far, 20% plus distinguished AML from MDS. And this slide shows you data from a prospective study on the blast thresholds that was published in Blood 2022. And this is data from Eli Estey's group. And what they did, they analyzed more than 1,000 patients with MDS, EB2, and AML according to the WHO. And as you can see from this slide, from the overall survival curve here on the left-hand side, you can see that patients with an MDS EB2, that the overall survival was somewhat inferior compared to the AML patients. And after accounting for age and performance status, genetic risk and allogeneic stem cell transplantation, they could show that patients with MDS EB2 and AML, that they have similar rates of survival and response to the therapy. And this is really challenging the arbitrary 20% blast threshold. And many cooperative groups have already included the MDS EB2 in their clinical trials. So coming back to AML with myelodysplasia-related changes, I've already mentioned that this category was eliminated in the new ICC because there were quite a few issues with this category. So first, clinically, secondary AML has not been uniformly defined. That means that we use different latency periods, but also the diagnosis of a preceding MDS was often not confirmed by a standard diagnostic workup and was only based on the number of blood counts. I think most importantly is the fact that clinically defined secondary AML, that they lacked a biological basis. And finally, one criteria for the definition of AML MRC was multilineage dysplasia, which has no independent prognostic significance and which has only moderate reproducibility. So this slide shows you one of the first, if not the first study that identified a gene signature for secondary AML. This is a study published by Coleman Lindsley and colleagues. And what did they do? So they compared the mutational profile of 93 clinically defined secondary AML patients with 100 de novo AML patients from the Cancer Genome Atlas. And they identified a gene signature that is characterized by mutations in 8 genes that are marked here in red. And these gene signature was highly specific for the diagnosis of a secondary AML. So in a next step, they validated the signature in 105 unselected elderly clinically defined de novo AML cases. And interestingly, they found that 33%, 1/3 of the patients, had this secondary AML type mutation signature. And these patients, they shared clinical pathologic characteristics with clinically confirmed secondary AML. And as you can see by the overall survival plot on the right-hand side, patients with mutations in these genes, they have a really inferior outcome. So this is data from our own targeted sequencing study. And the aim of our study was not to identify a gene signature for secondary AML. Our aim was to identify genomic classes. And here we found one interesting class that we named the chromatin spliceosome class. And classification in the chromatin spliceosome class required 1 or more mutations in these 9 genes that are marked here in red. And interestingly, almost all of these genes are identical to the gene signature that has been identified by Coleman Lindsley. And this class was associated with older age, lower white blood cell counts, incident myeloid disorders, multilineage dysplasia, and inferior outcomes. So all features of AML with myelodysplasia-related changes. And interestingly, there is unpublished data from the Hovan group on more than 2,000 AML patients, and they identified the almost identical gene signature in their patient cohort, and all these patients had an inferior outcome. So there's really a remarkable consistency across the studies with regard to the gene signature and the outcome. So with regard to AML and TP53 mutation, I think there is accumulating more and more evidence, both from a clinical but also from a molecular perspective, that AML and high-risk MDS with TP53 mutation is or represents an own molecular defined disease entity. And this is again data from the Hovan group, from Peter Falk's group. They have published their data in Blood last year. And there are 2 important molecular perspectives that they have found in their study. So first of all, they found a very high association of these TP53 mutated AML and MDS EB cases with a complex karyotype. But they also found that approximately 50% of these patients, they showed a paucity of concurrent gene mutations, so no concurrent gene mutations. And For the patients who had concurrent gene mutations, they could show that these are known contributors of age-related clonal hematopoiesis, such as DNMT3A, TET2, and ASXL1, that all lack a clinical relevance. So as we all know, TP53 mutations are associated with a really poor prognosis in the patients, and this is also shown in this study. You can see the overall survival is really poor on the left-hand side, irrespective of whether the patient has an AML or a high-risk MDS. And this was also seen for the presence of a single mutation in TP53 or multiple mutations, no difference in this poor overall survival. And the same was found when they looked or compared monoallelic versus biallelic TP53 mutations. And they also evaluated different TP53 variant allele frequency thresholds. So I think based on that, we can, am I out of time? Okay. Okay. It's good to know. Maybe it's also important to mention that, that with regard of the concurrent gene mutations, that they only confer limited survival benefits. So I think we really have a nice clinical and molecular evidence now based on this data that TP53 mutated AML should be an own category within the ICC. So this slide gives you an overview on the ICC. And I already mentioned for the AML with recurrent genetic abnormalities, only a few changes have been made. We need 10% blasts or more for this for this category of AML. And for AML with CPB alpha mutations, there was an update, a redefinition, and I will come back to this later in my talk. And then we have the introduction of the genetically AML categories, AML MDS AML categories, AML with TP53 mutations, AML with myelodysplasia-related gene mutations, these 9 genes that I have shown you. And then we have the AML with myelodysplasia-related cytogenetic abnormalities. And for all the remaining cases, they are designated as AML not otherwise specified. And it is important that for these 4 categories, the blast threshold of 10 to 19% designated these cases to MDS AML, and if it's more than 20%, then we name these cases AML. So one important point is that this ICC is a hierarchical classification system, and on top of the hierarchy is AML with recurrent genetic abnormalities. That means it trumps all other categories. So if there is no recurrent genetic abnormality, but there is a TP53 mutation, then we call this disease MDS AML or AML with mutated TP53. If there is none of these two, but we do have 1 or more mutations in these myelodysplasia-related genes, then the disease is categorized as MDS AML or AML with myelodysplasia-related gene mutations. If there is none of the 3, but we do have a cytogenetic abnormality, then the AML is categorized as MDS AML or AML with myelodysplasia-related cytogenetic abnormalities. And if there's none of the 4, for the remaining cases, as I already mentioned, they are categorized as AML not otherwise specified. And to all these different categories, we now have the diagnostic qualifiers, therapy-related, prior MDS or prior MDS MPN, as well as germline predisposition that are appended to the different categories. So the ICC also has a significant impact on the initial genetic workup. So first of all, cytogenetics, they are still an integral part of our diagnostic workup. They are still gold standard in the AML diagnostics, and results should preferably be obtained within 5 to 7 days, which is, I think, a major challenge for many labs and maybe not really realistic in most of the labs. Then screening for gene mutations, in particular for the actionable therapeutic targets like FLT3, IDH1, IDH2, and also MPM1. Here, the results should be obtained within 3 to 5 days. And for the remaining list of genes, you can see these are mainly the genes belonging to the myelodysplasia-related gene mutation category. Here we should get the results within the first treatment cycle, and screening for these genes is mainly performed by next generation sequencing, and I'm sure we will hear more about that later. So we can also have a rapid screening for the recurrent gene fusions by PCR or FISH. And interestingly, the ELN in their recommendations, they also recommended to screen for additional genes at the time of diagnosis. They are not required for the diagnosis, but it is a recommendation that might be helpful to have the information to monitor these patients by measurable residual disease during the course of the disease, during the treatment. This is still under investigation, but we all know that the field is really rapidly evolving. So as I mentioned before, the ELN was also updated last year, and many aspects of the ICC have been implemented in the ELN recommendations for AML. And this slide shows you the updated ELN genetic risk classification, and the major changes are marked here in red. For the favorable group, we do have a number of studies that have clearly shown that in-frame mutations in the basic leucine zipper domain of the CPB alpha gene, that they confer a favorable prognosis irrespective of if they occur as monoallelic or biallelic mutations. So in the firmer risk classification, we only had the biallelic CPB alpha mutations in the favorable group. Now it's the in-frame BCIP mutation, mono and biallelic. Another important change is that all FLT3 ITD mutated AML cases are now categorized in the intermediate risk group, independent from the co-occurrence of an NPM1 mutation, and the FLT3 ITD allelic ratio is not considered anymore for several reasons. And then we have the adverse risk group. Here some redefinition was performed for the complex karyotype. And then you can see the myelodysplasia-related gene mutations have been included in the adverse risk group based on the data that I have shown you. And it is also important that the ELN emphasizes that the initial risk assignment may change during the treatment course based on the results of the MRD monitoring analysis. So the ELN genetic risk stratification, risk classification has been developed in mainly younger, intensively treated AML patients, and therefore it might not be applicable to the older patients who received less intensive therapy. And within this context, I would like to briefly discuss with you data that has been recently shown from the VIALE-A study. So in this study, they had two major objectives. First, to evaluate the ELN 2017 and ELN 2022 risk categories to patients who have been treated with AZA-WEN. And second, to develop a prognostic gene signature for response to AZA-WEN. So in total, 279 patients who were treated with AZA-WEN were included in this analysis, patients from the VIALE-A and from the phase 1b study. And in addition, a comprehensive genetic screening has been performed, also including next generation sequencing analysis with 194 genes. So this slide shows you on the prognostic value of the ELN 2017 and ELN 2022 risk categorization. And I think you can see by the Kaplan-Meier curves here on the slide that the ELN risk groups do not provide clinically meaningful outcome stratification for patients who have been treated with Ven-Aza. So that means for these patients, for the older patients, and maybe also with regard to the type of treatment, we have to think about, or we have to identify new risk stratification systems. The second objective, to identify a prognostic genetic signature for response of treatment. Here they used a really specific biostatistical analysis, and they divided the patients into 3 distinct groups based on their overall survival, and then they determined how these groups differ with respect to baseline genetic data. And what they found, they could identify 3 different risk groups, and you can see the curves are separating quite well. The higher benefit group, characterized by wild type for TP53, for KRAS and NRAS, and for FLT3-ITD. Then a lower benefit group, and here this was characterized by a mutation in TP53. The median overall survival only 6 months, and as you can see for the higher benefit group, the median overall survival was more than 24 months. And for the patients not fitting in the higher benefit or lower benefit group, these patients has been categorized in the intermediate benefit group, and here the median overall survival was 12 months. So I think this is really a very interesting study, because they showed that the prognostic signatures of the 3 groups, they were derived based on the mutational status of only 4 genes. So at the end of my presentation, I would like to briefly discuss the increasing role of measurable residual disease in AML and its clinical implications. So we have to date, we have a large number of studies that clearly show that the MRD status at defined time points during the treatment and during the early follow-up period is of prognostic relevance. And we can use MRD to assess response and to detect an early relapse, and therefore to guide preemptive therapy and to start interventional therapies. And it is also very important for treatment decision making, in particular within the context of post-remission therapy. For example, if a patient should be treated with allogeneic stem cell transplantation. We can also monitor treatment effects, which I think is of particular interest in clinical trials using novel drugs. And MRD is currently discussed as a surrogate endpoint in clinical trials to accelerate approval of novel drugs. So with the rapid development of next generation sequencing technologies, we are now able to also monitor some challenging molecular markers like FLT3-ITD. And this slide shows you data again from the HOVON group that have been published last year. And in this study, this is a retrospective study on 161 treatment-naive de novo AML patients, all with a FLT3-ITD mutation, all enrolled in the HOVON or SAC clinical trials, and all received intensive therapy. And they established an amplicon-based MRD assay with a high sensitivity of 10⁻⁻⁵. And what they could show, so in patients who achieved a complete remission after 2 treatment cycles, they could show that the presence of FLT3-ITD MRD was significantly associated with an increased 4-year risk of relapse, 75% for the MRD positive patients versus 33% for the MRD negative patients, and also with an inferior overall survival. And also in multivariate analysis, they could show that FLT3-ITD MRD was an independent prognostic factor, even outcompeting the significance of the most established markers in AML. Interestingly, at the last EHA meeting, also the data on NGS-based FLT3-ITD MRD monitoring from the Quantum First trial have been presented. And you know that in the Quantum First trial, the 2nd generation FLT3 inhibitor, quizartinib, was combined with intensive chemotherapy. 321 patients who achieved CRC after 1 or 2 courses of induction were available for this analysis. Again, an amplicon-based NGS assay was used with a very high sensitivity. And as you can see, patients who achieved CRC by the end of induction and patients who achieved a FLT3 ITD MRD level below 10^-4, they had a significantly improved overall survival, as shown here by the blue curve. And another interesting finding, when comparing the 2 treatment arms, they could show that patients who received quizartinib together with intensive chemotherapy, that they had a significantly better reduction of the FLT3 ITD variant allele frequency. So the survival benefit of these patients treated with quizartinib seems to be, at least in part, derived from an early and deep reduction of the FLT3 ITD leukemia burden. So the last slides, I would like to show you also our own data on FLT3 ITD NGS-based MRD monitoring, and the aim of our study was to evaluate the prognostic impact of the MRD status defined at several time points, not only after 2 cycles. From patients with FLT3 ITD mutations, patients who have been enrolled in our AMLS G1610 trial. And this was a multi-center single-arm study combining midostaurin, the first generation FLT3 inhibitor, with intensive chemotherapy, and patients received for post-remission therapy in high priority allogeneic stem cell transplantation, followed by a 1-year maintenance therapy with midostaurin. So we identified 157 patients who achieved a CR or CRI after induction therapy, and for whom bone marrow and peripheral blood samples were available at diagnosis, after 2 cycles, at the end of treatment, and during the early follow-up period. Median age, 54 years, and you can see a high rate of patients who received allo stem cell transplantation in first complete remission, 77%, and the median follow-up, quite good, 47 months. This is one of the most important results we found in our study. Achievement of MRD negativity after 2 cycles was significantly associated with a inferior 4-year cumulative incidence of relapse and 4-year overall survival. You can see here the cumulative incidence of relapse was 51% for the patients who were still MRD positive at this time point. And in multivariate analysis, we could show that after 2 cycles, achievement of MRD negativity was a consistent variable for CR and overall survival. Finally, we also evaluated the impact of conversion from MRD negativity to MRD positivity during the early follow-up period. And during this time period, 16 patients converted from MRD negative to MRD positive, and 13 of the 16 patients relapsed within a really short time, median time of only 7 days. And this directly translated into a significantly higher relapse risk, as shown here on the left-hand side by this Kaplan-Meier plot, and an inferior overall survival. And in multivariate analysis, MRD conversion was the strongest factor for outcome in these patients. And interestingly, the 3 patients who did not relapse, they had very low FLT3 ITD MRD levels. 2 of them received midostaurin for maintenance therapy, and all 3 became MRD negative later on. With my last slide, I would like to sum up. I think I've shown you that there have been major advances in our understanding of AML, including the new knowledge about the genomic landscape that leads to an update of the disease classification, a refined risk classification, and the identification of predictive factors, but also progress in technologies in the genomic diagnostics and the assessment of MRD in our AML patients. And data on the mutational landscape and its clinical significance in the older patients ineligible for intensive therapies, these data are emerging, and I think we do need more data, and we need to validate the findings that have been published so far. And these recent advances, they are nicely reflected in the new ICC of AML, as well as in the 2022 ELN recommendations. And with that, I would like to finish my talk. I would like to thank you for your attention, and I'm happy to discuss with you these data and to answer questions. Thank you very much. Should I come up?
Let's go. Thank you very much for your nice talk and for introduction for this session. As we are a little bit short with time, as proposed, we have joint discussion afterwards. So I will call. Yeah, please take a seat.
I come over. Yeah.
Yeah, from this side, and I will ask Dr. Antolic from Croatia to take a mic.
Good morning, everyone. My name is Margareta Radic-Antolic. I'm a specialist in medical biochemistry and laboratory medicine, and I work in the Department of Laboratory Diagnostics in University Hospital Center Zagreb. These are my disclosures. I would like to thank the organizers to this invitation, and my task today is to talk about NGS in AML. As you all know, AML is a heterogeneous disease, and we need heterogeneous laboratory approach to manage AML. So we need cytomorphology, immunophenotyping, and genetics. Last classification of AML 2022 gave us really a good start with genetics. They put genetics in front of morphology because it has a big impact on phenotype and outcome of patients. So in this case, we cannot use single gene PCRs anymore because they are not informative enough to characterize this disease. On the other hand, we have NGS, a very powerful tool to seek for different molecular markers in the same time and to manage AML very good. ELN recommendations from last year gave us quite a good perspective how to do that diagnosis. In this table, you can see all the relevant things you have to know how to diagnose these patients. I would refer to a genetic analysis where NGS is recommended for screening for gene mutations using a gene panel diagnostics. But in this, some cases, NGS is not good enough, or it's not informative enough for some mutations. So for example, for a FLT3 ITD detection is important in diagnosis to use a capillary electrophoresis, because some softwares we use in NGS do not recognize these duplications very well. In the area of TKI inhibitors for FLT3, it's very important to diagnose patients with these mutations. I think most of the routine clinical laboratories really use a combination of single tests and NGS in order to get the very rapid results for some mutations, and they lack of finances and personnel, so they do NGS more, not so often they should. So this turnaround time for this analysis sometimes is too long, and it should be in this time that is here mentioned, but sometimes it's just not possible, and not possible for all the patients. So we have to manage with the things we have in our laboratories. I speak about NGS, but I didn't say what NGS really is. We have different definitions of NGS that are saying about its technical things. It's also a technology that is revolutionized clinical practice. And my favorite definition is that it's established methodology in a clinical laboratory for screening and diagnosis germline and semiotic mutations in order to give our clinicians some information about the genomic profile of a cancer. I think really NGS is a very powerful tool and a bridge who gives us an information about patients or a group of patients to see how we can personalize the therapeutic approach. First, we had Sanger. I started Sanger with AML mutations 10 years ago, and now we have lots of NGS types. One of the the biggest information we get from whole genome sequencing. It's this big pie on the left side, and you can see that we can get very much information for lots of money, but with low sensitivity. The piece of that pie is whole exome sequencing, which we can use to detect variations in coding regions, but we don't use it in a clinical laboratory yet. For clinical laboratory, is recommended to use targeted sequencing. It's a type of sequencing where we choose genes or hotspots in those genes to detect some variants that are known or novel, and we can use it for association with some diseases we are trying to detect. In AML, NGS is based on two panels. First panel is using DNA to detect single nucleotide variations in DELs and copy number variants. As Professor Donner said, we have different genes associated with myelodysplasia and TP53, and those mutations, it's not possible to do with single PCRs. We need this tool to do it with NGS. On the other hand, we also need to detect some fusion transcripts and alteration, and that is done with RNA-based NGS. But I think in most clinical laboratories, the routine practice is to use karyotyping, FISH, and PCR-associated methods because they are well established in our laboratories. We know how to use it, and it's easier to do that, maybe even faster in this time. And NGS is therefore still not widely used for identification of gene fusions. As Professor Donner said, we have classification, risk classification of abnormalities in risk classification of AML from ELN from last year. We have these big letters and we also have these small letters. We have to read the both to have a good risk stratification, classification of our patient at diagnosis, to seek for mutation that are targeted for our therapy solutions and for predicting relapses. It's also one very big group of myeloid neoplasms with germline predispositions. You can see here we have a pretty big list of genes that are needed to be done. So it's very important that clinicians are know for that, and they take a thorough family history to identify potential myeloid neoplasms with germline predisposition in families. It's very important to do that for every patient, regardless to age, because this patient can have malignancies in older age. And it's important to know that we just report pathogenic and likely pathogenic variants now that are considered to be causative of this hematological disease. Also, we have to follow those mutations in all families. It's important because of the inherited germline predispositions to hematological malignancies or more malignant states. And it's also important when we talk about family donor selection for allogenic stem cell transplantation. Professor Donald also said that it's very important to detect MRD in AML patients. We all know that we have well-established methods for MRD detection, multiparameter flow cytometry, which is very spread in our laboratories, but it has a point of less sensitive and very subjective method sometimes, and also real-time PCR, quantitative PCR. But all those methods have their advantages and limitations. Sometimes we don't have a patient who has some kind of fusion transcript or NPM mutation, so we cannot use real-time quantitative PCR for MRD detection. On the other hand, we could use NGS for potentially any somatic mutation we could find in our patients, but still we don't have enough harmonized this whole process from taking sample to giving the results. In conclusion, I would like to answer the questions I asked on the beginning of my lecture. I think it's very important to do NGS to every patient at diagnosis and for differential diagnosis. It's very important that we use it for risk stratification, therapy approach, for MRD. Also, we can seek for leukemia evolution, and it's important to find germline mutations for prevention. When we should use it? We should use it at diagnosis. We do it in Croatia at diagnosis. It also could be done in relapse and planning bone marrow transplantation. In the end, I would like to thank all the people who are in our group in the University Hospital Center Zagreb, Department of Hematology and Laboratory Diagnostics, and my MIC team. It's a multidisciplinary team for acute leukemia, where we discuss all our patients with our clinicians, and we try to avoid these pre-analytical errors that can range up to 75%, and they could imply on our results in the end. Thank you.
Thank you very much. I would like to continue. I will call Professor Suvejic for showing us results of FLT3 acute leukemias. Thank you.
Dear colleagues, representatives of IHA and representatives of national associations, I am grateful for the invitation and the honor to present the experiences of our center in the treatment of AML patients with FLT3 mutation. First, I will represent our center. We had 210 employees, among them 40 physicians, 6 biologists, 136 medical nurses, 17 lab assistants. In the last year, in March, we relocated into modern building where the standards for treating acute leukemia patients was met. It means single and double rooms. Our center consists of 11 departments and 3 services, and some of them are thematically oriented. In the new building, we have highly improved working and accommodation conditions and improved patient care too. We have 70 to 80 newly diagnosed AML patients per year. 1/3 of them are elderly patients, and 10% are those with acute promyelocytic leukemia. 60 patients per year are suitable for intensive treatment, 12 per year for non-intensive treatment, and about 5% are for palliative care. We assume that in Serbia there is 150 to 160 newly diagnosed AML patients per year. At the last National Congress of Hematology in October last year, we prepared recommendations for diagnostic and treatment of patients with acute leukemia, in which we implemented the newest recommendations of ELN and ESMO. Unfortunately, limited financial resources prevent us to implement those recommendations in our everyday work. This is the list of genetic analyses recommended by ELN, the latest ELN. And this is the list of genetic analyses that we perform in our center. It is karyotyping, FISH, and PCR. The results are available within 7 to 8 days, just the time to give the midostaurin on the day 8. Among 219 newly diagnosed AML patients, we have about almost 20% those with FLT3-ITD mutations and almost 2% with TKD mutations. 17 patients who are ITD positive had also mutation in the gene of nucleophosmin. Addressing the issue of treating with patients fit for intensive chemotherapy, we could treat them with chemotherapy with midostaurin if they have FLT3 mutation. I must say that midostaurin is not reimbursed by Health Insurance Fund, but it is given in our center. The patients who are not, who don't have FLT3 mutation are treated with classical 3+7 in induction and 3 cycles of IDAC, but oral izacitidine is not available in our country and in our center. Besides, Mylotarg and Vixiers are not available too. Addressing the issue of treating the unfit patient for intensive chemotherapy, in our center they could be treated with monotherapy with azacitidine, low-dose cytarabine, and best supportive care. Azacitidine is not reimbursed by Health Insurance Fund. Midostaurin is a drug registered in Serbia since 2019 for AML and advanced systemic mastocytosis. It is not reimbursed by Health Insurance Fund, but our clinic is providing Mido from its own funds from March last year. We also rely on the patient-oriented program. Our first experience with Mido was in phase 3B study with midostaurin, sponsored by the Novartis. In that study, we enrolled one patient just before termination of enrollment. She had TKD mutation. After induction, she achieved partial remission, and after second induction, she contracted COVID-19 and died in aplasia. Those are the results of our 12 patients with AML and FLT3 mutation treated in our center with Mido. The median age is 43. The median VBC count is 34. 10 among them had ITD mutation. The median follow-up was 16 months. The median overall survival was 5.5 months. 2 patients died during induction. We had 8 complete remissions, 6 patients were transplanted, and 5 of them are still alive. Among the mutated patients, 10 were with intermediate risk and 2 with adverse risk. This is the review of our 12 patients. It is of note that among them, 2 were primary refractory and 3 relapsed. 1 after allogenic transplantation, 2 during consolidation with IDEC. We also have 1 patient which is treated with mido off-label. She received, this is a patient, FLT3-ITD positive, who was transplanted and who received mido after allogenic transplantation for 1 year as a maintenance therapy. She is still in complete remission, morphological and without minimal residual disease for 2 years until today. In conclusion, we must say that in our center and in our country, we need better diagnostics based on NGS in order to improve risk stratification of our patients. Personalized treatment based on the genetic profile of each patient should be our goal. All centers in Serbia should have refundable midostaurin, and all treatment options recommended by ELN, the latest ELN, and ISMO should be available for all patients with AML. Thank you.
Thank you for your speech, and I invited Professor Vidovic from Serbia to talk about treating unfit patients with AML.
Dear colleagues, the issue of treating unfit AML patient is one of the crucial problems faced by hematologists, and it will be discussed in the next 10 minutes. The term unfit patients usually refer to patients, elderly patients than 65 or 75, but also patients with high comorbidity index, and also non-compliant patient for some a certain type of treatment. Also, term fragile or frail patient has multiple meanings, as you can see in these slides. It is well known that AML is very heterogeneous disease according to the very complicated molecular classification scheme with the most common genes mutation, as you can see in this classification. According to the ELN classification based on molecular and cytogenetics findings or changes, EML patients divided into 3 risk group: favorable, intermediate, and adverse. It is well known that the AML is disease of elderly. The median age is about 70. And also it is known, very well known, that the incidence of prognostically poor cytogenetics findings, such as you can heard before, AML with monosomal karyotype, complex karyotype, also AML with myelodysplasia or therapy-related AML is very frequent in this group of patients, but relative incidence of recurrent cytogenetic abnormalities is reduced in this population of patients. This chart clearly shows the exponential decline of 5 years survival in those group of patients comparing with the younger patient, as you can see. There are many scoring systems that help doctor to define for which therapy is patients suitable, intensive or non-intensive, and one of them is Ferrara score, as you can see, but revised acute myeloid leukemia composite model is more clinically applicable, and we use this model. Now I would like to show you in the next 2 slides the timeline of AML therapy from the first application of chemotherapy back in 1960 as you can see. Then application of evidently unreplaceable regimen 3+7 combination with cytarabine and anthracycline through the performing allogenic stem cell transplantation, and discovered and also approved many new drugs in the past 2 decades, as you can see, and many of these drugs or agents have indication, especially for unfit or elderly patients, such as agent CPX351, so-called Vyxeos. Also, venetoclax, very potent inhibitor of anti-apoptotic BCL2 protein or hypomethylating agent, and some tyrosine kinase inhibitor. Professor Constanza very detailed talk about Viale C and Viale A study, and it is very well designed study, double-blind placebo-controlled study, where Professor Constanza said, and I will very shortly pass this slide. Also Viale A, you can see that the median age of this patient is 76 years. Okay, there is also some younger patient, but this patient is also in some instance not suitable for intensive treatment. And in the BOOT study, you can see that the rate of complete remission, I will back, also the overall survival was significantly longer or better in the group with AZA and venetoclax on in the previous study, venetoclax plus low doses RC. It is also very important that the transfusion independence is significantly higher in the group of these previously mentioned patients. The result of these two studies directly influenced the approval of the use of Vyxeos or venetoclax with combination with hypomethylating agent or low doses RC for patients who are not eligible for intensive therapy, chemotherapy. As I mentioned before, there are also one agent, Vyxeos, that represent a fixed combination liposomal of cytarabine and daunorubicin, and it pretends to be a new standard of therapy for elderly or unfit patients. And this study shows that the overall survival was significantly longer in the group treated with Vyxeos versus regimen 3+7. And this is the overall survival, and this agent is especially effect on the elderly patient, elderly than 65 and 70. This slide on the bottom show recommended therapy for elderly patients. And there is all drugs or agent that I mentioned before, and this combination, especially hypomethylating agent AZA or something else with venetoclax, gives these patients shorter survival, also the less frequent induction mortality, and allows some patients to be later candidate for allogeneic stem cell transplantation. But this is the situation in our country for for treatment of unfit patients. Professor Nada Sulojic talk about that, but I want to stress that the last two drugs, azacitidine and venetoclax, can be applied, but under the certain regulation. Now I would like to show you one mini pilot study that we made last year. We comparison the characteristic and also overall survival and the induction mortality, especially in the group of two group of patients. First, older than 60 years, and then in AML patients, younger than 60 patients. And as we expected, the percentage of adverse or intermediate cytogenetics findings significantly was in the percent is high in the group of older patients compared with younger patients. There is a type of therapy, it is the standard type of therapy. We have only few patients treated with new agent. Induction death was significantly higher in the first group. As you see, older than 60, 39 comparison to 10% induction mortality for younger patient. And this chart showed the median survival of patients in this study. That is significantly shorter survival in the group elderly than 60 years. As I said, those patients was treated with maybe old therapy, not innovation therapy, but we try to do that in the future. Finally, we also made some pharmacoeconomic testing, compared the financial cost of induction therapy 2+5, including usage of transfusion, antimicrobial drug, and so on, and also at the other side, the cost of azacitidine. And as you can see, the cost is significantly lower in the group with the azacitidine due to less use of transfusion and antimicrobial. I would like to conclude with one very famous meta-analysis that concluded, said that any therapy is better than no therapy, even if the goal is prolongation of the life. It is the goal, okay, even in older, less fit patients cohort. And also that the fact that the principal cause of death in this population, even in older, is disease, AML, rather than treatment-related mortality and non-cancer mortality. Thank you for your attention.
Thank you very much for your presentation, and we are going now to the last presentation of this session, and I invite Professor Cili from Albania to discuss about quizartinib in newly diagnosed AML patients.
Ladies and gentlemen, dear EHA members, dear hematological presidents, and dear colleagues, I just want to thank you for having me here today. On July 20th of 2023, quizartinib was approved by Food and Drug Administration for the treatment of AML FLT3 positive patients. And of course, that was approved only if the FLT3 mutation was tested by an FDA-approved test. I have nothing to disclose. When we were little, at nighttime, all our grandmas and parents had time to tell us fairy tales, and that's what I have called the discovery of the FLT3 mutation in the early 1990s, a little fairy tale, which was a very nice discovery to change the, of course, the prognosis of FLT3 mutation AML patients. FLT3 mutation is positive in about 1/3 of patients with acute myeloid leukemia, and these patients had more relapse of refractory disease and poor response to salvage therapy and a shorter overall survival than those with FLT3 wild-type disease. And then we came to the discovery of FLT3 inhibitors. I want to mention midostaurin, and I want to mention glitarinib, approved for FLT3 AML patients based on their potency and specificity of FLT3 inhibition. There has been a lot of progress and a lot of course, a lot of nice things done on the overall survival of patients with acute myeloid leukemia. We can see that in early 1970s, we had a 5-year survival of only 13%. And if we come to 2010, we had an overall survival of 55%. Quizartinib is a small molecule with its principal active called AC886, and it does bind to the ATP tandem, and it did show anti-leukemic properties in mouses that were induced acute leukemia by activating FLT3 mutation. Quantum First is a randomized double-blind placebo-controlled phase 3 trial, which made possible the approval of quizartinib in these patients. So between September 27, 2016 and August 14, 2019, there were 3,468 patients with AML and 539 patients. From them, 293 were male patients and 245 female patients, which tested positive for FLT3 ITT mutation. And they were randomly assigned to quizartinib group a total number of 268 and placebo group a total number of 271. So the recommended quizartinib dosage during induction was 35.4 milligram orally once daily on days 8 to 21 with a historical protocol of 7.3, and on days 1 to 7 plus daunorubicin 60 milligram per square meter on days 1 to 3, and on days 8 to 21 or 6 to 19 of an optional second induction 7 plus 3 or 5 plus 2 respectively. The recommended quizartinib dosage in consolidation and maintenance during consolidation was 35.4 milligram orally once daily, and during maintenance was 26.5 milligram orally once daily. Quizartinib did prove quite significant overall survival, and there was a primary outcome of 31.9 months versus 15.1 months in the placebo group. This is a phase 2 trial where quizartinib was used as a monotherapy in patients with relapsed or refractory acute myeloid leukemia. And quizartinib was introduced as a monotherapy versus salvage chemotherapy in relapsed or refractory FLT3 acute myeloid leukemia patients. And it did show an overall survival superior to salvage chemotherapy, and of course a very not very significant side effects. We should be very careful with QT prolongations with quizartinib. We should, of course, measure the QTc with an ECG. We should only introduce the quizartinib if the QT is only 450 milliseconds or less. And we should be very careful with other medications that do prolong QTc. And of course, we should monitor the patients with ECG. During induction therapy, we should do that weekly. And during maintenance therapy, we should do that weekly for the first month. And then we should do it monthly for during maintenance. And of course, we should be very careful with electrolytes imbalance. We should be careful, of course, with strong CYP3A inhibitors. Let's say we have the patient on a modified dosage of 7 milligram once daily, and we do have to introduce the patient to a strong CYP. We should definitely stop the quizartinib, and then we should restart it or reintroduce it to the patient at the same dosage only after 5 half-lives have passed after stopping the strong CYP3A inhibitor. As far as hematological side effects, we had neutropenia and thrombocytopenia. The dosage was only lowered in 19% of the patients, and the dosage, the quizartinib was stopped in 34% of the patients. These are some of the other side effects during quizartinib after LOH-CT. And I have to contradict my first slide. The FLT3 ITD does not predict inferior prognosis nowadays in acute myeloid leukemia patients aged 60 years or older. And that does show the very important FLT3 inhibitors introduced to acute myeloid leukemia patients. In conclusion, we should consider quizartinib as a standard of care, and the addition of quizartinib to standard chemotherapy with or without LOH-CT, followed by continuation monotherapy for up to 3 years, resulted in improved overall survival in adult patients aged between 18 and 75 years old with FLT3 ITD positive newly diagnosed acute myeloid leukemia. Hvala, thank you, faleminderit show. It was a pleasure.
Thank you. Thank you to all speakers. And the opening discussions, we have about 5 to 10 minutes for several questions. Please, colleague from Greece.
Thank you very much. I would like to ask you, usually when we send NGS mutation analysis, then I get back a result. And if I see to the small details, because in the details usually is the devil, as I say, you see that they say that this mutation is pathogenic, but sometimes they say to us that this mutation is likely pathogenic. So I'm really wondering if you have an answer like that you have a mutation that is likely pathogenic, do you consider this mutation as, do you stratify patients into risk group according to this answer?
I guess this is for me. So first of all, I mean, I would strongly recommend that we stick to the genes for mutation screening by NGS that are recommended by ELN. And if you really end up with mutation screening result where you do not really have a clear pathogenic significance, then we do not, I mean, we have different tiers. I don't know which system you are using for the pathogenic significance, but if the pathogenic significance is not really clear and defined by a high or higher tier, then we do not report this as a pathogenic mutation.
So what if you have tier 2, do you consider is that pathogenic? Because I mean that, for example, they give me a result for A6L1 or for I don't know for RUNX1, and the answer is okay. You have a mutation there, but this mutation is likely pathogenic. Then what I have to do?
Yeah, I mean, then in this case is where it's not clear from your own data pipeline, from your own results that you get. I mean, then you have to go back to the biostatisticians or to the group of people, and you have to go back into the literature and into the databases and have a look if there is more data available. I think these are really rare cases, and we do know that some of these genes, like ASXL1, they are full of SNPs. We know that. So I think if you have a result that is unclear and that is not by your pipeline, and you should know what type of databases are used for the interpretation of the data. If this is not sufficient, then you really have to go back to other databases and have a look if this is a SNP and how big is the probability that there is a significance or not. But normally for the mutations that we have seen or that are categorized in the ELN, we have the hotspots, and they have a clear high pathogenic significance. Maybe we can ask our colleague from the NGS field.
We report only pathogenic and likely pathogenic variants. We don't report variant of unknown significance. And we use different bioinformatic tools for to see if these mutations are present in acute leukemias, and we always try to see if the VAF variant percentage is likely with blasts, and we always want to know what is this patient diagnosis, what is the other reports laboratory, and we discuss it with our clinicians on these meetings. So it's easier then to conclude what is the result of our diagnostics.
Yeah, I mean, this is a developing field. I mean, it could happen that we, in 1 year, that we interpret the results different for several of these gene mutations. But I think very important is that you know with which types of databases your pipeline is working, and that you can interpret the results.
And you have the report, and on the report there must be said what kind of bioanalytic tools you're using for analysis. So if you know that, you must be certain that these mutations that are on the report are very important and they are connected with that disease.
Okay, is there any more questions? I have a question, one concerning two issues raising in several ELN meetings annually in group for diagnostics. That means comparison between MRD on immunophenotyping and MRT on genetic scale. Not all countries and not all groups, even in Europe, do have access to genetic MRD testing. We know that in the last 6 or 7 years, CLN groups forced flow cytometry evaluation of MRD as a basic and easy accessible clinical tool. What is your opinion? Or should we recently will go to genetics, or the genetics will be second level in case of patients with positive immunophenotyping MRD, because immunophenotyping is much cheaper, much easier for the patients with quite good sensitivity, 10 to 3, 10 to 4.
I mean, this is a really very important question, and we are discussing this within the ELN MRD working group all the time. And here we have a flow group, and we have the molecular people doing MRD. And as you said, I mean, in many labs, flow MRD is well established, mainly in US. They're using MRD by flow for AML monitoring. It's not so frequently established in some of the European countries. I personally think this is a technically demanding assay, but if it's established, if it's working, if you may have the opportunity to do cross-validation, then I think it's really a helpful tool. And the HOVON group, they are using flow-based MRD for many, many years, and I think they have included it already in their studies, and they have really nicely shown the prognostic relevance of flow MRD, even with a lower sensitivity. 0.1% is often enough. And my experience with NGS-based MRD is we are not there yet, because we have to define the markers that we would like to monitor. We do not know if all of the markers, all of the mutations that we do see are really usable for as a molecular MRD marker. We have this clonal hematopoiesis issue, and it's really important that you interpret the results right. I mean, we had this discussion before. And I'm not sure if we really do need this high sensitivity that we can reach with NGS, because sometimes you find something which is not really relevant for the relapse. It's there at a very low level, but we also have a kind of immunoreaction. We have many effects that have an influence on residual cells. And we also have, if you go deep enough in healthy people, we do find some of these molecular markers.
Situation with CML.
Yeah, no, I think flow MRD has been well established. It's technically demanding, but if it's established in your lab, I think it's a very elegant tool. And Peter Falk, in his first NGS-based MRD analysis in AML, he had a comparison with flow MRD. And I mean that the results were really very nice and very synergistic. And there are only a few cases where you have flow MRD positivity and NGS MRD negativity and vice versa. So for me, it was a very elegant study to show that you can use the one or the other technique, and they recommend to have both, but I think we are not there yet to do everything.
Thank you. Any other questions? Dr. Pantic from Belgrade.
Good morning. And for intermediate risk group, do we have any other marker for bone marrow transplantation besides the MRD after second therapy? Because if you wait for the end of the second therapy, it might be time consuming for the patient.
So you mean any other marker than the FLT3 ITD?
Any other marker which will tell us this patient is candidate for bone marrow transplantation?
From the intermediate risk group?
Yes.
I mean, in the intermediate risk group, you have seen this is characterized by the FLT3 ITD. I mean, this is our marker for decision making if this patient should receive an allogeneic stem cell transplantation. I think for the others, it's based on the categorization, very clear. Adverse is,
Yes.
in most of the cases, the indication. But we also should take into account, and this is also true for the favorable risk group, MRD. So that means if you have a patient who is categorized in the favorable risk group, but you do see MRD or kinetics that are not really showing that the patient is responding, then I think you should take into account MRD for the indication for allogeneic stem cell transplantation too.
Thank you.
Thank you. Anyone?
May I ask a question to Anna?
Yes.
Is this possible? Yeah. So Anna, when ASA has been shown based on the data from the VRLA study and from many other studies, this is our new standard of treatment in the elderly unfit patients. I must say, I do have a certain problem saying that this is a less intensive therapy. Yes. In my experience, the combination of the two drugs is quite toxic, hematotoxic. And I would like to ask you, what type of schedule are you using when you treat patients with this combination therapy? Are you giving the full dose of venetoclax over the whole time, or do you have any experience in those?
With the combination,
Yeah.
ASA plus Ven.
Yeah.
Actually we treat only one patient, Professor Milena Todorovic, patients young that she relapsed after second transplantation. It is the first, and we only planned just now to start to treat one patient with this combination, Vene plus ESA, who is 75-year old, but he's in very good condition, and we will try. And also we have one study, I mentioned you last day, in the second remission. But we don't have, but I know that the venetoclax also in the other disease such as HLL is also, you must be precautioned when you treat the patient, but it's a we will see. And I have one for you, a very short for everyday practice question. What's your personal opinion about the use of growth factors, for instance, GCFG, especially in the induction of AML patients? Because we are very agree in our institute about the usage of this in the induction, especially in induction of AML, where we expected where we expected the rate of febrile neutropenia, we know about 20%, and it is very high.
So did I get you right, Anna? You are applying these growth factors to your patients, or you are reluctant?
It is different in one department I use. I will be honest, but there are departments from NADA that they didn't use in the induction. But we wait about, in my department, we wait about 15 days from the start of therapy, induction therapy, when patient into the deep aplasia, then we use. And what's your personal opinion? I'm very curious to know.
So we are doing it more or less exactly like you are doing that. So we were very reluctant for a long time to give these growth factors during the early induction therapy, but with the data that have been generated, and in particular with these new combinations in intensive treatment, we do see these long phases of neutropenia. And we are now also in our clinical trials allowing or recommending to give growth factors from the very beginning on, from the first cycle of induction therapy.
Thank you very much.
When the patients are neutropenic.
Immediately after chemotherapy, or you are waiting for 2 weeks and then start, or do you using only as a secondary prophylaxis in the patients where we have some very febrile neutropenic episodes before that?
You mean for the growth factors?
Yeah.
We are waiting. We are waiting for the patients and look at the recovery of the blood counts. And when we see that, that there is a prolonged recovery, then we start with the growth factors. Yeah.
Or the patient is doing bad with infections or something, high fever,
Yeah.
then you're starting.
Yeah, yeah. No, it's not in all of them. It's really we are mainly focusing on the neutropenic phase. So if they get fever, they have their antibiotic and antimycotic prophylaxis anyway. I think that the infection is at a later state point, maybe a later time point, maybe an argument for giving growth factors, but normally we start earlier if they are showing this prolonged regeneration.
Please, yes.
Just a quick question. So most of the funding bodies that reimburse us for drugs for AML, such as venetoclax, are still insisting on 20% plus or greater for the definition of AML, yet the definition is now changed to 10 to 19%. And I'm just wondering what your thoughts are on sort of on how we should be either canvassing these funding bodies to extend the licenses down to the 10% mark, or and really what evidence there is for drugs such as venetoclax or azacitidine in that category of 10 to 19% blasts.
Yeah, so I think I have no experience with the reimbursement now within the context of the new ICC. So I do not have seen any problem with our patients that we are designated now as MDS AML, and that somebody is looking at the blast count and saying, okay, we are not reimbursing, there's no reimbursement for the patient. Maybe this is becoming an issue. Maybe we have to discuss this with the regulators. Yeah, I mean, that's a good question. I mean, this is unsolved and is not adapted to the new classification if you use the ICC.
It's a question for IHA. I think because some countries have a very rigid systems like we do, like Britain as well, and we are using registration trials which had been performed under the different classification systems and under different positions. So we have a problem with even the drugs for MDS because they are defined under IPSS, not IPSS revised, and we still have another molecular markers for that. And the problem is labeling of the drugs. We have the problem with the labeling of the drugs because our agency and our regulators are very strict to those things written in SMPCs, in registration. Very similar to England, but they have some kind of bypass of a process through the NHS. We are trying to do that also with our health insurance system, but it's sometimes a problem, and that might be an issue for IHA for some proposal and for some kind of recommendations. We may rely in some discussions. That's a general policy in Europe. Nevertheless, the country or the budgeting system or something.
I mean, I think that the recommendations, whatever kind of recommendation you are using, that's what I've heard from the different national societies. They play an important role, and that they are often accepted, or that they are more accepted by the regulators. So if something is really in a written recommendation that is highly accepted by the community, this might help. But I think it's so complex, and with the novel drugs and with these two classification systems, I think it is really difficult to find a common definition and a common agreement with these regulatory people to find
not only regulatory but also the financial people
and also financial people. Yeah, for sure.
Yeah. Okay.
But I got the message.
Yes. Yes. Okay. Thank you very much to all speakers, all discussions, and I announce pause. 15 minutes, please. 10:45. 10 minutes, sorry.
Good afternoon. Dear colleagues, thank you for your interest for this session. I would like to, respectively, I have an honor to announce the first speaker of this session, Professor Brian Hinckley. Namely, Professor Brian Hinckley is a clinical research scientist who combines running a laboratory group with his practice as a consultant hematologist in Addenbrooke's Hospital. He's also head of the Department of Hematology at the University of Cambridge International. He is a member of European Hematology Association Executive Board and Research Committee and chair of their Fellowship and Grant Committee. Professor Hinckley, I would like to invite you to present your State of Art lecture.
Thank you very much. I'd first like to thank the organizers, so the Serbian Society, the Balkan Societies and EHA, for giving me the chance to present today. This is my first visit to Belgrade and to Serbia, and I'm greatly enjoying it. I really enjoyed the first session. So I'm going to talk today about the therapy of AML, and I've picked out a couple of areas that I want to stress because it's a relatively short talk, and that is an area of burgeoning activity. So I have no relevant conflicts of interest. So just as an overview to my talk, I'm going to give you a little bit of a background, and you're all aware of this, about acute myeloid leukemia in terms of its complexity, but I don't want to be negative about that. I also want to talk about our growing understanding and the promise of new therapies, and then we'll talk about current considerations for AML therapy. I'm going to try and boil that down into relatively simplistic ideas, and talk about three things. Talk about genotype-dependent de-escalation for induction. Talk about one novel therapy, of which there are many, to talk about menin inhibitors, and then to talk about an area of growing interest in the maintenance therapy in acute myeloid leukemia, particularly relation to hypomethylating agents and FLT3 inhibitors. And the speakers in the first session did an excellent job of introducing many of the things that I'm going to discuss in my talk today. So acute myeloid leukemia, as you're aware, is transformation along the myeloid lineage, and it's characterized almost uniformly in every aspect of its biology by heterogeneity. So it's very much more than a single disease. The level of transformation is different. There are a number of transforming events that occur along a continuum, as we've discussed. And in individual tumors, there's significant intratumoral heterogeneity, and between tumors, there's significant intertumor heterogeneity. These in part explain its low survival rates. And up until recently, we had a situation where our therapies had changed very little. If we look at some of the things that have happened over the last couple of decades, we had a very nice session just now talking about its clinical heterogeneity and trying to encompass its genetic complexity between tumors at diagnosis, but also in terms of its heterogeneity of response with things like measurable residual disease. But we're better understanding this disease, and the improvements in the understanding of the biology have really been massive across the last couple of decades. This is just a cartoon slide from a very good review from Hartmut Döhner, Andrew Way, and Bob Lowenberg, just detailing the discovery of so many different and new targets within acute myeloid leukemia. Some of these are completely agnostic of mutational state, so they will target perhaps every AML, surface molecules, processes such as apoptosis, and some are linked to mutational genotype. And that gives us the chance to target across AML, to target specific genotypes, and that is coming into the clinical trials and some of the combinations that you heard this morning. And also, many of these agents are becoming available. So I first became a hematologist in the 90s, and really, for the first 20 or so years of my practice, we didn't really change. It was still 7 and 3 plus sort of add-ons. This is a very nice slide from Zayden and colleagues earlier this year in Blood, and it sort of details the timelines of acute myeloid leukemia. You can see in orange the first 40 years, where we'd only had 2 drugs that were licensed in acute myeloid leukemia, and for gemtuzumab ozogamicin, that was actually withdrawn. However, within the last 6 years or so, there have been massive inroads in terms of our understanding and the regulation of new agents, such that gemtuzumab, various FLT3 inhibitors, various IDH inhibitors, glasdegib, combinations of ven plus either hypomethylating agents or low-dose Ara-C have become commonplace. And we heard about some of these this morning. So we've got a lot more than 7 and 3 now. And you could say that being spoilt for choice actually provides itself as a problem, because we now have to work out how we're going to use these dizzying array of therapeutics. So this is a slide that I borrowed from a colleague, Pramila Krishnamurthy from King's in the UK. And this is a sort of cartoon, and it's only there to demonstrate one thing, which is that treating AML is complex. This is our current sort of pathway choice within the UK. And you've got to remember that in the UK, we have access to a great deal of these medications, which I'm deeply grateful. But we don't have frontline access to IDH inhibitors, to menin inhibitors. We can only use one FLT3 inhibitor up front. So it is complicated, and therefore I've decided to sort of simplify things just to get my points across. So this morning's session excellently showed us about how important it is to use the knowledge that we have from AML patients to optimize their therapy. So I've put down a kind of simplified disease workup in newly diagnosed patients. We've talked about these disease characteristics, so primary or secondary treatment related, white cell count, age, the genetic sort of characteristics in terms of cytogenetics, next generation sequencing, fusion transcripts, etc. And these will then allow us to put together their risk stratification. That's got to be taken in the context of the whole patient. So we then need to think about their age, comorbidity scores, and that, along with the availability of trial entry, and I'm a great believer in entering patients in clinical trials, will give us an idea about what would be optimal for that patient. And we need to try and turn that around quite quickly. But after that, treatment is really simple. It's 3 phases. So it's induction, and we've talked about sort of 7 and 3. We've talked about some of the more sort of higher intensity induction therapies with CPX, or in the UK, we still use quite a lot of FLAG-IDA. And we've talked about the major inroads that have been made in elderly and unfit patients with venetoclax regimes combined with either hypomethylating agents or low-dose Ara-C. On that, we've been beginning to layer further targeted therapies. We heard a bit this morning about FLT3 inhibitors. I've mentioned gemtuzumab, and there are other novel agents that are becoming au fait in terms of IDH inhibitors, etc. We then move into the consolidation phase, and that would be determined by a number of things, including the risk stratification, the age and the comorbidity score of the patient, and also the availability of a donor, but broadly can be broken down into the delivery of further consolidation chemotherapy if they're not eligible or not suitable in terms of their risk stratification for an allo stem cell transplantation or allo stem cell transplantation. And as we'll come to, we're now moving into maintenance. You heard 1 or 2 things that suggested that maintenance is becoming more accepted in acute myeloid leukemia. And the 3 areas I'd like to talk about in the remainder of my talk relate to induction. So basically to trying to choose the least toxic induction therapy on the basis of genotype. So I'll be talking about venetoclax-related regimes in nuclear Fosman mutated disease. I'm going to give you a smattering of new targeted agents, and I'm going to talk about the menin inhibitors, of which I'm very excited about. And I'm going to talk to you about maintenance as well. Maintenance makes a huge amount of sense in AML. It's something that has a long history, but I think nowadays, now that we've got this biological understanding, this array of agents, it really should be coming to the fore. So let's start with trying to de-escalate a nuclear phosmin-mediated disease. Now, why is that the case? This is some slides that I got from Richard Dillon, and these are looking at the general CR and CRI rates with venetoclax-related regimes, either low-dose RSC, AZA, or other hypomethylating agents across 4 of the largest studies. And you can see here the results are very good in terms of the CR/CRI, and particularly in line of the fact that these patients are generally, in these studies, are generally very elderly. However, if you look at the second line, and we just limit that to nuclear phosmin mutated patients, you can see that they really are exceptional. And these are CR rates that any AML trialist would want to have for their upfront induction. If we look at whether median overall survival has been reached with the follow-ups of these studies, which are reasonable, again, the median overall survival has not been reached. And the Kaplan-Meier at the bottom there is just to show that these responses can be durable. You can see there for the wild types in green that there's the usual attrition rate that we associate with acute myeloid leukemia, but for nuclear phosmin in blue and for the IDH2 mutant, these are actually exceptionally good rates, and they appear to be durable. So that has started us to, in the UK, to look at comparing them with real-world data. Trial data, I think you have to be somewhat, not dubious about, but you have to say that it's the best possible. So what we've got here are, on the left-hand side, this is a comparison between our UK AML 17 study for patients that will be eligible for the Victor study that I'll talk about. And that's basically nuclear phosmin mutated FLT3 wild type. If you compare that to the real-world data from the UK on venetoclax comparing regimes, you'll see that they are really very, very similar. And I'd also point out that the median age of the real-world data is actually older, suggesting that venetoclax regimes do work very well here. This is comparing it to AML 19 and to either DA with gemtuzumab ozogamicin or to FLAG-IDA with gemtuzumab ozogamicin. And again, we're seeing a very similar kind of response rate. So that's led to us developing the Victor study, and I should give Richard Dillon all of the kudos for that and thank him for his slides. And that's currently ongoing in the UK, looking at patients who are over 55, who are fit for intensive therapy. As Connie mentioned, these are not regimes that are low intensity by any stretch of the imagination. Nuclear phosmin mutated, but importantly, FLT3 ITD negative, and that can be either on locally or centralized rapid screening. As you can see here, this is a one-to-one randomization on those characteristics, comparing then, and in this case, low-dose RSE against what our standard would be in this mutational genotype of DA-GO and consolidated with DA and then HiDAC. It allows for the ability to, on the basis of strong molecular monitoring, to default to a FLAG-IDA based regime thereafter. So the primary endpoints are molecular event-free survival, and it's designed as non-inferiority. But I think this is a potentially interesting area, and it may be that we can de-escalate some specific genotypes that are of relatively low risk upfront. This is not just an idea that the UK has. This is a similar study. I think Vincent must be Victor's little brother. And this is from the German Study Alliance group and the AML consortium group. So it's similar, actually younger patients, again, a randomization to standard of care, comparing that with FEN and AZA. And again, they have similar molecular monitoring and the ability to transfer to regimes for patients where it's obviously not working at the molecular level. So the second area that I'd like to comment on is just on this area of new targeted therapies. And this would be with a view to developing these therapies that could be slotted into combinations at the very much at the induction setting. To use the analogy with FLT3 inhibitors, for example. So I'm going to talk a little bit about menin inhibitors and the excitement that's occurring around these. So menin is an adapter protein, a chromatin adapter protein, and it tethers the MLL, the normal MLL complex, to this LEGF protein, which binds to actively transcribing genes. It also does this for the MLL fusion protein and its attendant protein complex members, which causes aberrant transcription of leukemia-associated genes and keeps them switched on. So this is pertinent to, obviously, MLL-rearranged leukemias, but it's also been proven that this is a process that is ongoing in nuclear Fosman-mutated cases, and importantly, in these very horrible NUC98 rearrangements as well. So it covers a reasonable number of AML genotypes, some of which have a poor prognosis. So the inhibitors were initially developed by Yolanda Grumbecker in Michigan, and they have been developed by a number of companies since then. They cause an inhibition of a protein-protein interaction. And again, I think this is a nice paradigm because there's a number of protein-protein interactions that we would like to inhibit. So this basically drags the MLL complex off of these genes and for the leukemia-specific ones, switches them off, as I'll show you. And there are a number of drug companies that have molecules in this space. SDNX 5613, better known as revumenib, that should be revumenib, KO539, ziftomenib, and there are others also. So let me give a little flavor of some of the data as recently published and presented. So for the revumenib, this is a study from predominantly Memorial Sloan Kettering. This is the Augment 101 study, relapsed refractory AML. Didn't start off as being all MLL and nuclear Fosman, but the majority that were recruited thereafter were. So 90% of the patients have what we would determine would be sensitive genotypes. It's a relatively small study, and it's a phase 1 study. 68 patients, adults and children, but the adults were a median age of 50.5. So the first thing to say is it was well tolerated, and there were the fairly common side effects, QTc prolongation and GI upset. Of interest and sort of speaking to the way that it works, differentiation syndrome was seen in 20% of patients. And if we look at what they actually did, looking at transcriptionally, you could see that there was a reduction in leukemia transcripts as evidenced by the MICE1, an upregulation of transcripts that would be associated with differentiation, which would go along with the differentiation syndrome that was seen, and a significant reduction in the blast count. In the waterfall plot, you can see that this was effective. The triangles and the diamonds suggest either CR or CRI, but the red crosses show that it was not necessarily durable. And if we summarize that, we could see that there was an overall response of 53%. MLL always appears to be better than nuclear Fosman. Some of these 30% were CRs or CRHs. Again, MLL outperformed nuclear Fosman. And of those patients who reached complete response, the majority of them, sort of 75% plus, actually were MRD negative. You can see the Kaplan-Meier at the bottom, again, shows that it's promising, but not durable. But this was still enough to achieve it FDA breakthrough therapy designation for relapsed and refractory MLL rearranged both adults and children. This is a class activity. This is a summarization of the results that Amir Fathi showed as a late-breaking abstract at the most recent EHA Congress for ziftomenib. This is the Cura Pharmaceuticals Comet 001 style study. Again, relapsed refractory. This is an update, and I'm just showing the nuclear Fosman mutated. Again, unfortunately, the duration of response was limited, but it did allow 2 patients to be bridged to stem cell transplantation, and the side effect profile very similar, anemia, thrombocytopenia, differentiation syndrome. So the CR rate, remember this is just the nucleophosmin, very similar at 35%. The overall rate, 45%. And of those achieving a complete remission, the majority again were MRD negative. So activity, but not duration. So the most sensible thing to do is to combine this with other standard of care therapies. And I'll just highlight a couple of trials that are ongoing. So the BEAT-AML and the AUGMENT-102 trials are combining revumenib with Ven/Aza in both newly diagnosed and relapsed refractory. And there is the son of COMET-1, COMET-7, again combining ziftomenib in the same setting, either with Ven/Aza or 7 and 3. So I think this is an agent to keep an eye on and could well be plumbed back into improving primary therapies. So I want to sort of finish by talking a little bit about maintenance therapy, and I'll specifically talk about FLT3 inhibitors and hypomethylating agents, but this could really apply to any therapy. So I want to keep this conceptual, as it were. So this is really revisiting an old concept. I remember the first trial that I was involved in had a maintenance on AML trial. I can't think it was AML 9 or something like that in the UK, and it had an interferon maintenance, which was unfortunately at that time not successful, but it may well have been for any number of other reasons. So the rationale is obvious. Most patients die through relapse, so we are not controlling the disease half well enough. And measurable residual disease studies have shown the scale of disease persistence that we're aware of and the association of disease persistence with relapse. So major concern is an obvious, major relapse is an obvious concern. And this is particularly where we're not able to deploy large-scale immunotherapy with stem cell transplantation. But also, we know that patients with adverse risk don't do as well as we would like with stem cell transplantation, so it's possible to give further therapy in that setting as well. And we have the paradigm of other hematological malignancies. We'll hear today about acute lymphoblastic leukemia, where it's really been a mainstay of therapy, and there's lenalidomide and myeloma, etc., etc. So I've told you it's been previously tried without success, so what's different now? Well, a great deal. We have a large number of new target therapies that I've mentioned, but we also have a greater temporal control over the kinetics of the disease. We've got an understanding of those patients that might do better in terms of their measurable residual response, and we have targeted genetics as well. So I think that AML maintenance therapy is kind of prime time. So I mentioned that over the last 40 years, things have been tried, but I'm going to concentrate on recent studies with hypomethylating agents and FLT3. And where does the kind of evidence come from that? Well, it comes over the last 10 years, and some of it's actually been mentioned this morning already. So with regard to hypomethylating agents, in the UK's own AML 16 study in the over 60s, in those patients achieving a CR, some were given azacitidine, and this led to an increase in the 5-year overall survival, as is seen here, sort of 40% versus 13%. And retrospectively, we could see that that was only occurring in those patients who were MRD negative. And the HOVON had a similar study, greater than 60, with azacitidine maintenance, and 12 months of maintenance therapy was superior to the observation with the results as shown there. With FLT3 inhibitors, the SOAR-AML study, which randomized patients to sorafenib, including sorafenib maintenance plus IC, and this was regardless of the FLT3 status, showed an overall event-free survival advantage, although that did not read out at the overall survival advantage. And you'll all be very familiar with the RATIFY study, which combined intensive chemotherapy with midostaurin, plus or minus placebo versus midostaurin, but also had a 12-month maintenance phase, and that showed a superior event-free and overall survival. Okay, so let's talk about HMA maintenance already. The Quasar study has been mentioned in the passing. So this is oral azacitidine. This is a phase 3 randomized placebo-controlled trial of AML patients greater than 55 in first CR after induction chemotherapy, and randomized about 200 patients into each arm. They were given 300 milligrams daily for 14 days, and the median age was 68 years, and the primary endpoint was overall survival. This is a median follow-up of 42 months, and you can see from the Kaplan-Meier that there was a significant improvement in median overall survival. This is survival from randomization, and that's 24 versus 14.8 months. There was also a median improvement in relapse-free survival, and in subgroup analysis, the benefits were shown across most subgroups. And importantly, particularly in this sort of patient demographic, it was relatively well tolerated, and there was preservation of quality of life. This has been updated recently with 55 months of median follow-up. Interestingly, 25 patients are still on maintenance therapy. That's 11% of the initial cohort. And the survival estimates and the benefits of the survival estimates have been maintained at 3 and 5 years. They did some predictive analysis, and the patients who are more likely to be long-term survivors were those with intermediate ELN risk, those patients who are nucleophosmin positive, and those patients who were MRD negative at the time of randomization. Maintenance therapy, I think, is important, but it's always very dangerous to think about applying a selective pressure to disease like AML over a prolonged period of time. So specific resistance is likely to be encountered. We can anticipate that. And in an ideal world, we would want to deploy combination therapies, even in the maintenance setting. So on the basis of the fact that Veneza, although not low intensity, has been very well tolerated with multiple courses able to be delivered. A successor to the Viali studies that were described this morning, the Viali M trial, is currently being planned. This would involve dose finding to find the exact doses of venetoclax and azacitidine that can be deployed with tolerable effects in the maintenance setting, and then to randomize on a 1-by-1 basis at CR patients into either having the combination or just single azacitidine. And it's predicted online to start in 2026. Hopefully it might be a little bit sooner. Just to say that hypomethylating agents have been used post-stem cell transplantation. There was a dose escalation study, the CC486 AML-02, which established the feasibility of this. It was tolerable. Importantly, there was no increase in graft versus host disease. There was a relatively low rate of relapse by comparison with historical controls at 19 months, and the median overall survival had not been reached. And in the UK, through the IMPACT trial group, we have an ongoing study looking at this post-allogeneic stem cell transplantation, the so-called Amadeus trial. This is Charlie Craddock and his love of opera. This is a randomized phase 3 international trial for patients with AML or MDS, comparing azacitidine or placebo post-allogeneic stem cell transplantation. And initial thoughts are that it's well tolerated, no increase in GVH, and there are favorable trends for both of those and relapse. So further results are awaited. So just to finally finish up with FLT3 inhibitors and maintenance. I mentioned that the RATIFY study, this was the registration study for midostaurin, looking at its combination, either midostaurin or placebo, in combination with intensive chemotherapy. And there was an overall survival advantage seen. Now it's been suggested that the 12-month maintenance may have somewhat contributed to that, but I think it's not really, I don't think it stands up to statistical rigor. The trial was not powered to assess maintenance. If you look at the 350 patients in either arm, Only 120 versus 85 went on to midostaurin or placebo in the maintenance phase. And a post-hoc landmark analysis did not suggest any difference between those. However, later studies in either the relapse refractory setting or in the newly diagnosed setting are quite positive. So the first one I'm showing there is the Admiral study, and this is a phase 3 randomized placebo-controlled refractory comparing gilteritinib versus salvage chemotherapy with physician choice. This has shown an overall survival advantage, 9.3 versus 5.6 months, which is statistically significant. And in a longer-term follow-up, gilteritinib maintenance has been shown to preserve the overall survival advantage. At 2 years, this was 20.6% versus 14.2%. The Quantum First study, which has been mentioned by a colleague this morning, for newly diagnosed patients, also has a maintenance phase. It's shown an improved relapse-free survival and overall survival advantage, and the contribution of the maintenance arm to that will be assessed, and we're awaiting that. So what about post-allogeneic stem cell transplantation? So there's a phase 2 SORMAIN study looking at sorafenib. Again, as with many transplant trials, there are very few trials in transplant, but in a relatively small numbers of patients, 83 patients in this, randomized to sorafenib or placebo over 2 years, well tolerated, no worsening of graft versus host disease, and at 42 months it's shown improved relapse-free survival and an improved overall survival at 24 months of 90 versus 66%. However, just in the interests of fairness, the RADIUS study, which was very similarly designed for midostaurin, a smaller number of patients, 42 patients, has not shown any clear advantage. So I think that the jury's out, but the further results are awaited with maintenance, but based on the fact that we now have well-tolerated agents, and we will see further trials in combination, and we can say that maintenance therapy is viable, it's well-tolerated, and the preliminary results are promising enough in both those patients ineligible and eligible for stem cell transplantation. Okay, so I think that's just a repetition of what I said there. So, okay, so thank you very much. I'm going to finish there, and I'm very happy to take any questions that you have.
So, thank you, Professor Huntley. In the interest of time, we'll take the questions at the end of the session. So, we're rapidly moving now to the second talk on focusing the FLT3 inhibitors in acute myeloid leukemia. Please forgive me for not being able to pronounce you.
Even in Romania, it's complicated. Yeah. So thank you very much for having me today here. I will move the discussion into the clinical practice. So first of all, let me just thank the organizers. It's quite nice to be here. So a big thank you to the IHA committee for this great opportunity, and also for the colleagues here in Serbia for this kind invitation. So I have no disclosures. My presentation is going to have 2 clinical cases. It's about 2 patients that were treated in our department for FLT3-ITD AML. The first case, it's a patient that was referred to our department on October 2017. He had no major complications. The most important thing I would like to stress out is that he was diagnosed in July 2017 in some other hospital unit in Romania with FLT3-ITD AML. So during that time, FLT3 inhibitors, they weren't available in our country. So he was started on classical induction with 7+3. As it was expected, he didn't respond very well. So our colleagues from that department, they decided that given the fact that he is young, he should be treated with salvage chemotherapy. They tried to induce complete remission by salvage chemotherapy flagetoposide. They gave 2 courses of chemotherapy, but with no good results. What else is more important about this patient is that, of course, during this salvage chemotherapy, he had a lot of complications. So he had blood culture positive for Klebsiella. He also had Clostridium difficile infections. But the most important thing was that he had a fully matched sibling. So he was referred to our department on October 2017. This was his first lab test from the beginning. As you see, he had quite a normal laboratory test. Of course, we performed a bone marrow aspirate, which revealed a morphology with 70% blast infiltration. He was tested by flow cytometry, which revealed myeloblast and monoblast. We tried to perform cytogenetics, but he had no metaphases, and he was positive on molecular biology for FLT3-ITD and negative for all the rest gene fusions and MLL rearrangements. During that period, so as I was saying, we didn't have available FLT3 inhibitors in 2017 in Romania, but we knew that results are better and patients have better chance to achieve CR when adding a FLT3 inhibitors. So the family of the patient and also the patient associations in Romania, they decided that they are going to have the patient with this drug. So the treatment decided was cytarabine, idarubicin, and sorafenib. So he was started on treatment on 27th October. He had a lot of complication after the all salvage chemotherapy that he received before. So he had mucositis, he had a prolonged aplasia, he had a febrile neutropenia, and he needed a lot of antibiotics and antifungal. After 40 days, he was discharged from our department. And 7 days later, we performed the bone marrow aspiration, the first assessment. It was the first time when he had almost 5% myeloblast in his bone marrow aspirate, and the molecular biology for FLT3-ITD was negative. So he stayed on sorafenib, and he was admitted to the department of bone marrow department for the procedure in January 2018. After that, I have to say that he stayed on sorafenib for 24 months, and that he was the last seen in our department in December 2022, when he was in good clinical shape and he had a chimerism 100% donor. So coming back to our days, this is a patient that it was diagnosed in December 2022 in our department. He had 20% blast in her peripheral blood. The first checkout of the bone marrow aspirate revealed blast. They were all myeloblasts, so they had myeloperoxidase positive with CD34 positive and CD13, CD32. On cytogenetics, we saw that it has 16 cells with normal karyotype and that the patient was positive for FLT3-ITD. Nowadays, we have approved in Romania FLT3 inhibitors, first generation for the patients in induction. So the patient was started on 7+3 and midostaurin. The decision was made that once she will achieve complete remission, she will be admitted to the bone marrow transplant department. This is the results after the first course of induction. So she had complication during this aplasia. She needed a thoracic CT scan because we had the suspicion of pulmonary aspergillosis. She also had blood culture positive for Candida glabrata, and she was started on antifungal, on caspofungin. She performed also bronchoscopy. This was made still after she recovered the platelets. So our colleagues from the pneumology performed the bronchoscopy, but I have to say that the patient was still on treatment with antifungal. So the results came negative for pulmonary aspergillosis and also undetectable for Mycobacterium tuberculosis. This was the first assessment after the first course of induction. So the patient had 3-4 morphological blasts in her bone marrow aspirate, and the flow cytometry revealed a minimal detectable residual disease. We have discussions in our department, so we have a lot of meetings to discuss these patients, and the decision was made to continue on midostaurin for another course of consolidation. So she had intermediate dose of cytarabine plus midostaurin. She had a febrile neutropenia. She needed antibiotics and voriconazole, but otherwise the aplasia evolved very well. This is her second assessment after the first course of consolidation. So he had 7% blast infiltration. He had a minimal detectable disease at 1.5%, and also she had a molecular biology which was positive for free TITD. So everyone agreed that this lady has an AML refractory ITD, and that it's better to switch the FLT3 inhibitor and to continue on gilteritinib. This is her last assessment before the bone marrow transplant, which was in September. So in August, after the treatment with gilteritinib, the patient had 4 or 5 blasts in her bone marrow aspiration. She had a detectable MRD tested by flow, 0.2%, and she had a FLT3 positive. Day 0 for the patient was 27th September, when she had the procedure. And I have to say that when she will recover from this aplasia, she will be recontinued on gilteritinib, and we hope that the detectable MRD will maybe disappear after the bone marrow transplant. And with this, I would like to thank you.
Our third presenter for today, relapse refractory AML patient, therapeutic options, Sasha Doma, hematologist from Clinical Center Ljubljana.
Good morning, everybody. First, I would like to thank the organizers for inviting me. I'm very happy to be again in this friendly city of Belgrade. So my talk will be about this challenging topic of relapsed refractory AML, and also I'll show some of our experiences with those patients. Despite evolving efforts in the diagnostic field and targeted therapies, a relapse of AML is still a very common scenario. About 40 to 50% of younger and the majority of older patients relapse, and the 5-year overall survival is only around 10%. On the other hand, around 20% of patients demonstrate primary induction failure. So for those patients, the only curative option is allogeneic hematopoietic stem cell transplantation, but that requires a matched donor and is associated with the risk of severe GVHD and infectious complications. In the era of novel agents, we are coming to other treatment strategies, but so far nothing is really established. Well, classical prognostic factors of relapse are the duration of first CR. So if there's a short time from the first diagnosis from the relapse, that's bad. Also higher age, unfavorable cytogenetics, certain molecular features such as FLT3, a history of prior hematopoietic stem cells transplantation, and also the fitness of the patient, whether they're fit for maybe another allogeneic hematopoietic stem cell transplantation. So at the relapse, we should repeat the mutational screening and cytogenetic analysis because there is a high likelihood of clonal evolution, and we can find some mutations which offer novel therapeutic options. Of course, we must do the HLA typing and search for a donor. And we must also take into account the age and comorbidities of the patients, previous toxicities that the patient was exposed to, and also we must decide whether the patient can be intensively treated with the aim of subsequent transplantation, or maybe he's not a good candidate for that. So for fit patients without prior transplant, we do the salvage therapy with the aim to maintain cytological remission. So this salvage therapy is a bridge to transplant. Different regimens show similar results, but important components of the salvage therapy is a combination of anthracycline, high-dose cytarabine, possibly purine analog or etoposide. And we must keep in mind that this salvage therapy-induced remission is usually shortly sustained, so allogeneic transplantation should be performed quickly. For patients who relapse after hematopoietic stem cell transplantation, the outlook is even more dismal, especially if they are relapsing soon after the previous transplant. These are our experiences. In our center in Ljubljana, we use salvage therapy, Flakida, which is generally widely used salvage chemotherapy, in which around 50% of relapse refractory patients achieve a CR. So these are data from an 11-year period. A bit more than 100 patients are included in this analysis, with a median age of 60 years. You can see that some patients were also very old in this analysis. But the complete remission and complete remission with incomplete hematologic recovery was quite high, 70%. However, the median survival was less than 10 months. The survival was much better in patients who were younger than 60 years and much, much better in those who were transplanted more than 5 years. For unfit patients, the approved therapeutic options are very limited, and we must aim to prolong the patient's life with acceptable quality of life. While some patients are fit for intensive chemotherapy, the others can maybe only be for symptomatic therapy and transfusions. Venetoclax has changed the paradigm of treatment of older patients with the first occurrence of AML, but there are also good results in the relapsed refractory setting. And some patients on this regimen could also be bridged to allogeneic hematopoietic stem cell transplantation. On the other hand, venetoclax is also incorporated in more intensive regimens, which is even more successful. And these are our data of 23 patients, older patients of a median age of 69 years, who were treated with this combination as second-line therapy. Around 60% of patients responded. The median, they got 6 cycles of therapy, and the median survival is 12.8 months. We also have, for FLT3 positive AML, we also have the possibility to treat patients with gilteritinib, which was approved by Admiral trial. This trial showed that monotherapy with gilteritinib was better than salvage chemotherapy, but in this salvage chemotherapy group there were different patients. Some of them were treated intensively, the others not intensively. However, the response was twice as better in the gilteritinib arm. And best results were also shown for patients who were later transplanted. In Ljubljana, we had 10 patients who were treated with gilteritinib. I must say that our data are not so good. The median age of those patients was 64.5 years, and the overall response, 6 out of 10 patients responded. However, only one of those patients was transplanted, and the median survival only 3.8 months. As I showed previously, younger patients were treated intensively with Flakida and transplanted later. And now we will also have the possibility to use IDH1 and IDH2 inhibitors, which are not available in Slovenia. The good thing is that these are oral drugs and have shown promising results, especially in the relapsed refractory setting. So this is the algorithm we more or less follow. And I will conclude here. that future for relapse refractory patients is not really bright, but is getting better. It seems that we will still need allogeneic hematopoietic stem cell transplantation to cure those patients, but with advent of novel drugs and better mutational screening and better options for MRD, we will surely make survival of these patients better. That's all. This is our medical center.
Thank you. Now we move to the fourth talk on acute leukemia M3 after liver transplantation. Dr. Aliona.
Good morning. Thank you for the opportunity to be here. It's very beautiful in Belgrade. I would like to present a clinical case, and although we didn't obtain therapeutical success in the treatment of this patient, I think this case is important because acute leukemia in a post-liver transplant patient is a rare entity. So it's a male patient, 34 years old, that underwent orthotopic liver transplant for cirrhosis with hepatitis B. Immunosuppression was induced with mycophenolate mofetil and methylprednisolone. 15 months post-transplant, the patient developed chronic rejection of the liver graft, confirmed by liver biopsy. Stenting of the anastomosis of the main bile ducts and plastic choledochal anastomosis was performed, followed by a portal vein thrombosis. 24 months after the transplant, patient observed progressive weakness, weight loss, and abdominal discomfort. Also, there appeared a tendency for leukopenia. The leukocyte count dropped gradually, reaching 0.9 thousandths of leukocytes, so the immunosuppressives were cancelled. The leukocyte count started to increase, but the patient developed anemia and thrombocytopenia and was directed to our department. When the patient presented during the physical examination, we have noted petechia and ecchymosis all over the body surface, also jaundice and ascites. In the CBC was as follows: hemoglobin 80 grams per liter, platelets 5,000 and leukocytes 9,000 with 58% of the blood cells. So in the blood film, there were noted large with abundant basophilic non-granular cytoplasm blasts. And these blasts were without any granulation, only in some of them were noted small, fine dust looking like granules. And the nucleus of the sum of the blood cells was folded or bilobed. Bone marrow aspiration showed a hypercellular bone marrow with a 72% of blood cells. The megakaryocytes were normal, while platelets were decreased. So the conclusion was to make differential diagnosis between M4 and M3V, a hypergranular variant. Flow cytometry was as follows: myeloperoxidase positive, CD 45, 13, 33, 117 positive, CD 64 heterogeneous, and CD 35 negative. There was detected PML RARA positive transcript, and M3V was confirmed. So if we summarize the history, we can see that the patient was diagnosed with liver cirrhosis in 2020. The liver transplant was performed in August 21. Precisely in 24 months, the patient was diagnosed with acute promyelocytic leukemia. We began with the induction with all transretinoic acid, but it's a pity on the 5th day of the treatment, because of the GIC, the patient has died. Speaking about major risk factors for patient post-liver transplantation, we can highlight renal dysfunction, biliary complication, recurrent diseases, infection, last but not least important, malignancy. That is why there are recommended screening intervals for malignancies for liver transplant patients. For example, for patients to screen for colon cancer, they should perform colonoscopy every 5-10 years for patients without any history of colonic neoplasia, and every 3 to 5 years with patients with
neoplasia in history. Speaking about malignancy in post-liver transplant patients in Republic of Moldova, in the last 5 years, we had about 54 transplants. And we have reported only 4 cases of malignancy, between which one was with acute leukemia reported here, one was with skin carcinoma, and 2 were with adrenal tumors. So the frequency is the same as in the general literature. So the solid tumors would make the biggest part, and acute leukemia would be a rare complication present in about 0.12 to 2.5% of the patients. The first post-liver transplantation AML case was described in 1997 in a 65-year-old man with hepatocellular carcinoma. These are 10 patients from the literature review that developed acute leukemia post-liver transplantation. As we can see, all of them received immunosuppressive treatment. All of them received liver transplant either because of the hepatocellular carcinoma or because of the cirrhosis with or without B or C hepatitis. The age is very different, ranging from 15 years old to 71 years old patients. So the median would be 41.5 years. Also, the cytogenetic profile in this patient is very different. And all these patients were treated according to the protocols specific for their leukemia type, some of them receiving complete remission. Median time to diagnosis also was very different, varying from 10 months post-transplant to almost 85 months post-transplant. Recent advances in the disease-free survival rate after organ transplantation have led to an increased incidence of post-transplant malignant tumors, the majority being solid tumors. So acute leukemia developing post-organ transplant would be a rare complication. Acute promyelocytic leukemia would be even a rarer one, M3V having a worse prognosis than a classical subtype. The patient's chromosomal mutation profile, the choice of immunosuppressive agent, and infection by hepatitis virus may be the risk factors for the development of leukemia after liver transplant. Well-defined complications after chemotherapy, radiotherapy, surgery are not different for the liver transplant patients. And if immunosuppression is reduced or stopped, the risk of allograft rejection is noted to be 25 to 50%. Thank you.
For today, thrombosis in acute leukemia, Mediana Mitrovic, hematologist, assistant professor of internal medicine and medical faculty.
Dear colleagues, it is so good to see you all in the Belgrade. First, I want to thank EHA for this great opportunity to have European and world key opinion leaders in the field and to discuss with them our Balkan experience and the problems. The last topic of the AML session probably will be a little bit different because I will speak about thrombosis in acute leukemias. Association between coagulation and cancer are well known for 100 years, and all 3 parts of Birkhoff-Triad are changed during the cancer. The very high risk of the thrombosis during cancer is probably led by, can we back? Okay, it's probably led by releasing by tissue factor and microparticles by tumor and pro-inflammatory condition. However, we must think about endothelial damage caused by irradiation and chemotherapy, and in some circumstances, venous stasis can be cause of thrombosis. Thrombosis are the second leading cause of death in cancer patients, and one big Scandinavian study showed that cancer patients with VTE had 3.4-fold higher probability of death, and interestingly, this is regardless of cancer type and the stage. And because of this, we must think how to prevent thrombosis in our cancer patient. Of course, we can use primary prophylaxis in this group, but question is how to identify a patient with a high risk of thrombosis and then apply thromboprophylaxis. We can begin by identifying thrombotic risk factors, and nowadays we separate these factors in 4 big groups. Let's say patient-related factors are older age, race, prior VT, obesity, and comorbidities. We all know that some type of tumors have higher grade of thrombosis, and a very high grade are in stomach and pancreatic cancer. High grade are in hematological malignancy, as well lung, gynecological, and brain tumors. Patients with higher grade of cancer have higher risk of thrombosis, of course, and the majority of thrombosis will be diagnosed around the date of cancer diagnosis too. We all know too that some types of therapy can raise the risk of thrombosis. Let's say platinum-based protocols, anti-angiogenetic agents, hormonal therapy can raise the patient risk. However, everyday procedures can cause thrombosis too, and we must think about that. Let's say that surgery, central vein line insertions, and immobilization during hospitalization are thrombophilic too. And today, or nowadays, we are using some biomarkers to predict a patient risk for thrombosis development, such as part of complete blood count, D-dimer, prothrombin fragment, P-selectin, and C-reactive protein 2. When we combine these risk factors in the model, like risk assessment model, we can improve our ability to identify a patient with high risk. And today, according to Big Darcy systematic review, we have 15 or more different RAMs for VTE development in the cancer. Probably first of them, and widely used for guide thromboprophylaxis in the cancer is Corona score. You can see Corona score. However, the first patient cohort of Corona group didn't include any patient with acute leukemias. I must say that nowadays there is only one risk assessment model for acute leukemia patient, Alani score. However, unfortunately, this score isn't validated yet. Risk of VTE in acute leukemias is even higher than a risk in other solid cancer. If we focus only on AML patients, we can say that reported incidence is between 8 or 14%. And this very high risk of thrombosis raises some question. Is there any impact of survival? Should we use a thromboprophylaxis? If we should, can we identify a patient in high risk? Do we have some risk factors or some RAMs? Of course, when you are thinking about anticoagulant drugs in your AML patient, you must think about bleeding and bleeding risk. And unfortunately, there is no any guidance to help us with these decisions. And because of that, I will try to answer on some of these questions by showing you our experience. We conducted a very big retrospective cohort study, including that more 600 patients who are treating in our center. And goals of our study was to identify a thrombosis frequency, to assess risk factors, and to develop some model. As you can see on the first graph, 70% of our patients developed thrombosis. Interestingly, half of them developed thrombosis during induction or diagnosis when their cancer or leukemia was the leading thrombophilic factor. However, 40% of them develop thrombosis while they are in complete remission during consolidation and transplantation. And the main type of thrombosis in our group were central vein related thrombosis. Interestingly, in our group, patients who had thrombosis survived longer. This is interestingly for me. I guess that patients who are living longer had more intensive therapies and more central line catheters and probably higher risks of thrombosis. But I must say that other groups didn't show any impact of thrombosis on survival of acute leukemia patients, probably because the survival was so short. Speaking about predictors, among patient-related predictors, male gender, prior thrombotic events, and ECOG were predictive. Among biomarkers, only INR was predictive. And among leukemia and therapy-related factors, central vein line insertion and intensive chemotherapy type was predictive too. If we compare our results with results of other groups, you can say that there is no single one consistently predictive factor for thrombosis development. And I must say that other group did not investigate impact of therapy type and ECOG performance status for thrombosis development. According to our results, we developed our predictive model. Even more, we validate Corona score in our group, and Corona score wasn't predictive. We predicted this score developed for leukemia, Alani score, and this score wasn't predictive too. And one of our goals was to make easy to calculate the risk of your single patient for thrombosis. Because of that, we created this nomogram, and you can put your data for your patient and calculate the patient risk for thrombosis. You can find our nomogram on the link or by using this code. Prediction capacity of our model was good, as you can see by ROC curve and C statistic. And on the other side of the slide, you can see that we perform bootstrapping internal validation. And these methods show that our score doesn't overestimate or underestimate thrombosis risk. In the end, the big question is, how should we hide the risk that you must apply thromboprophylactic therapy? And guidelines are not so punctual about this, because they are saying to apply thromboprophylaxis in patients with high risk of thrombosis and low risk of the bleeding. The ACCP guidelines guide to apply thromboprophylaxis in the patient with risk of 10% or higher. Ingrid Pabinger group developed one model and advised to apply thromboprophylaxis if the risk is 15%. And as you can see on our decision curve analysis, the major impact thromboprophylaxis will have in the patient with a risk between 10 and 20. As I said, we must think about bleeding. I must be honest, 14% of our patients develop some type of the bleeding, grade 3 and grade 4 in 30% of the patients. However, during anticoagulation, we didn't have any serious bleeding event. And to conclude, thrombosis are very frequent in AML, and because of this, we developed this model which can help you to identify a patient with a high risk of thrombosis, probably male gender and prior thrombosis event, and you maybe should think about thromboprophylaxis in this group. Of course, by using this model, you can identify a patient with a low risk which do not need any prophylaxis. In the end, we have a big need for dedicated thromboprophylaxis study in acute leukemias, especially having in mind that new drugs with very safe bleeding profile are on horizon, such as factor XI inhibitors. In the end, this is the part of stuff for our new clinic in our new building, and I want to thank all of them, and especially our leukemia team. Thank you for your attention.
John?
Thank you. Any questions from the audience? If not, I have one. Yes, please.
I want to ask two questions. First one is, did you see recommendations for treatment with cytarabine? Was that intermediate dose aracetin has the same efficacy as high dose aracetin. And also, there's from MRC trials. Also, I remember that you had a trial where that you showed in a randomized fashion that intermediate dose aracetin has the same efficacy as high dose aracetin. However, I still observe that you still administer high dose aracetin. So I'm just wondering why you don't change to intermediate dose aracetin. This is the first question. And the second question is regarding maintenance treatment with the oral AZA. I really want your personal opinion. If you think that should we administer oral AZA as maintenance to all the patients who complete consolidation, because QUASA trial was not designed like that. In QUASA trial, most of the patients were patients that they didn't manage to complete consolidation. And we should take this in mind because this is a very expensive drug. So these are two questions. Thank you very much.
And so, in answer
No.
No?
Yes.
Now? No? Yeah, good. So to answer your first question, my memory is from, you're right, that there was a suggestion that the lower dose of RSE for consolidation was non-inferior, but I also think that we could not definitively say that because of the way that the trial was designed, because it was one of many consolidation choices. So I don't think we could say definitively that that is the case, but my own experience is that it appears to work just as well as the higher dose. To answer your second question, I think people should be going into clinical trials, and I was circumspect with what I said in my discussion. I do believe in maintenance, but I think that we need to categorically prove it, because, as you say, it is further medication. It's tolerated well, but it's not tolerated well by everybody, and it's very expensive. If it was my mother, then yes, I would say that we would go for maintenance, but I'd like a little bit more evidence, not just of its continued efficacy, but its efficacy across the board. It looks good for the majority of subtypes, but how long to give it for, given that every medication is, we can't continue to just spend. I think we do need to know. But if you ask me for a yes/no decision, I'd say yes. So at the moment, at the moment, we have no idea of whether menin inhibitors would be helpful in that setting. I think that we should go through the normal standard of combining these therapies, because obviously a single agents, and then we should think about using them at different time points. Just to come back to dealing with relapse refractory, I think that the best way that we can deal with relapse is to not allow it to happen. So I think we really need to stack primary therapy and then try and resource things later on. So my preference would be to get these things into combination, to use them in induction. Yes. Yes, and I think that they will be equally very expensive or more expensive when they achieve licensing. So I think we've got to think of resource limitation as well.
Okay. Brian, I have a couple of questions, but we are lacking time. What happened with the cytabine? Because it was much, in an earlier trial, it was much better tolerated than azacitidine, even in patients with low blast count acute leukemia and in patients with MDS, and it disappeared from the guidelines. And the second question is concerning the patient for the transplant. Recently, we have some trials which proven that transplanted patients who are not in complete remission, but with very low blood count below 10%, can completely feasible go through the transplant protocol, including manipulation with immunotherapy. What's your opinion about that?
Okay, I'll start with the transplant question. I think that it's optimal to transplant patients in the minimal residual disease situation as possible. However, we all know of situations where that has not been possible with chemotherapy. And then there's always the conundrum about, do you go with the different new therapy, the immunotherapy, or do you try and give further chemotherapy, which actually just prolongs the time to get to transplant. So in our setting and in most transplanters' minds, ideally, yes, you want them to be in the lowest disease state in terms of bulk, but that does not mean to say that you cannot salvage some patients. I think it's suboptimal for the majority, but it can work. With regard to decitabine, so decitabine was in 2 of those trials that I mentioned.
in terms of its license indications and in terms of its physician preference, it just seems to be that azacitidine has won that battle, as it were. It doesn't mean to say that azacitidine is bad. If you look at the way that hypomethylating agents work, I think they work by a lot more than hypomethylation. And if you look at the difference between decitabine, which only affects DNA processes, azacitidine also affects RNA processes as well. I'm working with Steve Jackson, who designed PARP inhibitors to look at this further. I personally think that there will be a mechanistic explanation that azacitidine is better. And I think that certainly physicians have a great deal more experience with it. So it's one of these kind of, if you remember videos, I'm old enough to remember, it's kind of a VHS Betamax type of thing where one wins out, but there's no great evidence for it. It's just license indications and physician preference.
Since if azavan fails, trying it with a decitabine combination.
I don't think that the evidence suggests, the comparable evidence suggests that they work with similar efficacy. I haven't seen any studies that have used them sequentially. I think the majority of people would struggle with that, just on availability and license indications. My preference would be to try something different.
Okay. Any other questions? And over there.
Thank you. Two short questions for Dr. Mitrovic. What is the impact of hereditary thrombophilia in patients with acute leukemia, and especially with promyelocytic leukemia? And if it is an additional risk factor for VTE?
In this group of the patients, we didn't perform any thrombophilia measurement, but we published our study about thrombosis in acute promyelocytic leukemia, and we performed thrombophilia testing in that group. Interestingly, in that moment, 10 years ago, 15 years ago, we performed a PI analysis, and PI was significant, probably because, because of impact on fibrinolytic system. Nowadays consider that mutation isn't thrombophilia. Data about acute leukemias are very different. In some groups, there is some impact of factor Leiden on thrombosis development. In others, there is no any impact. It's hard to say because the majority of thrombosis were central vein line thrombosis. It's hard to discuss if there impact of thrombophilia to this situation.
Okay, thank you. And another question. Okay. If the COMPASS RAM, it could be applicable in patients with acute leukemia. What is your opinion about it?
I didn't understand the first part. Can you repeat?
COMPASS RAM. It's a new RAM, which is applicable in colorectal cancer, in breast cancer, in ovarian cancer, and lung cancer.
Okay. Oh, well, yeah, I know. The risk score for thrombosis.
It has very many parameters
that can be used.
Be used in patients with acute leukemia as well.
Yeah, I know that is the Greek developed score. Yes, we will try to calculate, because Darko was our head was the part of this score. Yes, we can try to calculate the risk according to COMPASS. You can come here. But the parameters can be calculated.
Also, you have in that score, for example, parameters for, I don't know, hormonal therapy and other type of therapy dedicated to solid cancers. And because of that, Grigor is not included patients with bleeding cancers.
Yeah, but we can try put 0 on therapy type, and maybe we can use our combined score. Yes. Yeah. Do you want to say something?
Don't leave the stage. I have 2 questions.
Oh, great. I'm not aware that you are so interested about thrombosis in this group.
Do you insert central line in each and every patient you treat?
No, only for patients with who are treating intensively. Because of that, we put just intensive therapy in the score, not both of them.
What is the drug of your the drug of choice for giving primary prophylaxis in patients?
1 molecular weight heparin.
And the dose?
Let's say 50 units per kilogram, maybe. Because we don't have trials about that. Nobody have a trials, but we use some type of prophylaxis.
And what is the threshold for platelet transfusion?
Yes, we can use that amount of dose if the platelet count is higher than 30, and full dose if the platelet count is higher than 50.
And have you observed any increase in platelet transfusion?
No.
In those patients you treated with primary prophylaxis?
When we have acute thrombosis, we are trying to rise the platelet count and use heparin therapy in this occasion. We will have the rise in platelet transfusion. But when we speak about thromboprophylaxis, we just stop the thromboprophylaxis when the platelet is too low. We don't want to rise the risk of bleeding, of course.
Okay, thank you. Another question?
So this is really very impressive data, more than 600 AML patients that we evaluated for the risk of thrombosis. So my question is,
I'm sure that a proportion of these patients received anti-thrombotic prophylaxis, and how does this impact your data?
We didn't use thrombotic prophylaxis in this group of the patient because we want to calculate the risk, and there is no guidance to use thromboprophylaxis, and we didn't use. Sometimes nowadays we will use thromboprophylaxis in male patients with prior thrombosis. We will consider. The majority of these patients had some acute infarct or CVE, not venous thrombotic events, and that is frequent. And after the thrombosis, you can lose your central vein line, postpone therapy, and have a problem.
Thank you.
Thank you. Can I sit now?
Mic is not working, I think.
I'm Viktor Pleslov from Croatia. I have a question regarding few of you mentioned that subject. FLT3 relapsed refractory patients. In our center, we have a debate about treating those patients, of course, fit patients. I know we have randomized data from Admiral trial, but some of our patients now we are treating with FLAG-IDA plus venetoclax combination. What do you think about that compared to gilteritinib monotherapy?
So, are these patients that have received FLT3 inhibitors previously?
Yes, induction.
Yeah, and have they received gilteritinib?
Some of them yes, some of them not.
Yeah, I mean, I'd go back to the Admiral study. I mean, what was very heterogeneous was the salvage chemotherapy that was used, and it was quite variable. Some of them were relatively low, what we would call low intensity. I think that there's a rationale for looking at other combinations, but I would certainly try to use a FLT3 inhibitor that the patient had not seen if they relapse and are FLT3 positive. So are they positive at relapse as well?
Yes.
Yeah. I think relapse disease is very, very difficult. I think that clinical trials will go back to that. But if in an ideal world, I would throw the kitchen sink at them if it was possible, and I would have a combination with a FLT3 inhibitor. In an ideal world, that would be a different FLT3 inhibitor, and I would be moving to transplant as soon as possible.
We are now trying with adding azavan to gilteritinib to patients that are with suboptimal response to gilteritinib.
Yeah, obviously we need something else.
Yeah.
I like speech too much. lunch will start for 10 minutes. We will proceed to our national meeting, symposia. Presentation will be on English, and we will speak on Serbian. Who want to stay, you are welcome. Who want to go on the lunch, enjoy your lunch.
Polako, pobegli su mi ovi drugi, pa... Ovako. Marijanče, ajde. Hoćeš ti tu? Aha. Pitaj nju. Može da se zatvore vrata, da prestanu priče. Jel mi možemo da krenemo sa našim sastankom? Mi Malecki tako moramo, da. Upravo kreće simpozijum. koji je posvećen našim iskustvima u lečenju pacijenata sa akutnom mieloidnom leukemijom koji imaju mutaciju u FLT3 sa naša dva izlagača, docentkinjom Virijević i docentom Borivojem Sekulićem. Ovaj simpozijum je sponzorisan od strane Novartisa i jedan kratak uvod. Dobro znamo da je FLT3 mutacija prisutna u skoro 30% novodiagnostikovanih pacijenata sa akutnom mieloidnom leukemijom, a od kliničkog značaja najvažnije su dve mutacije, unutrašnja tandem duplikacija itd. i TKD mutacija, tačkasta mutacija u delu za u receptoru. Poznato je da pacijenti sa ITD mutacijom imaju kraće remisije, da su skloni relapsu i da je ukupno preživljavanje kraće. Veliku novinu uveli su lekovi tipa inhibitora FLT3 mutacije, koje su produžile život pacijentima i napravili bridging ka transplantaciji. Pre svega tu su midostaurin koji uz standardnu intenzivnu terapiju dejstvuje i gilteritinib registrovan kao monoterapija za pacijenta sa relapsirajućim ili rezistentnom AML. Uprkos novim lekovima, alogena transplantacija matične ćelije hematopoeze je nezaobilazni terapijski modalitet u lečenju ovoga entiteta i predstavlja još uvek izazov za lečenje. Ovo su analize koje se izvode u Kliničkom centru Srbije za hematologiju i dalje je to kariotip, FISH i PCR, a vidimo da je danas NGS nezaobilazan. FLT3 ITD radimo PCR-om od 2016. TKD od 2019. a nukleofozvin od 2018. I možemo reći da je do D8, kad počinje midostaurin, stižu rezultati. Opet ovaj slajd ponavljamo da je učestalost, bar u našem centru, ITD mutacije oko 20%, TKD je svega 2%, a jedan značajan broj pacijenata ima i pridruženu mutaciju, osim ITD-a, i u genu za nukleofozmin, što ga čini intermedijarnim rizikom. Ponavljamo da je midostaurin registrovan u našoj zemlji 2019. godine, dobijamo ga preko člana 9, nije baš, to znači neke institucije ga dobijaju, a neke ne mogu da koriste. Međutim, član 9 koristimo tek od marta prošle godine i koristimo ovaj patient oriented program. To znači da je firma Novartis obezbedila prvu kutiju leka za indukciju, da slučajno ne bi zakasnio pacijent da počne da ga koristi u vreme indukcije, jer midostaurin najveći efekat svoj ostvaruje upravo u početku lečenja. A videli smo iz ovih predavanja da u održavanju, maintenance-u nema dokazano veliku efikasnost. I bar naša prva iskustva sa midostaurinom su bila kroz kliničku studiju gde smo uspeli jednog samo pacijenta da regrutujemo, već je bio završen proces regrutacije. I u ovom trenutku molim da dođe Marijana Virijević da prikaže naš slučaj sa flitacijom, sa mutacijom FLT3 gena.
I onda što sam... Ne, se vratim na početak. Da, to je to. Poštovane kolege i koleginice, ja ću vam danas prikazati prikaz slučajeva pacijentkinje sa akutnom mieloidnom leukemijom i FLT3 mutacijom. FLT3 mutacija je najčešća genska mutacija kod akutne mieloidne leukemije, koja je identifikovana kod 1/3 novodijagnostikovanih slučajeva. Javlja se u dve forme, unutrašnja tandemska duplikacija i tačkasta mutacija. I ono što je karakteristično za FLT3 mutaciju, to je njena povezanost sa povećanim brojem leukocita, zatim visokim procentom blasta u perifernoj krvi i koštanoj srži i povezana sa proliferativnom bolešću. Isto tako, znači, ima povezanost i citogenetskim karakteristikama kao što je diploidni kariotip, translokacija 6-9, translokacija 15-17 i sa nuklofozmin mutacijom. Ono što karakteriše FLT3 mutaciju, to je znači njena nestabilnost, što znači da ona može da se stiče, a može da nestane u relapsu i progresiji bolesti. I glavna karakteristika FLT3 mutacije jeste u stvari loša prognoza ovih pacijenata. Poslednje decenije nastale target terapija, lekovi, FLT3 inhibitori, tinozni kinazni inhibitori. Međutim, zahvaljujući rezultatima treće faze RATIFY studije, midastaurin je postao sastavni deo protokola za lečenje akutne mieloidne leukemije. Tako da naša pacijentkinja, 50 godina stara, na prezentaciji imala je tegobe, slabost malaksalost, tahikardiju, u fizikalnom nalazu, splenomegaliju, 3 cm pod levim rebarnim lukom, lična i porodična anamneza su bile bez značaja i dugogodišnji je bila pušač. Na prezentaciji u krvnoj slici uočava se povećan broj leukocita, 88.000, anemija, trombocitopenija, zatim u leukocitarnoj formuli 55% blasta, poremećeni parametri hemostaze, a u biohemiji povišen nivo serumske laktadehidrogenaze i feritina. Znači, citomorfološka analiza aspirata koštane srži pokazala je populaciju mieloblasta sa, znači, cup-like formacijom jedra koja je ukazala na suspektnu nuklofozmin mutaciju. Imunofenotipizacijom identifikovana je mielomonoblastna populacija s imunofenotipskim karakteristikama koje su ukazale da se radi o akutnoj mielomonocitnoj leukemiji sa izraženim CD7 pozitivnošću, CD2 pozitivnošću, CD25 i CD56 ekspresijom. Tako da CD56 ekspresija ukazuje da pacijent može da ima sklonost ka relapsima bolesti povezano sa neuroleukemijom, CD25 na prisustvo FLT3 mutaciju, CD2 pozitivnost na prisustvo inverzije šesnaestice. Naša pacijentka imala normalan kariotip, isključene su core binding faktor leukemije i PCR anamnizom potvrđena je pozitivnost FLT3 mutacije i nuklofozmin mutacije. Naša pacijentkinja nije imala neurosimptome, međutim imala je faktore rizika za neuroleukemiju, kao što su povećan broj leukocita, kao što je povišen nivo laktadehidrogenaze, monocitni fenotip, CD56 pozitivnost i FLT3 mutaciju. Tako da je imunofenotipizacijom likvora potvrđeno prisustvo leukemijskih ćelija. I u zaključku možemo da kažemo da smo kod pacijentkinje posle dijagnozu akutno mielomonocitne leukemije sa normalnim kariotipom, nuklofozmin i FLT3 pozitivnošću sa neuroleukemijom. Prema Svetskoj zdravstvenoj organizaciji radi se o entitetu akutne mieloidne leukemije sa nuklofozmin mutacijom, a prema mogućnostima koje smo mi imali, koje smo mogli da uradimo molekularno-citogenetski profil naše pacijentkinje, mi smo prema ELN klasifikaciji rizika svrstali u intermedijarni stepen rizika. Terapija je krenula sa induktivnom terapijom, znači 7+3, midostaurin, i 28. dana urađena je procena remisije koja je pokazala 16% blasta. Tako da naša više pacijentkinja nije bila intermedijarnog, već lošeg stepena rizika. Ona nema kalapodularne davaoce, tako da je otpočeta pretraga registra davaoca koštane srži. Dalje lečenje nastavljeno je reinduktivnom terapijom sa intermedijarnim dozama citozara, daunorubicinom i midostaurinom i na D28 urađena je procena remisije koja pokazuje 4% blasta, citomorfološku remisiju. Na dan 31 od primene reindukcije pacijentkinja je primljena radi daljeg nastavka lečenja, međutim u laboratorijskim analizama uočavaju se znaci lezije jetre. Urađen je ultrazvuk abdomena koji pokazuje uvećanu jetru, slezinu, virusološke i imunološke analize su bile negativne, a prema indikaciji gastroenterologa urađena je biopsija jetre koja je isključila toksičnu leziju jetre i druge infiltracije jetre. Na primjenu suportivne terapije, pacijentkinja u jednom vrlo kratkom periodu, 7 do 10 dana, normalizuje hepatogram. Tako da dalje nastavimo lečenje konsolidacionom terapijom, znači intermedijalnim dozama citozara sa midostaurinom, gde na proceni remisije bolesti, znači uočava se u mijelogramu 4% blasta, a minimalna rezidualna bolest je protočnom citometriju pokazala jednu malu populaciju rezidualnih ćelija. Kod pacijentkinje je potvrđena remisija neuroleukemije i prema preporukama Evropskog tima za transplantaciju kod pacijentkinje je dalje nastavljeno lečenje zračnom terapijom, kranijospinalnom terapijom, s obzirom da se kod nas ne sprovodi zračenje, kompletno zračenje tela. Neposredno pre zračenja ona je bila na terapiji održavanja midostaurina. Dalje je pacijentkinja ušla u centar za transplantaciju i tu je urađena pretransplantaciona evaluacija bolesti koja sada pokazuje jasan citomorfološki relaps, zatim relaps na nivou minimalne rezidualne bolesti, protočnom citometrijom i PCR-om. Znači imala je pozitivnu nukleofozmin mutaciju i FLT-ITD mutaciju. Tako da pacijentkinja je sad trenutno u centru za transplantaciju. Što bi ovako ovdje izdvojila što se tiče diskusije, to je reklasifikacija, gde vidimo da u stvari određivanje stepena rizika kod pacijenta sa akutnom leukemijom, znači utiče na prvom mjestu odgovor na terapiju i rana procena minimalne rezidualne bolesti, tako da smo na primjeru naše pacijentkinje vidjeli da je ona iz intermedijano prešla u loš stepen rizika, da midostaurin, znači može da da, znači specifične neželjene efekte. Jedan od njih potencijalno može da bude hepatotoksičnost kod naše pacijentkinje koji je bio primer, ali je veoma važna interakcija sa drugim lekovima, naročito sa CYP3A inhibitorima, koji znači mogu da dovedu do ispoljavanja ovih neželjenih efekata, tako da u svakodnevnoj praksi treba koristiti i drug checker. I terapijske opcije kod naše pacijentkinje, znači koja je imala tu pozitivnu minimalnu rezidualnu bolest, dalje davanje terapije, znači ne bi pokazalo benefit, tako da je pacijentkinja praktično ušla odmah poslednja proces transplantacije, a već pred transplantacijom je bila relaps bolesti, međutim s obzirom da mi ne možemo da damo u našoj zemlji bridging terapiju sa gilteritinibom, postoje miloablitivni kodicini režimi koji se primenjuju u takvim situacijama koje pacijentkinja trenutno prima i dalje je u planu nastavak lečenja terapijom održavanja FLT3 inhibitorima. Zaključak bi bio da je akutna milna leukemija sa FLT3 mutacijom je agresivna bolest, da su FLT3 inhibitori ušli u standard lečenja i da u stvari zbog toga što je odgovor na FLT3 inhibitore ograničen, postoji dalja potreba za razvojem novih eradikacionih terapija. Ovo je naš tim za naše klinike koji se bavi lečenjem i diagnostikom akutne leukemije. Hvala na pažnji.
Sada neka izvoli, zahvaljujemo se, docent Sekulić, a onda ide prava panel diskusija. Izvolite.
Poštovane kolege, zahvaljujem se Novartisu na pozivu da učestvujem na ovom simpozijumu ispred Kliničkog centra Vojvodini, da prikažemo naš slučaj FLT3 pozitivnog pacijenta koji je lečen midostaurinom. Iskustva našeg centra za FLT3 inhibitore su vezane uglavnom za kliničke studije, pre svega kvizartinib. Imamo iskustva, kažem, sa nekoliko pacijenata, tačnije 4 pacijenta koji su primali midostaurin i jedna pacijentkinja je čak i primala gilteritinib koji je sama kupovala, to je bio rani relaps nakon transplantacije kod FLT3 pozitivnog pacijenta. Ne bih se puno ponavljao oko FLT3 mutacije, ovo su naši neki podaci gde su u trećini pacijenata, znači 34% su bili FLT3 pozitivni, u 30% je bila udruženost nukleofozmin 1 mutacije i FLT3 ITD mutacije. Mi smo do januara 2023. slali naš materijal za Institut za molekularnu genetiku i genetičko inženjerstvo, a od januara 2023. radimo u našoj ustanovi PCR metodom, znači određivanje molekularnih markera. Naš pacijent je 45 godina star, prezentacija u septembru 2022. sa izraženim znakovima praktično anemijskog sindroma, nije imao neke druge hronične bolesti, mesec dana pre prijema imao COVID-19 infekciju i navodi da nekih godinu dana pre prijema ima problem sa pilonidalnim sinusom, vidi se da to je značajno uticalo i dalje u toku lečenja. Ne pušač, negira alkohol, ima pozitivnu porodičnu anamnezu u pravcu maligniteta, na prijemu dobrog opšteg stanja, normotenzivan, tahikardan, respiratorno suficijentan sa izraženim znacima anemijskog, bez znakova hemoragijskog i znakova infekcije. Krvna slika na prijemu, leukocitoza 37.000 leukocita, izražena anemija, trombocitopenija, sa visokim procentom blasta u perifernoj krvi, sa praktično normalnim parametrima jetrene i bubrežne funkcije, blago povišen LDH i mokraćna kiselina. I kod našeg pacijenta su viđeni blasti sa cup-like nukleolusima. S obzirom da smo mi zemlja sa ograničenim mogućnostima, kad vidimo ovakva citomorfološki nalaz, obavezno treba da radimo dodatna molekularna istraživanja, s obzirom da je često pozitivna nukleofozmin 1 i udružena FLT3 mutacija. Što se tiče urađene flow citometrije, citogenetika normalni kariogram i molekularno testiranje, tada smo još slali za Institut za molekularnu genetiku i rezultate smo dobili 8 dana nakon slanja materijala. Bio je pacijent FLT3 ITD pozitivan, TKD negativan i nukleofozmin tip A pozitivan. Tako da smo kod pacijenta krenuli sa suportivnom terapijom, transfuzijom, znači jednom standardnom uvodnom terapijom, međutim i pre započinjanja praktično intenzivne terapije, tok se komplikuje s jednim izraženim tromboflebitisom leve podlaktice i dokazanom sepsom sa Staphylococcus aureusom multirezistentnim, tako da je terapija stafilokokne sepse, Staphylococcus aureusom odložila početak indukcije, tako da su se stvorili uslovi da se obezbedi i lek po članu 9 i da se, da kažem, svi nalazi prikupe. Stav je naše kuće da se rano radi HLA tipizacija, tako da je kod pacijenta identifikovan srodni donor 10 od 10. Nakon sanacije infekcije započeta je indukcija, klasična 7+3, u kombinaciji sa midostaurinom od 8. dana u standardnoj dozi. 12. dana javlja se febrilna neutropenija, odmah krećemo ponovo sa antistafilokoknim antibioticima s obzirom na prethodnu istoriju. 14. dana i dalje visoko febrilan, radimo praktično hemokulture standardne i multiplex PCR gde dobijamo brzu identifikaciju uzročnika sepse, to je Klebsiella pneumonija koja je karbapenemaza produkujuća i praktično u tom trenutku obustavljamo midostaurin sve do nekih 27. dana dok se nije sanirala infekcija. U tom trenutku sepse je on u dubokoj aplaziji, praktično sa izraženim markerima inflamacije i sa ostalim, znači potvrđenoj kulturi Klebsiella pneumonije. Ostale kulture, uključujući galaktomanan i beta-T glukan, su bili negativni. 14. dan dolazi do razvoja bilateralne pneumonije i 16. dana, to je neki 5. dan perzistentne febrilne neutropenije, radimo CT gde pacijent ima levostrani pneumotoraks, praktično da li je to spontani ili sekundarni u odnosu na prethodni infekt, to je sad pitanje, laminarnu pleuralnu efuziju i desnostrano jednu kavitarnu leziju. Tako da već naredni dan pacijent oporavlja svoje vrednosti, znači što je, mislim, i bilo presudno za dalju sudbinu ovog bolesnika, ali i brza identifikacija uzročnika i uključivanje ciljane terapije kolistinom, ceftazidim, avibaktamom i ostalom suportivnom terapijom dolazi do, da kažem, sanacije infekcije. Nije odmah čak ni mogao biti dreniran, s obzirom da je u tom trenutku imao 6 trombocite, tako da je ali je bio respiratorno suficijentan, tako da je drenaža izvršena nekoliko dana ranije. Odgovor nakon prve indukcije, kompletna morfološka remisija. Prva konsolidacija, odnosno druga terapija bila u novembru, odnosno decembru 2022. Primio je uz intermedijarne doze ARAC i midostaurin, opet od 8. dana u standardnoj dozi. 18. dan ciklusa dolazi do razvoja febrilne neutropenije sa jednim, da kažem, brzim skokom proinflamatornih markera i razvojem jednog septičnog stanja sa hemodinamskom nestabilnošću, tako da je opet prekinut midostaurin, s tim da ovog puta nije nastavljan. Da, ovde nisam napomenuo da smo u indukciji nastavili midostaurin nakon sanacije. Ovog puta nije, jer je veći deo ciklusa isprimao. Znači, to je bila sepsa sa Escherichiom coli multisenzitivnom, koja je sanirana na adekvatnu terapiju. Dalji tok lečenja je obuhvatio primjenu konsolidacionih režima, tako da je primio još i drugu i treću konsolidaciju u kombinaciji sa midostaurinom i ove terapije se nisu komplikovale, čak nije imao ni febrilnu neutropeniju i nakon, ajde da kažem, završenog lečenja je u martu urađena revizija nalaza gde je konstatovana kompletna remisija uz i dalje prisutnu FLT3 ITD mutaciju. Tako da je on stavljen na midostaurin kao bridge do transplantacije i započeta je jedna, da kažem, detaljna priprema za transplantaciju. U tom trenutku dolazi do aktivacije onog pilonidalnog sinusa, tako da je incidiran i dreniran i praktično u maju mesecu se prima radi transplantacije. Međutim, uvidom u revizijom svih ovih nalaza, brojni zubi su mu povađeni, da kažem, ostale su samo premolar i molar koji su protrudirali u maksilarni sinus, tako da je ponovo konsultovan oralni hirurg koji je smatrao da je to potencijalni fokus za infekciju, tako da je moralo da se vadi ti zubi. Izvađe napravljena oroantralna komunikacija koja je bila i očekivana s obzirom na protruziju tih zuba i to je zahtevalo hiruršku operaciju i to je sve naravno odložilo transplantaciju. U junu ponovo i dalje curi gnoj iz pilonidalnog sinusa, tako da je napravljena ponovna reincizija i drenaža i savjetovano previjanje do praktično sanacije. Međutim, to nije tako lako išlo. Do septembra meseca on i dalje imao aktivnu uz sve negativne briseve, tako da je se abdominalni hirurg izjasnio da je to apsolutno locus minoris rezistencije za transplantaciju, tako da je on i po treći put hirurški obrađen, nadam se ovoga puta i definitivno. Sve vreme on je bio na terapiji održavanja midostaurinom, tako da je on već neki 7. mesec, dobro toleriše ridapt i nadamo se da će se uskoro sprovesti transplantacija kao jedina, da kažem, kurativna metoda, s obzirom da ima i srodnog donora koji je HLA identičan. Sad, Marijana se već, da kažem, osvrnula i u svojoj diskusiji i u zaključcima, pa bih ja, eto, možda izneo i ovde moja neka razmišljanja. Ono što smo mi imali, pošto imamo, kažem, skromna iskustva sa midostaurinom, jeste da se svakako u dubokoj aplazi, u indukciji i konsolidaciji on ne isključuje. Međutim, pitanje je šta je sa febrilnom neutropenijom, jel da li je to indikacija da se on ipak isključi, jer ako gledamo nomenklaturu ovih neželjenih dejstava, to je već gradus 3 neželjenog adverse eventa, tako da po SMPC-u mislim da je to već za isključivanje. Ono što je isto, malo moram da priznam, bilo zbunjujuće u izlaganju u prvoj sesiji, jeste da smo slušali da se radi NGS kao monitoring minimalne rezidualne bolesti. Posle koleginica rekla da baš NGS i nije toliko senzitivan, da je više PCR metodom i ta kapilarna elektroforeza da je puno specifičnija, a svi znamo da je FLT3 vrlo nestabilna mutacija, tako da je pitanje ove pacijente koji su na midostaurinu kako u stvari pratiti i da li ćemo, ako dobijemo nakon završenog intenzivnog lečenja negativan nalaz, davati bridge do transplantacije, s obzirom da imamo FLT3 leukemiju. I naravno u eri ovih novih FLT3 inhibitora pitanje je da li nukleofozmin 1 pozitivna, FLT3 negativna sa normalnom citogenetikom i bez drugih nekih, da kažem, jasnih, loših prediktora za ishod bolesti, da li je to i dalje indikacija za transplantaciju. Eto, zahvaljujem se.
Pitanja koje nismo pokrili.
Na ovom slajdu su prikazana ta neželjena dejstva koja su specifična za mikroskopiju. Posebno pratiti, ali naše iskustvo je... Da. Naše iskustvo je bilo, kao što ste čuli, sa hepatotoksičnošću, koja je kratko trajala i vrlo brzo rešena suportivnom terapijom. Međutim, ono što je mnogo bitno, to je sledeći slajd, to su interakcije sa drugim lekovima, znači kontraindikovana je upotreba CYP3A4 indusera, znači koji smanjuju koncentraciju leka, kao što su karbamazepin, rifampicin, fenitoin, a upotreba lekova, znači CYP3A4 inhibitora, da kažem, nije kontraindikovana, znači mogu se upotrebljavati kad je to neophodno, ali uz jedan veliki oprez, zato što oni povećavaju koncentraciju leka u ovoj krvi i samim tim mogu da dovedu do neželjenih dejstava.
I sledeći, molim vas.
Sledeći slajd odnosi se na pitanje značaja NGS-a koji smo i danas pominjali na ovim predavanjima. Zapravo, za ove naše pacijente mnogo je važno što mi ne možemo u startu da odredimo njihov stepen rizika. Ovo su preporuke nove ELN klasifikacije koje zahtevaju da se odrade sve, da kažem, ove mutacije i hromozomske aberacije da bi se odredio pravi stepen rizika. Tako da, kao što je koleginica iz Hrvatske danas pričala, doktorka Radić, ona je pomenula u stvari značaj NGS-a, znači na prvom mestu u prognozi, zatim dalje u terapiji, u relapsu i to je, da kažem, nešto što je sada postaje standard, znači za dijagnostiku, da odredimo sve ove citogenetsko-molekularne karakteristike.
To upravo pokazuju ova dva slučaja. FIT pacijenti, mlađi, FLT3 ITD pozitivni oboje, nukleofozmin pozitivni oboje, krstimo ih intermedijarni rizik, jedna pacijentkinja počinje da relapsira molekularno i morfološki pred transplantaciju, a drugi pacijent 7 meseci popravlja zube i rešava pilonidalni svoj sinus i ništa se ne dešava. Očigledno da bi ove druge molekularni markeri pomogli da ih bolje upoznamo i klasifikujemo. I molim vas, da li, pre thank you, da li ima još neko koji bi prodiskutovao ova dva slučaja? Ako ne, zahvaljujem se na pažnji i prijatnog dana.
case there is no margarita, we have enough time.
It's
Yes, with the discussion at the end. It was.
You will do it.
Okay. Okay, start well. I will start and you will take the next one. Take all the rest from the first. Take all the rest from the first. And I will pick up the discussion. Nema više ili? Mira, hoćemo li startujemo ili? Hello everybody. I hope that you have enjoyed lunch. Some are still in the lunch rooms, but we will start with the afternoon session. Afternoon session is considering the acute lymphoblastic leukemia. So I would like to call the first lecturer, Dr. Jan Trka from the Prague University, please.
So, ladies and gentlemen, it's my great pleasure to be here. I thank EHA for the kind invitation to this meeting. And one apology at the start, I'm pediatric hematologist. So part of the lecture will be dedicated to the pediatric stuff. I have no relevant conflict of interest. And when we look at the subtypes of ALL, we know at the moment, this is the pediatric acute lymphoblastic leukemia subtypes, and we know more than 30, 22 for BCP ALLs and 11 for T-ALL. So we know quite a lot, but when we want to prepare our diagnostic algorithm, is everything what we know really needed? And can we do everything? So the first important question we have to ask when we prepare a diagnostic algorithm is what information is needed for risk stratification, prognostication, and treatment selection in the particular protocol you want to use for your patients. Then next question is, what are the technical capacities, not only machinery and chemistry, but also the expertise of the people in your lab? What is the throughput of patients and samples for the diagnosis? And last but not least, the important question is, who's gonna finance it and to which extent? Lately, national and particular European regulations are also an important player, particularly the new EU regulation on IVD. So at the moment, we have two prognostic factors in acute lymphoblastic leukemia. It's genetics and response to therapy or minimal residual disease. When you look at this graph that depicts differential prognoses of several genetically defined subtypes of adult ALL, you can see huge differences among these subtypes in prognosis. And on the second graph, you can see the impact of minimal residual disease at the end of induction and consolidation in one of the pediatric BFM-based protocols. So let's start with the novel approaches to genetic classification of acute lymphoblastic leukemia. And before we start with the novel, let's summarize the classical one. So morphology. In my opinion, nowadays morphology is rather a screening tool than a real diagnostic method in hematology. However, it's completely the opposite for immunophenotyping by flow cytometry. It's not important also for the confirmation of the leukemia diagnosis for blast count, lineage, ploidy, and despite the fact that it cannot discriminate genetically based subtypes with certainty, it can provide us with strong hints for some subtypes, like NG2 expression in KM2A rearranged leukemias, expression of CD371 in DAX4 rearranged leukemias, particularly pattern of expression of CD27 and 44 for ETV6 RANX1-like leukemias, CRLF2 overexpression, or the presence of myeloid antigens together with T antigens for ETP and ETP-like leukemias. And then molecular genetics and molecular cytogenetics is still very important. FISH, if it's established in your laboratory, can be very useful in detection of the recurrent fusions and rearrangement. And the same applies to RT-PCR, particularly if it's multiplexed. It's fast and cheap and allows you to identify very important prognostically and treatment-related aberrations like BCR-ABL1 fusion, ETV6 RANX1 fusion, or rearrangements of KM2A gene. What about the novel diagnostic approaches? They are all based on genomics at the moment. SNP array is very useful for detection of copy number alterations and UPDs. In pediatric world, particularly for ICAROS-1 deletions and so-called ICAROS-1 plus genotype, a complex genotype that requires investigation of several genes, and also ploidy, including masked hypodiploidy, which cannot be properly investigated neither by flow cytometry or FISH. Then exome sequencing in all its variants, very important and useful for detection of ploidy changes in those mutations. And transcriptome sequencing, again, in many modifications for detection aneuploidy, all transcribed fusion genes, all mutations in transcribed regions, and also for the gene expression profiling. So using the results of transcriptome sequencing, you can identify subtypes like BCR-ABL1-like or ETV6 RANX1-like leukemias, UBTF rearranged or deregulated leukemias, KM2A rearrangement, microarrangements, and all kinds of fusions with TCF3 gene. I would like to demonstrate the importance of using these novel genomic approaches on our relatively recent study. When you look at these are just BCP ALL patients, and when you look at this graph, you can see that using the traditional molecular genetic approaches, we were able to identify several of the subgroups. However, more than 1/4 of the patients remained genetically unclassified. However, when we employed exome sequencing and transcriptome sequencing to a selected group of patients and SNP array as well, we were able to identify several other groups, and altogether only less than 7% of patients remain genetically uncharacterized. So you can see that these methods can be very helpful in the more detailed genetic classification of ALL. Based on this experience, we set up a diagnostic algorithm for the Czech Pediatric National ALL Study, which is ALL BFM 2017, and I would like to guide you through this algorithm to demonstrate to you its advantages. So we start with immunophenotype, and we also measure minimal residual disease at day 15 in all patients. Then we apply a multiplex PCR analysis for the group of well-known classical fusion genes. And then we apply SNP array to all patients. Particularly, we are interested in finding the ICAROS-1 plus genotype, IM121, ploidy changes, including this masked hypodiploidy and other aberration like Bach's aberration, for example. Then minimal residual disease by the quantitation of IGTR rearrangement is performed in all patients by combination of NGS and qPCR in all patients at day 33. And in those that are positive at day 33, the analysis is repeated at day 78 at the end of consolidation. And then in only a selected group of patients, we perform whole transcriptome sequencing, in particular the other patients that were not genetically characterized by all the previous approaches, and in a small group with high hyperdiploidy patients with highly positive MRD in a search for potentially druggable fusions. And more for research purposes, we also perform transcriptome sequencing in T-ALL and in mixed lineage leukemias. Exome sequencing, however, we use only in the very small group of hypodiploid patients in search for TP53 mutations and in patients when there is a suspicion for a predisposition. So using this algorithm, we are able to genetically characterize 95% of all our patients in prospective real-life manner. You can hear lately people talking about gene expression classifiers as a potential way ahead in diagnostics. We were involved in the development of one of the, in my opinion, best classifiers called ALL-CatchR. And as you can see, it's good in identification of several groups. However, there in the middle of this UMAP graph, you can see a huge overlap, particularly with the unassigned B other patients. So at the moment, I don't see it as a diagnostic tool for treatment decision. So a short summary of the first part of my talk. We need to carefully select the methods we want to use for patient classification, stratification, and treatment selection. And we believe that the hierarchical algorithm, similar to the one of ours, saves time, money, labor, and helps deliver the results in the required time for your protocol. I personally believe that in the near future, combination of whole genome sequencing and whole transcriptome sequencing will be the diagnostic modality for all hematological all patients with hematological malignancies. And what about germline genome analysis? It is important, for example, in the SNP array we use this, we need a control for the germline genome, and it's important for some predisposition, but it's not generally needed in all patients. In the second part of my talk, I would like to switch to minimal residual disease detection and novel approach to MRD detection. You all know that minimal, or now as it's more trendy to say, measurable residual disease is widely used in the guidance of treatment. It was used in pediatric ALL protocols since late 90s, and the gold standard is now the quantitation of immunoreceptor gene rearrangements by qPCR. It's used in pediatric protocols, as I said, since 90s, and it's now widely adopted also by adult hematologists. And detection of MRD by this approach is particularly used for not only in frontline treatment, but also in the treatment of relapse after the stem cell transplantation or during and after immunotherapy. And we can reach high specificity and sensitivity when the guidelines developed by the EuroMRD consortium are strictly applied. On this graph, you can see one of the first stories coming from Germany showing the effect of MRD in adult ALL patients. And you can see the huge difference between the group of patients that were positive for MRD at the end of consolidation, although almost half of them were successfully transplanted in first complete remission. When you exclude the transplanted patients, you see that the difference in prognosis is even bigger. In pediatric patients, I can show you the latest published data, unfortunately, from BFM 2000 protocol, and you can see strong prognostic impact of minimal residual disease despite any genetic aberration. These are all patients without respect to their genetic background. And very importantly, minimal residual disease can also detect few patients with good outcome in the generally poorly prognostic group like BCR-ABL1 positive leukemias, or vice versa. It can identify patients with poor outcome, the few patients with poor outcome in generally good prognostic group like ETV6 RANX1 positive leukemias. MRD is not only useful as a method for the follow-up of the treatment and the detection of and the prognostication of patients. It can also help you to identify a new disease, like in this example. Several years ago, when we studied minimal residual disease in Ph-positive pediatric acute lymphoblastic leukemias, we have come across patients that have discordant minimal residual disease when measured by quantitation of IGTR and BCR-ABL fusion. As you can see, the difference is huge. The decrease of minimal residual disease by IGTR is fast in response to induction treatment. However, BCR-ABL levels remain very high. Later, using several experimental approaches, we discovered that these two leukemias really differ in biology. In typical ALL, lymphoid progenitor is hit by the BCR-ABL fusion. However, in this, what we call CML-like disease, and it's now being coined like a term for this disease, multipotent progenitor is hit by BCR-ABL. So BCR-ABL are positive, not only the blast, but also myeloid T cells and non-malignant B cells. Next generation sequencing invades also MRD monitoring. Why is that? Because it simplifies target identification and selection of the immunoreceptor gene rearrangements. It allows for virtual quality testing of patient-specific MRD targets, and it helps us to determine false MRD positivities in the critical phases of treatment, like post-transplant or immunotherapy. It can also provide us with the information about B-cell reconstitution, which is interesting for research and can be potentially important for prognostic purposes, and potentially quantifies MRD with the same or even better sensitivity than classical qPCR-based approach, and definitely with higher specificity. I'm sure that you are aware of the existence of the EuroMRD consortium that standardizes for many years the approaches for IGTR rearrangements for MRD detection. It now comprises more than 60 laboratories on 5 continents, and in collaboration with another consortium, Euroclonality, it developed standardized open academic solution for IGTR-based NGS MRD detection in lymphoid malignancies. We used this technology in a retrospective study and compared its result to the classical approach. We found a decent concordance between these two approaches and definitely better specificity for the NGS approach. And this better specificity, when we use the NGS approach for patient stratification, allowed us to stratify significantly more patients into the standard risk group, and that would theoretically allow us to reduce therapy in the bigger group of patients compared to the classical approach. I was talking about determination of false positivities in qPCR-based MRD detection. This is a fact that it's known already for many years. I'm sure that you are aware that low positivities below 10 to the minus 4 remain a gray zone for treatment decision, particularly in the situation of a B-cell reconstitution like after the stem cell transplantation. And these potentially false positive results that originate from non-specific amplification of the background may have devastating results for patients. So we decided to retest these low positive results by qPCR by NGS, and we did it in a prospective study in 3 transplant centers in Czechia and Slovakia on pediatric and young adult patients. And we found 32 patients with these low qPCR results that were potentially false positive, and we reanalyzed them by NGS. What we found that only 9 of these were truly positive by NGS and 22 were negative. And when you look at the outcome of the patients, of these 9 truly positive patients, 5 relapsed and only 4 remained in complete remission. However, in the second group that were NGS negative, 21% remained in complete remission and only 1 relapse. So this shows that NGS is really a powerful tool, particularly in this gray zone of very low MRD positivities. Last but not least, I would like to mention the sensitivity issue, because when you hear, particularly when you hear about the commercial assays for NGS MRD, you can hear that this commercial assay reaches sensitivity of 10 to the minus 6. So sensitivity is defined by the amount of analyzed material, cells or DNA, rather than the technology used. To reach the theoretical sensitivity of 10 to the minus 6 or 1 cell among 1 million normal hematopoietic cells, you have to analyze at least 10 million cells by flow cytometry, or at least 7 micrograms of DNA for all DNA-based methods. And given the stochastic nature of these methods, you would rather use 3 times more, something like 20 micrograms. And this is the amount you can hardly reach during the treatment, particularly in pediatric patients. So better sensitivity is not the advantage of NGS MRD, it's the specificity of the approach. So let's summarize this part. We have shown that NGS provides concordant results with the gold standard qPCR in extensive comparison. There are some discrepancies, and to the major extent they are explainable by better specificity of NGS. NGS clearly enhances the impact of MRD when it's routinely used in specific settings, particularly after the stem cell transplant in the time of massive B-cell reconstitution. And at least in pediatric ALL, there is no realistic prospect of a prospective comparative study that would show the superiority of NGS method because of the overall great outcome of pediatric ALL patients and very long follow-up you would need for such a study. So we believe that it's time to incorporate NGS MRD to the future currently planned treatment protocols. So in conclusions to my talk, novel diagnostic methods provide more information that are currently needed for treatment, and we have to choose wisely which we want to use. NGS-based technologies will definitely dominate diagnostics and MRD detection in the near future. And we believe that complete hierarchical algorithms for genetic classification and MRD detections are needed for fast and cost-effective diagnostic of ALL patients. On the very last slide, I would like to thank my key collaborators from the CLIP laboratories and the Second Faculty of Medicine at University Hospital Motol in Prague, both national societies, Czech and Slovak, and their heads, and also the colleagues from the EuroMRD and Euroclonality Consortia. And thank you for your attention.
Dr. Prague, for the insightful presentation. The questions will be addressed at the end of the session. Do you have any questions?
Yeah. Now? Okay, we have a question and answer session at the end of the session.
Okay, okay. We continue so, but before we continue, I would really like to thank Rita and the colleagues from the Serbian Society of Hema Association for the opportunity they have given us to be together here in the beautiful city of Belgrade and to change experience and ideas about our work. Margarita Genova will the second lecture, unfortunately, is not here with us because of a mild health problem, and we'll move on in the third lecture under the title "The Place of Minimal Residual Disease in the Management of Acute Lymphoblastic Leukemia," which will be given by Dr. Kara Binar from Turkey.
I would like to thank to the organizing committee for this opportunity. And I'm very glad to be here and talk about MRD in ALL. I have no disclosure. In patients with ALL at diagnosis, there are 1 trillion leukemia cells. When we decrease those cells to 1%, we say the patient is in hematologic remission. After that time, we cannot detect disease by light microscopic evaluation. So we need some different methods to measure residual disease. Among those methods, multicolor flow cytometry is highly applicable method, and it's the fastest, cheapest method. It can detect phenotyping shifts during the treatment, but it has the lowest sensitivity. Real-time PCR for fusion gen and immunoglobulin or T-cell receptor gene rearrangements are the mostly used methods. For fusion gene, real-time PCR has a very limited applicability. However, the real-time PCR for gene rearrangements has applicable with great sensitivity, and although it's expensive and requires patient-specific primers, it takes a huge labor. NGS is not well standardized in ALL treatment, and it's very expensive and requires bioinformatic experts. So we need to study on NGS, but now we use real-time PCR and multicolor flow cytometry in the treatment of ALL. In the NEVO ALL, positive MRD at end of induction was evaluated in several studies. They use different methods, they use different categorization of MRD, and compared the MRD effects with the other variables. And they said the same thing, it's a significant independent prognostic factor for relapse in ALL patients. It's true for positive MRD at end of consolidation, and it causes higher relapse rates in those patients if it's positive. Children oncology group's experience showed us the early induction MRD response caused significant effect on patients' event-free survival rate. End of induction MRD leads lower event-free survival probability in early. It has a great impact on early relapse and late relapse, and end of consolidation MRD cause a worse prognosis. Good patients with good prognostic factors also affected by end of induction MRD positivity. So the patients with ALL, their MRD levels at end of induction, end of consolidation, and early induction cause lower event-free survival in the patients. From IOP BFM ALL 2000 study, separated patients in classical risk groups and looked at the effects of MRD risk group on the event-free survival. And the risk groups, MRD risk groups, were defined like this, and event-free survival for 5 years decreased with higher MRD levels. In each group, MRD caused a significant impact on the event-free survival. If the patient has positive end of induction MRD levels, end of consolidation determined the prognosis. If the patient had higher MRD at end of induction, the effect of end of consolidation MRD was significant. The same group evaluated T-cell ALL separately, and they showed that MRD risk groups had different outcomes, and relapse rates are significantly influenced by MRD risk groups. If the patients with T-cell ALL, if MRD is negative at end of consolidation, negative, end of induction MRD has no impact of the survival. However, if the end of induction MRD is positive, end of consolidation cause a very significant impact on relapse rates in those patients. T-cell ALL is different than B-cell ALL because the clearance of the leukemia cells are slower in T-cell ALL, and end of consolidation MRD is more proper to define the risk of relapse. And end of consolidation high MRD patients showed a relationship between the extramedullary relapses and MRD in T-cell ALLs. And it was shown that chemotherapy can be safely reduced in medium risk group patients in de novo ALL if they have negative MRD at end of induction, and outcomes improve with therapy intensification in MRD positive patients in medium risk group patients. When we look at the relapse ALL patients, in RES ALL FM 95-96 protocol aim to develop a reliable way to identify relapsed intermediate risk groups patients who require hematopoietic stem cell transplantation and who will benefit from it. And they measured MRD levels at different time points and showed that end of induction MRD has a great importance on survival. They defined MRD positive and negative 1 per 1,000 cells, and if the MRD level is higher, they showed lower event-free survival and overall survival, and it was related to the deepness of MRD levels. And the patients who had higher MRD levels and did not undergo bone marrow transplantation showed very worse outcome. In 2002, RES ALL BFM study put the patients who had a high MRD load after induction to transplantation, and the others received only chemotherapy. And you can see here the patients who had low or high MRD load after induction did not show any difference in event-free survival, overall survival, relapse rate, and death issues. And if you look at the two consecutive studies, BFM 2002 and 95-96, you can see the differences. If the patients received MRD-based hematopoietic stem cell indication, they showed improved overall survival, event-free survival, lower relapse and death ratios. In pre-transplant setting, MRD is important, and the lower the level of pre-transplant MRD, the lower the risk of relapse. Many studies are used, in many studies, PCR or flow cytometric analysis were used, and NGS used a few studies. It's obvious to lower the leukemia load before the transplantation to assure successful outcomes. However, it's not clear how deep it should be. If the MRD level is low, do we need to do more treatment for decrease this load or to reach zero? Post-transplantation MRD positivity is more important than pre-transplantation MRD positivity. If it's higher, causes lower event-free survival, and if it occurs later after transplantation, brings lower event-free survival too. The physicians should be very careful. The patients who are in second or more complete remission, who has positive MRD before transplantation, who did not have bone total body irradiation before transplantation, and who did not have acute GVHD until 19th day post-transplantation. Patients high and very high pre-transplantation MRD positivity, if they reached negative post-transplant MRD, had lower relapse rate and higher event-free survival. Reaching negative MRD after transplantation is effective. However, if the patient has positive MRD after transplantation and develop acute GVHD, their relapse rates are similar to the patients who had MRD negative without acute GVHD by the NGS studies. So MRD is most powerful prognostic factor, and patients benefit MRD-based risk stratified therapy. It is a good surveillance tool with the potential to detect early relapse, and it can serve a very beneficial surrogate endpoint to assess the therapeutic effects of a novel treatment or a new therapeutic product to speed up testing and approval process. And this is the summary of what I said. This is our experience with different protocols and different approach to MRD. At the beginning, we used a modified relapse ALL protocol. We did not measure MRD. So relapse rate was so high, and then we switched the protocol BFM 2002, but we couldn't measure MRD at the beginning, and then we tested end of induction and end of consolidation. Our relapse rates decreased, and then we used BFM 2009, and we measured early induction, end of induction, and end of consolidation MRD levels, and we saw the list relapse rates. So that's, thank you, your attention.
Thank you, Professor Karapinar, for your very interesting lecture. And now we're going to go ahead on the next speaker from North Macedonia, Professor Vidova, on the lecture over assessment of T-cell receptor gene rearrangement as a method for post-induction minimal residual disease monitoring in adult patients with T-cell acute lymphoblastic leukemia.
Thank you to the organizers for accepting my presentation, and I would like to state that by adult patients here are also included, and young adults and adolescent patients, as our treatment center treats patients beyond the age of 40. So the learning goal is to present the integration of molecular testing in T-cell acute lymphoblastic leukemia into clinical practice, but after this comprehensive lecture of Professor Trka, I decided to do through interactive clinical cases from our experience, and by those cases, I will try to answer if molecular-based approach to clinical management of patients with ALL seems plausible, especially in countries with limited resources to diagnosis and treatment as my country. So molecular testing in acute leukemia is a rapidly evolving domain because new mutations are being identified every year, and simultaneously high throughput sequencing techniques are evolving to detect those mutations. In general, molecular methods for detection of mutation in acute lymphoblastic leukemia include PCR, traditional sequencing, and next-generation sequencing. And nowadays, acute leukemia has become one of the most highly sequenced malignancies, and therefore an ideal model of how molecular studies can translate into clinical practice. And thanks to the characterization of molecular landscape of patients with acute leukemia, we have greatly improved our knowledge on pathogenesis, diagnosis, prognosis of the disease, encouraging new prospects for precision medicine. But what has been said generally addresses on patients with AML and patients with BLL. In TLL, this molecular landscape is somehow less investigated. For example, patients with AML and BLL, the revised edition of the World Health Organization classification of tumors has incorporated that new entities of AML and BLL based on genetic abnormality. Even more, based on these abnormalities, patients can be stratified into several risk groups. However, in TLL, in general, the diagnostic is based on immunophenotyping, and there are two types defined and included in the nomenclature, which is early T-cell precursor TLL and TLL not otherwise specified. Also, based on defining abnormality, there are targeted drugs which have been developed for the treatment of AML and BLL, while in TLL, those targeted drugs target non-specific abnormalities, general vulnerabilities. Something that is most important in the field of CLL is the topic of my presentation, MRD detection, because majority of patients with both BLL and TLL have immunoglobulin or T-cell receptor rearrangement around 90% of all patients, and respectively, we have a target for MRD detection. The method that is used in our country for MRD, for molecular MRD monitoring is T-cell receptor clonality testing by multiplex fluorescent PCR and subsequent capillary electrophoresis. Based on MRD values, patients can be risk stratified into risk categories, and also these values can guide the further treatment. This is especially important to answer the question whether patients who achieved MRD negativity can be spared from additional toxicities such as stem cell transplantation, and whether this procedure should be delayed in first hematological response. In our country, we do transplant the patients who achieved MRD negativity, and the main justification for that is that we are not sure that we can reach the optimal MRD level of sensitivity of 10 to -4. So this is the first patient. It's a 36-year-old male with no previous medical history. He initially presented to our clinic in December 2021 due to massive cervical lymphadenopathy, which was biopsy, and the finding was thin lymphoblastic lymphoma. As we can see, he came with normal blood counts, and there was absence of blast in peripheral blood smear. We performed bone marrow investigation, and both morphology and flow cytometry had no evidence of acute leukemia, but molecular studies was also performed for TCR rearrangement, and we detected monoclonal T lymphocytic population with rearranging TCR beta and TCR gamma genes. PET-CT scan was also performed, showing stage 4 of disease due to bone lesions in maxilla and lumbar spine. These are the photos for our patient. So the molecular studies confirmed the initial bone marrow involvement, although there was no signs of a morphological disease. The picture on the right side, in the picture performed on day 33, which shows also the same peak that was detected on the diagnosis is also present, but now it's observed in dominantly polyclonal pattern. This patient was treated with hypercivat protocol, and he proceeded to matched sibling donor stem cell transplantation. The second patient is a younger patient, 22-year-old boy, who also had no previous medical history. He presented to our clinic in July 2020 due to anemia and thrombocytopenia and leukocytosis, and 40% of bloods were present in peripheral blood smear. Bone marrow investigation proved TLL. There was no immunophenotype of VTP TLL, and molecular studies also showed T lymphocytic population and monoclonal with rearranged TCR gamma and TCR delta genes. So these patients were treated with BFM regimen. When we have a young patient with TCL acute lymphoblastic leukemia, we always pose the patient, should be this patient be considered as transplant regimen? The decision depends on individual risk, which is proposed by the protocol. As we can see, BFM protocol is one of the clearest examples which emphasize the role of MRD status. Based on MRD status, as shown on this figure, patients can be allocated to other risk group, even in absence of poor risk clinical features or poor risk cytogenetic features. And this regimen proposes, clearly defines the time points for MRD assessment, day 15, day 33, and day 78. These are the results from our patients. The upper picture is the monoclonal rearranged lymphocytic population at the time of diagnosis. On day 15, we did not perform bone marrow, but he was a good steroid responder as there was no blasts in peripheral blood smear. On day 33, we performed MRD from bone marrow, and we also we could see the same peak, but in a dominantly polyclonal pattern. Flow cytometry, as per flow cytometry, patient was MRD negative. On day 78, we saw absence of the initially detected monoclonal T cell population. These are some of the indications for stem cell transplantation in both patients with BALL and TLL, and we can see that patients who achieved MRD negativity on day 78 can be spared from stem cell transplantation. And this is also important for patients in which we don't have MRD data. They should be considered as transplant candidates. Pediatric BFM protocol established flow cytometry as a method for MRD monitoring. But can we use also a molecular method for MRD monitoring in patients treated with BFM protocol? In our practice, we use both methods, and these patients somehow are complementary each other, and the results are comparable. However, beside the known advantages of PCR methods in favor of flow cytometry, we would like to emphasize that we have noticed that patients who are undergoing treatment, they present with lower numbers of cells at the time points for MRD monitoring, which is logical due to hemotoxicity. And flow cytometry is more dependent on the number of viable cells compared to PCR methods. We suppose that the sensitivity level of flow cytometry in patients with hypocellular bone samples is reduced. This was already shown. And we move to the last patient. It's a 47-year-old male. He appeared with January 2022 due to symptoms of anemia. He had leukocytosis and also thrombocytopenia and 37% of blast in peripheral blood smear. flow cytometry confirmed the diagnosis of TLL, and molecular studies for TCR rearrangements also confirmed monoclonal T lymphocytic population with rearranged TCR delta genes. Patient proceeded to treat, this patient received hyper-CVAD regimen in a total of 4 cycles and then underwent matched unrelated donor stem cell transplantation. The MRD assessment of the end of first cycle, he was MRD negative. This is the consensus of North America experts proposed by Jabbour and Kantarjian, and according to this consensus, the only patients who are MRD positive should undergo stem cell transplantation, and also patients who have poor risk disease, such as considered patients with ETP TLL. However, in our center, we are reluctant to rely only on these MRD values due to the reasons I've already told. And this patient, stem cell transplantation was performed, and on the day plus 90 of transplantation, he appeared with ptosis of the left eyelid. The MRD was performed in order to exclude differential diagnosis, and it showed relatively normal finding. Bone marrow was performed, and this is important. He had normal bone marrow, and both flow cytometry and multiplex PCR showed MRD negativity. Cerebrospinal fluid was also performed, and cytology showed third classification group and presence of atypic lymphocyte, and molecular studies confirmed the monoclonal T lymphocytic population with rearranged TCR genes diagnosed in bone marrow at the time of diagnosis, which means that this target, which was observed at the time of diagnosis, could be also used for tracking this population in samples from the liquor. And I won't not gonna go through all of this. I'm gonna focus only on the last sentence. So in order to standardize the molecularly based approach in TLL, an initiative from Hematology Association is required to develop a scheme for providing universally available tools for molecular monitoring, especially in countries from Balkan. Thank you for your attention.
Thank you very much for the comprehensive presentation. And we'll go on with the last but not least presentation under the type acute leukemia associated with the T829 translocation and FGFR1 rearrangement, diagnostic and therapeutic challenges, which will be given by Dr. Voiko, if I am saying it
Yes,
well.
you're saying it right, yeah.
Okay.
Hello, I'm Pavel Voiko from Sofia, Bulgaria, from the National Hematological Hospital. I would really like to thank you for the kind invitation. And today I'm going to present a clinical case of acute leukemia associated with translocation 8 and 9 and FGFR rearrangement and its diagnostic and therapeutic challenges. I have no disclosures. Our warning goals for today is to present the clinical case of acute leukemia associated with this translocation, describe its unique features, and identify the genetic background. So we have a 48-year-old male patient who has the following symptoms since July 2022. They included fatigue, shortness of breath, lymphadenopathy, frequent infections, and fever. His only comorbidity was sleep apnea, and he was negative for cancer family history. The patient first arrived in our clinic in October last year. He presented with ECOG-PS status of 0 to 1. He had pale skin, tachycardia, and lymphadenopathy. These are his initial lab results. As you can see, we have leukocytosis with increased neutrophils and immature cells and marked eosinophilia. He also had mild anemia and thrombocytopenia. Before being referred to our center, the patient underwent a lymph node biopsy a month earlier, and the results showed materials from a significantly enlarged lymph node with obliterated histological structure, with diffuse infiltration of small lymphoid cells with characteristics closest to L1 lymphoblasts, and the immunochemistry markers show that the cells were positive for CD1A, CD3, 4, 8, and TDT positive, with immunomorphological data corresponding to precursor T lymphoblastic lymphoma leukemia. Our next logical step was bone marrow examination, and the bone marrow aspirate, for our surprise, showed 31% myeloid blasts and 26% eosinophils, with morphological data for acute myeloid leukemia associated with eosinophilia. The flow cytometry confirmed that the blasts are indeed myeloid. There was CD34, CD33, and CD13 positive. It also detected 20% eosinophils and no lymphoblasts. And the diagnosis of acute myeloid leukemia was confirmed by a bone marrow biopsy. As you can see on the picture, the top picture shows the bone marrow, and on the bottom one is the peripheral blood smear. Next, we did the conventional cytogenetics, which showed male karyotype with translocation 8-9, which was present in all chromosomes, and this find was later confirmed by FISH, and FGFR1 rearrangement was present in 88 of the interphase nuclei. We also did NGS, which showed RONX1 mutation and TET2. We also did a PCR panel for AML, but which was negative for the most common mutation. We also did a full body CT, which showed enlarged lymph nodes above and below the diaphragm. We did lumbar puncture, which was negative, and tests for hepatitis B and C, all of them negative. So on this slide, we have the diagnosis. We started with the lymphoblastic lymphoma, then we got the AML from the bone marrow aspirate, and then we got the FGFR1 rearrangement. And our final diagnosis, according to the WHO criteria, is a myeloid lymphoid neoplasm with eosinophilia and FGFR1 gene rearrangement. So, time to treat the patient. We decided to start with AOL induction regimen, the GMA1, which is the standard of care in our practice. We did the prephase and the first induction. And a month later, when we reassessed the patient actually progressed. The myeloid blast in the bone marrow increased to 36%, which was confirmed by flow cytometry, but at least we had some effects on the lymph nodes as they were decreased size. We then decided to change our treatment strategy and went with the good old 7+3 with cytarabine and idarubicin. And when we reassessed the patient a month later, the acute myeloid leukemia was in remission with 1% blasts, with negative MRD confirmed by flow cytometry. But of course, he had persistent enlarged lymph nodes. That's why we count the response as partial, not complete. We decided to continue with consolidation with high doses of cytarabine, and we got the same response a month later. And of course, our next logical step was to perform an allogeneic hematopoietic stem cell transplantation. We used MAC conditioning regimen with geotepa, busulfan, and fludarabine. The donor was a matched unrelated donor from Germany, actually. He had a rather quick recovery for neutrophils on day +10, for platelets a day later. He received standard GVHD prophylaxis with cyclosporine and methotrexate, and his only serious complication was neutropenic enterocolitis. And after the allogeneic transplantations, we finally achieved complete response with negative MRD, complete cytogenetic response, and the PET-CT, which was performed 3 months after the transplant, showed that it was negative with no enlarged lymph nodes. Post-transplant, he continued immunosuppression with cyclosporine, and he only had a mild BKV reactivation. So here we have the path to the complete response, even longer than the path to diagnosis. But what's important is that the patient remains in complete response to this day, 6 months after the transplantation. So let's talk a bit more about this group of diseases. Myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. They are a group of diseases with aggressive clinical course and rapid progression of chronic phase to blast phase or secondary acute leukemia. Clonal eosinophilia is a recurrent finding, and more than 70 different fusion genes have been identified. The most common being PDGFR alpha and beta, less common are FGFR1, JAK2, FLT3 rearrangements, and many more. They have a very diverse clinical presentation, which can include MPM, MGS, acute myeloid, lymphoblastic, or mixed lineage leukemia or lymphomas. The myeloid lymphoid neoplasms with eosinophilia and FGFR1 rearrangements are actually a subgroup of the previous group. They are very rare and they are characterized by clonal proliferation of myeloid and/or lymphoid precursors harboring translocation or insertions involving the FGFR1 gene. They can present once again as MPN, MGS, or acute leukemia. Extramedullary involvement can be frequent, and they were first described 30 years ago as 8p11 syndrome because the gene for the FGFR1 is located on the 8th chromosome. They are a very rare entity with less than 100 cases reported worldwide. And this case is actually the second in Bulgaria. The first one was 20 years ago. The most common gene fusion that can affect the FGFR1 can be always include translocation 8. The most common is translocation 8-13. Less common are translocation 8 and 9, like in our case, and even less common are translocation 6 and 8, 22, and at least 10 more. Another common finding on R1X1 mutation. And the diagnostic approach should always include conventional cytogenetics followed by confirmatory FISH testing. And the treatment recommendations depend on when the diagnosis is made, when it's in the chronic phase, hypomethylating agents in the blast phase, induction regimens for acute leukemia. There is some data about using TKIs like ponatinib and midostaurin, but it comes from a very few patients and it remains a bit controversial. There is actually approved target therapy, pemigatinib, which is a highly selective FGFR1 and FGFR2 kinase inhibitor, but it's only approved only in the USA, not in Europe. And allogeneic hematopoietic stem cell transplantation in its early referral is definitely recommended, and it's the only option for curative treatment. And to finish off with some case-based conclusion, myeloid lymphoid neoplasms with eosinophilia and FGFR1 rearrangement is a rare entity with an aggressive clinical course. We need full and thorough diagnostic workup. The treatment is even more of a challenge, and early allogeneic stem cell transplantations give the chance of prolonged control of the disease. And thank you for your attention.
Thank you very much for an interesting case. So we are opening the discussion. So please, Dr. Donner, you have a question for the beginning for Dr. Trka?
Really comprehensive, very nice talk on the diagnostic.
Yeah, it's okay.
On the diagnostic in pediatric acute lymphoblastic leukemia. So I have two questions. So first of all, what is the turnaround time? I mean, we do know that we need the information quite early in these patients. And the second question is, I mean, you mentioned that it's not only an issue of sensitivity, it's the quality of our material. And I would be interested because we do see really significant differences when we use peripheral blood or bone marrow. So what are you using in particular for MRD monitoring? And we are also seeing huge differences when we use MNCs versus cells that have been harbored by lysis. Do you have the same experience?
So this is all excellent questions. So the turnaround time. I haven't said that we have approximately 140 newly diagnosed ALL patients per year coming from both Czechia and Slovakia, including relapsed cases. And basically the needed turnaround time is 40 days. And we need within the 40 days, which is the end of induction plus 1 week, and that's the time point when the treatment starts to differentiate between the risk group among the risk groups. So this is what we need. So all these things are doable except for, let's say, transcriptome sequencing for TALL cases or MPALS, which is more as a research at the moment because TALL are not differentiated within the protocol. So 40 days, and we only outsource SNP arrays just because it's cheaper, and all other approaches are done directly in our laboratory. The quality of the material. It is crucial. We are receiving material that travels for 1 day, 2 days, sometimes even more, and the quality obviously differ. So we try to work with mononuclear cells. We don't use cell lysis in general, and we set up a complex scheme that allows us to transport the samples from all centers in Czechia and Slovakia within basically 24 hours. It doesn't work always like 24 hours, but we completely organize and provide this service for all the participating centers, which is costly, but it's good in terms of quality of the samples we work with. And it's only 7 centers in Czechia, 3 in Slovakia. So it's not comparable to Germany, where it's like in pediatric oncology, it's like 80 centers or something like that. So very, very complicated. And the third question was on peripheral blood and bone marrow. So all MRD assessments are done from bone marrow at the moment, because we know that in BCP ALL, the average difference between the levels in bone marrow and peripheral blood is about 1 log. In TLL, it's pretty comparable, but in BCP ALL, it's just 1 log. And people who use and promote the novel technology, the commercially available NGS approaches, claim as one of the potential advantages that we could use peripheral blood because of the higher sensitivity. But it's the same issue with the amount of material you need. So if you have 20 micrograms of DNA from peripheral blood, then it's okay. Then you will reach realistically a level comparable to 10 to the minus 5 in bone marrow, but definitely not 10 to the minus 6, and with this amount of material.
Thank you.
Very nice talk, Jan. Can I just one very quick question about the BCR-ABL cases with discordant IGH to BCR-ABL qPCR. Are these patients got P210 or P190 breakpoints?
Yes, that's a good question. There's no difference. Both these breakpoints are found in both groups. So it's not like, intuitively we would think, okay, these are CMLs in blast crisis, but it's not like this. And the difference is even in the populations that are BCR-ABL positive. It slightly differs from what we believe are true CML cases.
I have one question to you, but also to audience. We know that in adulthood, in many patients with acute lymphoblastic leukemia, you have a dry tap. It's much rarer in the childhood, as far as I know. The children dry tap. That means diagnostics is made on the bone marrow biopsy. How are you solving the problem of diagnostics in such a case when you have not the possibility to have enough cells from the bone marrow? because we are using morphology, we're using immunohistochemistry. Panels from for immunohistochemistry is much shorter and much restricted than panels for flow. Genetics can be done, but RNA assays are not. FISH is also a problem for such cases, but we can see such patients, let's say 1/4 of this ALL, adult ALL cases have the dry tap or very sparse material from the bone marrow.
So we definitely don't see it that often, and it's really rare if we don't have enough material. And if more material is needed for the basic diagnostic workup, it's repeated. The aspirations is repeated, and because we also analyze minimal residual disease in adult ALL patients. I haven't talked about it, but we have also a cohort of adult ALL patients, and we don't come across this problem so often as you referred to.
Any comment? Any questions more from the audience?
Can I have a question to Dr. Boykov? Did you have a chance to test clonality of these lymphoblasts and myeloid cells like IGTR rearrangements?
We did not, because the lymphoblasts are only in the lymph node biopsy, and we did not get fresh material. It was paraffin black, so like we could not do any gene testing on that.
Okay.
Any other questions concerning other reports? If no, please, next session is a coffee.
Doesn't work. Ah, okay. Dear colleagues, I would like to propose that we continue with the last session, but not less interesting. We'll continue to discuss about treatment, acute lymphoblastic leukemia, and I would like to invite our speaker, dear Professor Messer from UK.
The invite to speak today. It's a real pleasure being here. And I'm based at University College London, which is probably now the largest acute leukemia centre in the UK. So we have a catchment of around about 6 million people. And between Great Ormond Street and UCLH, we probably have around 200 new acute leukemias every year. And I'm going to focus my talk today on T-cell acute lymphoblastic leukemia. We had a really nice introduction from Jan and the others about some of the other diseases, particularly B-ALL, but this will really focus in here on T-ALL. So I'm going to talk about the genetics of T-ALL, particularly focusing on the non-coding genome and the aberrations that we've identified in that disease. Look at some of the prognostic markers in T-ALL, the clinicogenomic landscape of induction failure. So this is a particular problem in patients who fail to go into remission after their first cycle of chemotherapy. And then lastly, finish off with a novel immunotherapy target. As you're aware, immunotherapy for T-ALL has been quite challenging, and we have a quite exciting target that we are pursuing for that. So this audience doesn't need a particular introduction to T-ALL, but just to make a couple of points, about a third of cases have got a mediastinal mass, and that sometimes causes SVC obstruction. And then there's very high male to female preponderance, about 4:1, which is thought to be partly due to mutations in the PHF6 tumor suppressor gene. And people have already discussed these subtypes of T-ALL, but I think you can pretty much discern them by the 3 levels of differentiation arrest, the early T-cell progenitor subtype. So this is where most of the HOXA positive cases, which are often driven either by HOXA translocations or MLL translocations, will sit, as well as LIL1 and MF2C translocated cases. And these cases tend to have mutations in some of the myeloid-associated genes, even sometimes FLT3. And you have high levels of NMYC in this case, where you normally see CMYC in the other activation in the other cases. So the early cortical T-ALL cases, these tend to be TLX1 or TLX3 positive, TLX1 normally in adults, TLX3 normally in pediatric Ts, and these are CD1A positive and tend to have activation of the JAK-STAT pathway, like almost all of them have JAK-STAT pathway activation, and there's a very, very high instance of Notch1 mutations in this particular group. And these patients tend to do quite well. They tend to be quite steroid responsive and tend to be slightly easier to treat. And then there's the late cortical T-ALL subgroup, which is characterized by activation of TAL1 and LMO1 or LMO2. And these cases tend to be double positive or sometimes single positive, CD4, CD8. And they almost always have activation of the PI3 kinase pathway, usually through loss of PTEN. So there's been quite a lot of work done into the order of events that has led to T-ALL, and it's quite apparent that TAL1 lesions and LMO lesions occur very early in disease pathogenesis as these so-called truncal lesions. CDKN2A deletions that are commonly found are also very early events. And then there's these other events such as Notch1 mutations that occur much later in disease pathogenesis in subclones. And this is obviously very relevant for several reasons. Firstly, for MRD analysis, you obviously don't want to be tracking something like a Notch1 mutation that we've shown often gets lost at relapse, or you often acquire new Notch1 mutations at relapse. Whereas you want to be tracking something like a STIL-TAL deletion that occurs very early. And the second is therapeutically targeting things that are outside on the sort of little branches and leaves is unlikely to lead to a sustained response. And that's why our lab has spent a lot of time focusing on trying to target the TAL1 LMO locus, but I'm not going to talk about that work today. So what's apparent from cytogenetics is that actually 40% of cases, often you don't find a cytogenetic lesion that will explain activation of one of these major oncogenic transcription factors. And when you do gene expression profiling, as Jan was sort of alluding to, you often actually find that these cases will all fall into the other subsets. So they all actually will represent one of these other subsets, but you can't find the driver lesion. Tau1's a really good example of this because we know it's activated in about half of cases, but there's only still tau deletions in about 1/4. And these you can see here is the 80 kilobase deletion between the still promoter and to tau1, leading to its constitutive expression. So that means there's other unexplained reasons for tau1 activation. And when I was in Tom Look's lab, we came across these mutations that occur 8 kilobases away from tau1. And these are very small mutations, often 2 base pairs, sometimes 12 base pairs in size, that lead to insertions that create binding sites for the transcription factor MIB. So all of these mutations occur in exactly the same hotspot, and they all give us that very classic MIB primary binding motif. And this brings in MIB, and MIB then creates an enhancer that then activates tau1. And just a little bit of science just to show you that these are genuinely causative. So this mutation is present in Jurkat cells. And if you go and perform CRISPR and repair this mutation, you can see on the right-hand side that when you repair the mutation, tau1 expression is completely lost. So these are genuine causative mutations and not passenger lesions. So we've been calling these NEMOs, or neomorphic enhancer mutations of oncogenes. And when I set my lab up at UCL in 2014, we thought we would try and find more of examples of this, both in TLL and in other cancers. And we thought we'd go to whole genome sequencing. It seemed the obvious place to go for the non-coding genome, but the haystack is extremely big, as you know, 3.3 gigabase pairs. There's about 2 somatic mutations per megabase in an ALL genome, so relatively low mutation burden, but this still leads to over 6,000 somatic variants in any given ALL genome, and most of those will be just passenger mutations, and trying to find a true driver non-coding mutation in amongst that is genuinely like trying to find a needle within a haystack of needles. So we use another method called chip sequencing, which some of you may be familiar with more from the research side, where you basically use antibodies that grab bits of proteins that are bound to DNA, and then you sequence the reads. And what happens if you have a gain of function mutation is that the protein will bind just to that allele and not to the wild type allele. And when you look for the allelic ratio of those mutations, you see they're massively skewed in favor of the mutation. And you see that's also at the RNA level. You see monoallelic expression of the associated gene. And this turned out to be much more fruitful. For a start, it cuts down the search space from that 3.3 gigabase pairs down to now 1 to 2% of the genome that you're looking at. And we've done this in about 60 different types of cancer and found mutations amongst most of those cancers, but relevant to this audience, the TLL, we see mutations upstream of LMO2. This is another MIB insertion, 40 kilobases away this time from LMO2. And again, this we proved that that was a causative mutation. This is another mutation that we identified upstream of LMO2. This is actually slightly different. This isn't actually an enhancer mutation. This is actually a promoter mutation. So it's an insertion or a tandem duplication that occurs in the first intron of LMO2. And you can see that by the MIB peaks that you can see in blue there in the 2 cell lines with this mutation. And these mutations are internal tandem duplications, a little bit like you see with FLT3, but what they're doing is they're actually duplicating a MIB binding site. And it seems that when you duplicate this MIB binding site, it's enough to enable MIB to come in and then drive expression of LMO2 in these cases. And again, we proved that using CRISPR, that these are a genuine gain of function. What was sort of apparent is when we started digging into these genomes is that actually that most patients or many patients had both activation of LMO2 and tau1, often by different mechanisms, which is sort of quite interesting because these are 2 hits actually in the same oncogenic complex. So you rarely see that sort of in biology. But it did sort of remind us of some of the early work that Terry Rabbits did when he crossed the tau1 transgenic mouse with the LMO1 transgenic mouse and saw this massive increase in tumor penetrance and decreased tumor latency. So these are clearly cooperative when you increase expression of both of these transcription factors. So most of those mutations are actually instigated or caused by off-target RAG activity. So they often have cryptic RAG recognition sequences around them. But this one here that we found upstream of LMO1 is actually an exception. This was a point mutation that had a very characteristic APOBEC type signature. And again, introduced binding sites for MIB. So if we go back to our patients, we can now actually explain activation of these oncogenic transcription factors in an additional 15 to 20% of cases, leaving about a quarter of cases still with no obvious driver, and we're obviously working hard to try and determine whether there are any other drivers in those cases. So we know that the tau1 still tau deletions, for instance, occur very early in disease pathogenesis, but what about the non-coding mutations? Are these also first hit phenomenons? And we've done a recent study that gave us a really interesting insight into this, and this is looking at patients with very late relapse TLL. So most of you as clinicians will know that when you have a TLL relapse, it usually occurs within 18 months, 2 years. It usually is the same TCR rearrangement from a chemotherapy-resistant clones. So these patients who experience very late relapse, so this is after 5 years of being in remission, they're very rare, and we had to go around the world to collect these cases, and we found 10 paired presentation remission relapse samples. 3 of those had the same matched T-cell receptor arrangement as their original diagnosis, so those are true relapse cases. But we found 7 that had completely different TCR rearrangements, and we thought these were most likely secondary leukemias. And we actually probably expected to find germline predisposition, because the chance of getting TLL twice, because given it's a rare disease, seems infinitesimally small. But actually, we only found 1 case with a PMS2 mutation, a germline mismatch repair defect, leaving a lot of the other ones unexplained. And what was really fascinating is when we did whole genome sequencing on these cases, is that we found 4 cases where there was only a single same mutation between the presentation and late relapse, and that was these LMO2 intronic duplications. And in 3 cases, and we found a tau1 non-coding driver in 1 of the other cases. And I'll just show you what that looks like. So though in red you can see the internum tandem duplications in the 3 patients, and what you can see on the left is the tree, the first presentation. There's a tau1 lesion, which is a neomorphic enhancer mutation, and a CDKN2A deletion on top of the LMO2 intronic duplication. Then this boy was age 5, and when he relapsed age 12, he also then acquired a new activation of tau1, this time through a still tau deletion. He got a CDKN2A deletion, but the breakpoints were completely different to end up with what looked like the same leukemia, but is actually only shared with the single LMO2 intron 1 duplication, which I think is quite fascinating. We were able to get the blood spot from this child. So this is the blood spot that was taken at heel prick when the child was born, and we actually developed a PCR specific for the mutation. We're able to identify the mutation in this child at birth. So just to sort of show you this in a sort of more cartoonish fashion that might be a little bit easier to follow, we think that in some cases children are born with these LMO2 intronic mutations, a little bit like you see with TEL-AML1, that over a 5 to 10 year period they acquire mutations or activation of tau1, CDKN2A, and Notch1. What you would commonly see is that early relapses occurring from the same TCR within the first next 2 to 3 years. But there's this pre-leukemic clone that just harbors the single LMO2 intronic driver that goes on to produce a secondary TLL that activates the same pathways, tau1, CDKN2A, and Notch1, but through different mechanisms. So now I just want to move on to prognostic markers in TLL, because there are some sort of quite distinct for T versus B, and you obviously have heard a lot about MRD, and I think MRD probably trumps most things when it comes to prognostication in TLL. But TLL has been very difficult to study from a prognostic point of view because it's such a rare disease. So we don't have the luxury of these massive AML cohorts of several thousands of patients where you can get very robust prognostic markers. We're often dealing with low hundreds in numbers. It's also a very good outcome disease nowadays. There's a 90% survival in pediatric TLL, meaning there's very few events. So statistically, it gets very difficult to answer some of the prognostic questions. And then lastly, the treatment protocols make a massive difference, and I'll give you an example of that. So there are many different prognostic markers that have been put forward. I'll give you some of the more robust ones. So mutations in Notch1 and FBXW7, this was first put forward by the Germans and then the French group, showing that these are associated with good prognosis. I'll just show you the data from our own pediatric studies that patients who have 2 mutations in this pathway, so that's either 2 Notch1 mutations or a Notch and an FBXW7 mutation, have a really quite remarkable and excellent survival at 100% in children. In adults, it's not quite so impressive. There's a sort of trend towards improved survival, but certainly nothing that you would do in terms of differently when it comes to treatment. But nonetheless, the French actually used these mutations to risk stratify their patients alongside MRD. So we know that rapid steroid response is also important. CD1A positivity is definitely associated with a good outcome, as is TLX1 positivity. And actually all those 3 things are all probably part and parcel of the same thing. TLX1 cases tend to be CD1A positive, and they tend to be steroid responsive. Now, when it came to sort of immunotherapy targets, there was the Spanish group actually designed a CD1A targeting CAR T cell, and that is now currently recruiting in Barcelona. But there's a problem with that in that this CD marker is such a good prognostic marker that we very rarely see patients who with relapse refractory disease. In fact, only 3 of 50 patients that we had in our practice over a 9-year period were CD1A positive, meaning it's going to be quite difficult to find a sort of immunotherapy that covers all different types of patients. So going on to the poor risk markers, I just talk about ETP because this is something that's been quite a bone of contention across different groups and different protocols. And this is, ETP was first described back in 2009 by Daria Campana's group at St. Jude's, where they described this CD1A negative, 34 positive, CD5 dim, and expression of 1 or more myeloid markers as associated with a really dismal prognosis. As you can see in the survival curves here. But the key thing to note is that these were historic patients recruited at St. Jude's in the late 1990s through to the early 2000s, where there was no MRD risk stratification at that time. So we looked at this on our UCAL 2003 trial, where there is MRD risk stratification, where patients with high-risk MRD get ramped up, more intensified therapy. We used a different assay, which looks at biallelic deletions of TCR gamma, which doesn't perfectly overlap, but mostly overlaps with that immunophenotype. And what we found was these patients do exceptionally well, with an 87% survival. But when you look at the reason for that, it's quite obvious, because these cases all had very high MRD at the end of induction, with a median MRD of 2.5%. These patients all went on to the most intensive regimen, regimen C, and this was clearly sufficient to salvage them, and these patients didn't need to receive transplantation. So this really just highlights how protocols and MRD risk stratification can really sort of trump other prognostic markers. So I just now want to move on to a very particular group of patients that have been quite difficult to treat, and these are cases of induction failure TLL. So these are patients with 5% or more residual disease at the end of a first round of chemotherapy. And this is work done by David O'Connor, who's a clinician scientist in my lab and a consultant at Great Ormond Street. So what David did is he looked at over 3,000 cases from UCAL 2003, and he noticed that actually the risk of induction failure was 3 times higher in T-cell ALL compared to B-ALL when they're given identical induction therapies. So what he's done is he's now done whole genome sequencing on 50 of these cases. So he looked at 700 cases of TLL from UCAL 2003 and UCAL 2011, of which about 70 experienced induction failure, and then performed WGS on these 50 cases. And he found that age was by far the most strongly predictive clinical factor of risk of induction failure. So there was a over 20% risk of induction failure over the age of 16 years of age. And it's actually quite a continuum of risk according to age. And I think that's a really important thing when you come to discussing sort of induction therapy with older age children and young adults. There was a change in practice on how to treat these patients in the UK. So from 2011 onwards, these patients started to receive nelarabine, as you can see in the purple bars, followed by consolidation with allogeneic transplantation. And when we looked at what impact that made in terms of survival, it was actually slightly depressing, because the addition of nelarabine actually made no difference. In fact, they did slightly worse, these cases. And patients who received transplant did no better than those that did not receive transplantation. Now, I should just caveat that data that this is not randomized data by any means. This is just observational data, and there could easily be bias associated with this, where clinicians who have the most aggressive looking cases choose to go down the nelarabine transplant route. So this really needs to be sort of retested in a randomized trial, but randomized trials in this sort of setting is very, very challenging. When it comes to the genetics of this group, we saw a high preponderance of ETP cases, as we showed before, so consistent with this high MRD that we see in this subgroup of cases. Lots of them were HOXA activated. Many of the HOXA activated cases were downstream of MLL rearrangements. These patients actually do quite well. We managed to, most of them were salvaged with standard chemotherapy and or transplantation. The other cases, not so well. And what was really obvious, just to come back to the non-coding mutations, was that almost all the TAL1 positive cases that we saw at induction failure were driven from the TAL1 non-coding lesion and not still TAL rearrangements. And that's just shown in the top bars here. So usually with responsive TLL, these non-coding mutations make up 10% or so of cases, but by far the vast majority of these induction failure cases are driven by the non-coding mutation. And exactly why that is the case is really something to research, and we're currently looking into why that might be. So when we did a meta-analysis of risk of poor outcome after induction failure, the most striking genetic predictor was this TMR genotype. So that's having a TAL1 non-coding mutation, an activation of MYC and or RAS. And these patients do really abysmally and clearly needs alternative therapies. So are there any targetable lesions that we can sort of jump on with ready available TKIs, for instance? And sadly, the answer to that was no. So we didn't see any of the PDRF-beta type translocations that you sometimes see with poor risk BALL cases. We didn't see any ABL class mutations that you might be able to give ABL class inhibitors for. There's some JAK-STAT pathway mutations, but actually JAK-STAT inhibitors are not particularly effective in TLL. So this was really quite disappointing when it comes to targeted therapy, but to sort of reiterate the point that we really should be moving to an immunotherapeutic approach, as has been done for BLL, where we can be sort of agnostic to the underlying genetics and target a cell surface marker that is expressed across many cases. So I don't really need to introduce all the different types of immunotherapy for BALL that are currently approved, and many of them are approved on the NHS in the UK. But TLL has been much more challenging, and the reason TLL has been more challenging is this problem of shared T-cell antigens between malignant T-cells and normal T-cells, meaning when you try and develop CAR T-cells in vitro, these cells will tend to kill each other, something called fratricide, or if you give them to patients, it will eradicate their own T-cell populations, leading to T-cell aplasia, and yet obviously that's going to be quite immunosuppressive, unlike B-cell aplasia, which seems to be quite well managed just with IVIG. So to look at for a potential marker, we went to the Protein Atlas, where there's RNA-seq on 172 different normal tissues, and we asked a very simple question. We just said, what is expressed in the only TLL cell line in that compendium, which was MALT4 cells, but not expressed in any normal tissue? And this came up with a very short list of genes, just 12 genes. And of those, CCR9 was the most attractive because it was the only one that was on the cell surface. So CCR9 is a G-coupled cell surface receptor. It binds to a natural ligand called CCL25. And it's expressed on a very rare subset of gamma delta T cells in the gut. And the role of those T cells is not really quite clear, because CCR9 knockout mice who don't have those T cells are actually very healthy, they have normal gut health, but oddly are actually resistant to Crohn's disease. And so for that reason, pharma have been very interested in targeting CCR9 positive T cells for inflammatory bowel disease therapeutics. So we had a look in normal donors by flow cytometry, and fortunately we saw no more than 15% or so of normal B and T cell subsets express CCR9. We did see it expressed in double positive cells in the thymus, as we would expect. And when we looked across published cohorts of patients looking at the RNA level, we found CCR9 expressed in 80% of TLLs, and it was agnostic to the subtype. It was across all groups. So we developed a flow assay where we could quantify the antigen density on the cell surface. And what we found was that at relapse and refractory disease, and we looked here over 100 cases of TLL by flow cytometry, is that the expression of CCR9 is higher in relapse refractory setting. The actual antigen density is quite low, so we're talking around 1 to 2,000 copies per cell. And just to put that in some context, CD19 is expressed at around 20,000 copies on our B-ALL patients. So we were a little bit unsure whether we'd be able to develop CAR-Ts for this target. But nonetheless, we pushed on, and this all happened during COVID and the lockdown. We immunized rats, and my lab were coming in sequentially to keep these hybridomas going. And we eventually ended up, after losing many hybridomas, with one very good binder to CCR9. And we also made a CCR9 knockout cell line so that we could look at the specificity. And we had one binder, this 9G7 antibody. And we cloned that into a format very like Kymriah, as a single chain variant fragment, as a CAR-T, together with an RQR8 suicide gene. And when we tested this in vitro, we saw very specific killing of the P12 wild-type cells, but no killing of the P12 CCR9 knockout cells, so it's highly specific. And we saw highly specific release of IL-2, as you can see on the right. So is there any evidence of fratricide in vitro? Is there any self-killing? And the answer to that is no. These cells expand beautifully in vitro, and you can are very equivalent to CD19 CAR-Ts. And when you use them against primary PDXs, primary patient samples in vitro, you see very efficient killing, as you can see in the red dots. So we moved to in vivo, and we did in vivo in MALT4 cells. So we engrafted NSG mice with MALT4 cells that are CCR9 high expressing, and treated them with CCR9 CAR-Ts and CD19 targeting CAR-Ts and non-transduced T cells. And you can see really excellent disease control in the CCR9 CAR-Ts, to the point that actually they had no detectable disease at day 40, so we re-challenged them with tumor again. And in fact, 3 of the 4 mice rejected that re-challenge. We then moved on to doing PDX studies, so primary TLLs in vivo, and again we saw really fantastic control of disease. And when we looked in the bone marrow, when these mice were culled, we saw really no evidence of detectable T cell leukemias in those mice, even using MRD. So when we submitted this for publication, the reviewers asked us to determine what was the minimum antigen density where you'd see efficient killing in vivo. And I think that's actually quite a good question when it comes to developing a clinical trial. And we found when you go below 600 copies per cell that we start to see escape quite quickly, as you can see in the bottom Kaplan-Meier curve. But just to put that in some context, to go back to the antigen densities that we've seen in patients with relapsed and refractory disease, you can see that most of them have over 1,000 copies, meaning that we think we can probably capture almost all cases of relapsed refractory TLL who would be eligible for this type of CCR9 directed CAR-T. And so I'm pleased to say that we've now got funding from the MRC to take this to a first-in-human phase 1 trial, which we call Fractal. And that trial is going to start in adults, but hopefully, if we can get the funding, move into pediatrics as well, and that should hopefully open in the next 6 months. So just to conclude the talk, Non-coding driver mutations account for a significant fraction, probably 15 to 20% or so, of patients that lack classic chromosomal translocations. These are all in very distinct hotspots, and for that reason should be very amenable to pick up with targeted gene panels by NGS. These non-coding mutations are very early initiating events and are sometimes even present at birth. The TMR genotype is associated with a very dismal outcome in induction failure T-ALL, and novel immunotherapy target CCR9 has a possibility of an option to treat all comers agnostic to their underlying genomics. So with that, I'll be just to say thank you to the members of my lab who did this work and Paul McCotch's group who helped us develop the CAR T cells. And I'm very happy to take some questions at the end of the session. Thank you.
Thank you, Dr. Monsur, for your presentation. Sorry. Thank you, Dr. Monsur, for your excellent presentation. I have a pleasure to invite Dr. Anal İnce from Turkey for the presentation, the role of immunotherapy in treatment of acute lymphoblastic leukemia patient. Thank you, Doctor.
Okay, good afternoon, everyone. And I want to start by thanking to the organizing committee for their kind invitation. And also, I'm very pleased to be part of this very nice meeting. And I'll shift gears from lab data, more translational research, I would say, to clinical data, as well as to pure pediatric data. And I'll try to summarize in 10-15 minutes the role of immunotherapies in the treatment of pediatric B precursor ALL. I have no disclosures to make. So as learning objectives, we will go over the available immunotherapies for pediatric B precursor ALL, and we'll go over the evidence that we have to use them in relapse and newly diagnosed ALL. So it might look very good for our adult colleagues maybe, but it's for us pediatricians, even reaching to 80%, 85% survival rates for acute lymphoblastic leukemia in childhood is still not enough. So we're trying to do better. We still have patients that die with leukemia and die due to toxicities. And those are the patients generally for the newly diagnosed pediatric ALL. The challenges remain to treat patients less than 1 year of age or over 10 years with the adverse clinical features as listed here, also with unfavorable genetic alterations, and also as mentioned in the previous session, the not achieving a good MRD level, especially at the end of induction and consolidation, with a target of less than 10 to the -4. And also, we know in pediatrics, the early relapse still remains to result in less than 30% event-free survival and overall survival. So these for these hardly treated patients, we have today some other tools that we'll go over a little bit. So blinatumomab is a bispecific T-cell engaging antibody construct. So one hand goes to the T-cell with CD3, and the other hand goes to the blast cells. So it links the T-cell with the CD19 positive blast cells and induces the cytotoxic immune response. And we know today that it's not that good to induce remission, but very good in achieving MRD negativity, which we really need. And it's given as a continuous infusion, 28 days, so it needs hospitalization, and we try to increase the dose if the patients do not have any side effects. So today, for relapsed ALL, for high-risk patients, I'm sorry, I need the pointer. I think the pointer is not working. Anyways, we have two nice studies, one from United States, Brown et al. Reported, and the other one from Europe. And both of these studies showed the efficacy of blinatumomab in high-risk ALL patients. Both of them used a randomization of one from United States used 2 bilina cycles before transplant and compared it to 2 chemo cycles. And European colleagues gave 1 cycle of blinatumomab before transplant and compared it to the chemo-only arm. And both of them were able to show the significant difference in overall survival. As you will see, the one with 81%, the other one with 71%. The event-free survival was significant in European study, but the US study was actually terminated early when they saw the overall survival advantage, so they stopped the study to be able to, for all patients to be able to use the blinatumomab in high-risk relapse. So when it comes to the low-risk relapse, meaning that the patients generally, those patients who relapse after 36 months, and Children's Oncology Group randomized patients to receive 3 cycles of blinatumomab and compared it to the chemotherapy arm. In this study, there was no, when all patients, the whole cohort was evaluated, there was no significant difference in EFS or the overall survival. But interestingly, when they looked at the patients who had a bone marrow relapse with or without extramedullary relapse, they were able to show that the event-free survival and the overall survival was significantly better in the blinatumomab arm. So for pediatrics today, in all risk groups for a relapsed ALL, B precursor ALL, blinatumomab is the standard of care, and both the BFM and COG takes it as the treatment arm, and COG is comparing it to randomizing it to a study arm. When it comes to using the blinatumomab in newly diagnosed ALL, well, we do not have any randomized trials reported so far yet, but there is a single-arm phase 2 study which was reported this year, and this was on patients who we really had very difficult times to treat. Still, the survival remains in this group remained actually less than 50%, which was not acceptable. And then the study showed that implementation of the blinatumomab into an interferon 06 chemotherapy backbone, they were able to achieve event-free survival at 1 year of 96%, which was a great result. So without even any randomized trials, now today, the infant ALL patients are being treated with blinatumomab with this protocol. So other studies, both the Children's Oncology Group and the BFM group today, are randomizing their patients to receive blinatumomab versus chemotherapy, and we will have the results of these studies in upcoming years. So the second agent we have is the inotuzumab ozogamicin. So this is kind of an antibody sitting with a bomb. The CD22 antibody is conjugated to calciumycin, and after binding to the CD22 antigen on the blast cell, it's internalized, and then calciumycin just is released, goes into the nucleus, binds to the DNA, and causes the apoptosis. So inotuzumab ozogamicin was approved by FDA for the treatment of adult patients with relapsed refractory ALL after this randomized trial, which showed the 80% very significant CR rates in the inotuzumab arm as well as the MRD negativity, and they were able to show a significant improvement in event-free survival. When it comes to pediatric studies, we have 2 retrospective and 2 phase 2 studies. Actually, the CR rates are somewhat around 60%. The MRD negativity is not bad, but the event-free survival as well as the overall survival still remains less than 50%. And O'Brien et al. Actually reported better event-free survival for patients who were transplanted after inotuzumab and who received CAR T-cell therapy after inotuzumab ozogamicin, and also for those patients who were MRD negative, in MRD negative CR. These patients achieved actually around 60% of event-free survival. But the liver toxicity, especially the sinusoidal obstruction syndrome, is very striking, especially for patients who are consolidated with transplant, had up to 50% of sinusoidal obstruction syndrome. For today, the BFM group is randomizing inotuzumab to a standard chemotherapy for relapsed patients, and we will see the results in coming years. When it comes to the newly diagnosed ALL, we still do not have any published data in pediatrics in newly diagnosed ALL, but Children's Oncology Group is randomizing patients to receive 2 cycles of inotuzumab ozogamicin in between chemotherapy blocks. But after this protocol was open for patients, there was a considerable risk for sepsis in subsequent chemo blocks after receiving inotuzumab. So the protocol was actually amended to a lower dose of inotuzumab, and also they omitted a delayed intensification part 2. Also recommended some prophylaxis to avoid severe infections. So CAR T-cell therapy is one of the most promising treatment approaches that we have today. For this, patient has to be leukapheresis for their T cells, and these T cells are manufactured to express a CAR specific to a blast cell antigen. This is generally the CD19, and also CD22 CARs are coming to be used in clinical trials. And after these T cells are expanded, following a bridging chemotherapy, because the manufacturing time is around 2-3 weeks, these patients receive a bridging chemotherapy during this time, and after a lymphodepleting therapy, these expanded CAR Ts are given back to the patient. And of course, the patients are monitored for severe adverse events, the ICANS and cytokine release syndrome, and they have to be monitored closely for MRD and B-cell aplasia to predict the relapse. So tisagenlecleucel was approved by FDA in 2017 for BAL, ALL patients, pediatric patients, and patients who are less than 25 years of age, for refractory and in second or later relapse. And you see the one of the main studies, the Eliana trial in pediatrics, which was reported in 2018. Here, the event-free survival was given as 73% at 6 months and 90% overall survival at 6 months. And this year, actually, the long-term data was reported, and they gave the event-free survival of 44% at 3 years, and the overall survival at 63% in 3 years, which is better than what we had before, but actually quite not enough for our goals. And for a newly diagnosed ALL, the CAR T cells are being studied again in Children's Oncology Group for the high-risk patients who do not respond well to treatment with MRD positivity are offered to receive CAR T cell treatment. Again, we're waiting to see the results of this study. So are we there yet? I don't think we are. We still need improvement in the treatment of these patients. Yes, we have new tools. but each has advantages and disadvantages over the other. And there are ongoing studies that we would like to see the results, to see their use, optimal use of these tools. So with the hope to cure all patients, I want to thank you for listening, and we'll be happy to take questions and comments. Thank you.
Dear colleagues, about the role of immunotherapy in relapse-resistant ALL, will talk us dear Professor Todorov from Slovenia.
Hello to all. I'm very glad to be here and to have my lecture. My lecture will be very simply because I have only 10 minutes, and I'm going to talk about the B precursor ALLA. I have no disclosure. So in my introduction, you already know this slide. I think everybody knows it's famous for B-cell ALLA. The incidence is relatively rare in adults. We have peak, pointer is not working. We have peak in the pediatric group from 4 to 9 years, and after that, everybody have the same chance to get the LLL. And the older is patient, the news is worse. There is a bad news to get LLA in elderly days. In this slide, when we see that when we are treating B precursor cell BLL, CR rate after the frontline therapy is high, but relapse is very common. And we see CR rates are between 60 and 90%, but overall survival at years is very low, maybe 3 years or more in the younger patient if we talk. So remission rates are high, but the relapsing or refractory patient are additional 30 to 60% without stem cell transplantation or not. Remission rate in the first relapse with standard salvage combination chemotherapy are from 20 to 83%, generally not durable at the chemotherapy approach alone. In adults, long-term free survival and cure is 7 to 25%, which is very low and generally occurs only with allogenic stem cell transplantation. This is a very nice slide from Dr. Scharlach, and how we recognize relapse refractory acute lymphoblastic leukemia historically is hematological relapse. We have to think about salvage chemotherapy or stem cell transplantation. Curing consensus is quantifiable MRD from 10 on minus 4. For the patients without stem cell or in the first to CR, in the subsequent clinical relapse in 2 to 6 months reach 0.8 to 43 months. 5 years overall survival of patient with molecular relapse is 36%, in 15% without, very low, without allogenic stem cell transplantation, and 80% with allogenic stem cell transplantation. What's the future? NGS, MRD positive. I didn't put the slide on the point mutation in LLA is very complex, and in our clinic, we still don't work NGS MRD for LLA adult patients. What is the importance of MRD? MRD is detector and is critical for predicting the outcome and for selecting the intensity of further treatment strategies. Is the best marker who gives up, give us an answer if the patients will relapse or not. MRD developing is very popular at these days, and we have various new diagnostic platform, as I say, NGS sequences, and which are very significant advances in sensitivity of MRD diagnostics. Which methods we use for MRD? Common methods to assess MRD in LLA include multiparameter flow cytometry. They're usually reserved for pH negative LLL, and PCR for immunoglobulin or T cell receptor gene re-engagement is used for TLLA, and PCR for BCR-ABL patients with pH positive LLA, and the next generation sequencing and NGS. In our clinic, we are doing all of these three methods. Only NGS we don't have. What is the common salvage for relapsed refractory acute lymphoblastic leukemia adult patients? Standard salvage chemotherapy are, we all know, based on purine analogs, fludarabine, clofarabine based therapy, vincristine, and nelarabine for TLLA. What are the results of these common salvage chemotherapies we have on this table, which are showing us overall response rate. Those are different studies, different chemotherapies, and overall response rates are very low, from 14 to 48, but the overall survival in months is very low. What is the goal of the treatment of relapsed refractory acute lymphoblastic leukemia? The goal of the treatment is to induce remission and then to consolidate complete response with allogeneic hematopoietic cell transplant on the basis of the significant survival benefit seen with allogeneic stem cell transplantation. And we saw the best results from the common salvage therapy, so we have now in the new era immunotherapy for relapse resistant acute lymphoblastic leukemia. So we have MOBs, not like mafia MOBs, but monoclonal antibody. The previous lecture showed us those immunotherapies in pediatric population. They are the same in the adult population. So we have inotuzumab ozogamicin, this is CD22 antigen. Blinatumomab is bispecific, and the newest one, CAR T cell therapy. What are the NCCN guidelines for relapsed refractory ALL? As we see, if we had a failure, we have for pH positive or pH negative, we have all these three like treatment in the first relapse, blinatumomab and inotuzumab and CAR T cell TISA in this case. pH plus positive BLLA have TKI plus. I will be short because the previous lecturer will show us how blinatumomab works. I will tell you only the indications from blinatumomab. Blinatumomab is indicated as monotherapy for treatment in adults with CD19 positive relapse refractory precursor BLLA, and or monotherapy for the treatment in adults with pH negative CD19 positive BLLA. Patients who are pH positive, they have to fail treatment with at least 2 TKIs and have no alternative treatment options. What are the side effects of blinatumomab? The most significant toxicities are not studied with CRS and CNS effects because of the mechanism of action of this drug. Other adverse effects are common hematologically. Effects include cytopenia, infections, and other laboratory abnormalities. But it is important to know that all those side effects were noted in the first days of the first cycle of treatment, and most of them were transitioned. You all know for this tower study, this is the study for the blinatumomab versus standard chemotherapy, and we know the median overall survival was 7.7 months to 4 months for blinatumomab. And if we see the tower study remission by subgroups, all numbers are showing better results for blinatumomab cohort. Another of the monoclonal antibodies is inotuzumab ozogamicin, is CD22 directed antibody drug conjugated to indicate monotherapy for the treatment of adults with relapse or refractory CD22 positive leukemia, is indicated for the pH positive and pH negative at all or most patients. I would not repeat the mechanism which was told by our previous lecturer. I'm going to show only those slides for the side effects of the inotuzumab ozogamicin, like high rates of veno-occlusive disease in those patients post transplant is very significant. Some of them, 5 of 18, were fatal. The study which show us inotuzumab vs standard chemotherapy was INNOVATE, and in this can you see here the progression-free survival was better in inotuzumab group. In this slide, you see more of these trials for in targeting therapy for BLLA in adults. For inotuzumab are INNOVATE. I show you the result from INNOVATE. They are INNOVATE in combination with mini hyper CVID for adult and pediatric population. But in the blinatumomab studies, I like the most those Alcantara studies, which show us very fine results about MRD rate response of 88% and median survival 7.1. And plus study, who is arranged for the patients who are pH negative with only MRD positive disease, not without hematological disease, which show us a very high MRD rates of 78% and median overall survival of 36 months. What is the choice of targeted agents for relapsed refractory LLA? At first, what is available? What we've got? Decision is always should be made on the individual basis. Presence of the antigen CD19 or CD22, or maybe previous exposure to one of these agents, immune status of the patient, disease burden, comorbid conditions. Blinatumomab is better for only MRD positive patients, elderly patients with hepatic disease. Inotuzumab, it would be preferred in patients with a high volume of disease, CNS disease, and for the patients which are not going to allogeneic transplantation, we have consolidative treatment with blinatumomab in some studies in inotuzumab. In this study, ecocochrane, we see here that blinatumomab is incorporated in very early phases of treatment of LLA, is incorporated in MRD positive patients. CAR T-cell, we are going to listen our next lecturer would have on the CAR T-cell. I would only say that the year 2017 was marked by the FDA and approved for two chimeric antigen receptor therapies, EMA approved 2018, and approved indications were for the treatment of relapsed or refractory diffuse large cell B lymphoma and the treatment of patients up to 25 years of age with acute lymphoblastic leukemia in the second or early relapse. This slide we already see. And this is the promising table, which shows us that there are CAR T-cells trials for adults in relapse refractory B-ALL, not only for young adults to 25, but we have a Zuma study who is showing us fine result in ALLA in adults. What about the future? Sorry, okay. The future maybe is the combination of the red or blue pill, and this is the study from the MD Anderson, which they are combining their all. What about us? This is the Department of the Hematology in Ljubljana. This is our orange zone. We're treating our patients here, and we have 5 years experience with monoclonal antibodies. Because we are a small country, we have about 10 cases per year. Blinatumomab got 30 patients. Only 5 are alive. Inotuzumab ozogamicin got 4 patients and they are all died. CAR T-cell for adults LLA, we have none, but we have 12 cases for diffuse large B-cell lymphoma. Thank you for attention. This is Nice Ljubljana.
Thank you very much. I would like to propose dear Professor Tsirigotis from Greece. We'll continue to discuss about chimeric antigen receptor T-cell therapy in adult B-cell precursor acute lymphoblastic leukemia, curative treatment option or bridal transplant.
First of all, I would like to thank very much the IHA and the organizing committee for give to me this opportunity to be here with you. And I will in the next 10 minutes, I will try to give an answer to these questions. And I will touch these 3 topics as you can see in the slides. We know that we have two commercial, there are 2 available products commercially available based on the co-stimulatory domain. The first one is the one with the use as a co-stimulator domain, the 4-1BB, and the other one is that use co-stimulator domain, the molecule CD28, and there are big differences between these 2 products. CAR T cells with 4-1BB, they tend to persist longer in the circulation, while those with the CD28, they have a robust expansion initially in the first 1-2 weeks, but then they decrease, and after 1-2 months, almost none of the patients still have CAR T cells in the peripheral blood. These are the results from Eliana trial performed in children and young adults up to the age of 25 years old. And as you can appreciate from these slides, you can see that a significant proportion of patients actually enjoy long-term disease-free survival, and only 10% of them had the subsequent consolidation with allogeneic stem cell transplantation. So what the message from this trial is that actually at least a significant proportion of patients that receive treatment with this product can achieve long-term disease-free survival without any consolidation afterwards. Now, on the other hand, if with the other product, with the CD28 construct, and this is we have opposite results, and this is a trial from NCI. It's with the CD28 construct, and this trial included 50 patients, mainly children and young adults up to the age of 30. And as you can see from these slides, most of the patients achieved complete remission, and 21 out of 28 patients underwent allogeneic stem cell transplantation, while 7 patients they didn't receive any consolidation. Of course, the decision for transplant was at the discretion of the treating physician. It was not defined by the protocol. However, as you can see from the slides, almost only 2 patients who received allogeneic stem cell transplantation relapsed, whereas all of those who didn't receive consolidation, all of them relapsed in a median of 10 months. Now, on the contrary, if we go to adult patients, and especially if we see the results from ZUMA-3 trial, we can appreciate that first, 2 things. First, we cannot see that there is no plateau in the survival curve, and the other is that 25% of patients who achieve remission, they subsequently had an allogeneic stem cell transplantation, but there was no benefit from allo stem cell transplantation in patients who achieve complete remission. Of course, again, the decision for transplant was not defined by the protocol, and so we cannot have a definite conclusion about the necessity of transplant after achieving CR. And the same we can see the same results we can see from Memorial Sloan Kettering Cancer Center. Again, with the same CD28 construct, you can see that the patients, the long-term disease survival is not like the same like the construct 41BB. And again, the allo stem cell transplantation does not add any benefit. So in conclusion, if we use a construct with 41BB co-stimulation, then a substantial proportion of patients can achieve complete remission and long-term disease remission without allogeneic stem cell transplantation. However, a few patients still relapse, and so we need to identify factors that we can predict the relapse in these patients. On the other hand, those patients who receive CD28 constructs, they behave differently, and especially for children and young adults, it seems that for these patients we should consider seriously to administer as consolidation of relapse and allogeneic stem cell transplantation, while for adult patients we don't have enough data yet about this issue. Now I will switch and I will focus mainly on the treatment with those patients who will receive 41BB constructs, like, for example, Kymriah, that is produced by Novartis. And as I explained before, we need to identify those factors that will, in order to select patients who will be in need for subsequent transplant. So we need what are the pre-infusion risk factors that predict the outcome. There are many trials, but that containing a small number of patients that shows that if you receive previously blinatumomab, then the outcome after CAR T cells is worse. However, this is the large study examining that analyze the effect of prior blinatumomab to CAR T treatment, and what we can see from this trial is that if you receive blinatumomab and you don't achieve CR, then really you have a worse outcome. However, if you receive blinatumomab and you achieve CR, then you have the same outcome as those patients who were never exposed to blinatumomab, and you can see this in these curves. So another significant pre-infusion factor that determines the outcome of treatment with CAR T cells is the disease burden. And the higher the disease burden, the lower the possibility to have a long-term disease-free survival. And in this trial, high disease burden was defined as bone marrow blasts above 5%. And you can see here the difference in these slides. Also, you can see other things, that those patients who receive 4-1BB construct, they had better outcome than those who receive CD28. And also those patients who have circulating peripheral blood blasts, they have also a worse outcome, and these also parameters were retained their prognostic significance in multivariate analysis. Another issue that again we have to, this is only for 4-1BB constructs, is the loss of B-cell aplasia. The persistence of B-cell aplasia is a surrogate marker for persistence of functional CAR T cells. So if a patient loses B-cell aplasia, that means that the CAR T cells are not there, or if they are there, they don't work anymore. So as you can see from this trial, the earlier that you lose, if you lose B-cell aplasia, then that means that you have high possibility to have a subsequent relapse. And actually, the earlier you lose the B-cell aplasia, the earlier, the higher the possibility to relapse. And it seems that if you want to have a good outcome, then you need to have persistence of CAR T cells for at least 6 to 9 months. Of course, those patients that do not lose B-cell aplasia, they don't mean that they don't relapse. But if they relapse, they usually relapse with CD90 negative disease, as you can see from these slides. So finally, the best post-infusion factor that predicts the outcome of CAR T cells and that is useful in order to monitor patients is MRD. And especially, as you heard from the previous speakers, maybe the best method is to use NGS MRD with an NGS assay. And as you can see from this, at least from this trial, it seems that NGS assay is better and more sensitive than using multi-parameter flow cytometry. And again, it's also better to use bone marrow samples than peripheral blood. And as you can appreciate from the slides here, those patients who remain negative by NGS assay at 28 days and at 3 months, they have significantly higher possibility to remain in long-term disease-free survival than those patients who are MRD positive, and these patients, they have a very poor outcome because almost all of them, they finally relapse. And also another important thing from this study is that if you use NGS for MRD monitoring, then you have really enough time, because from the time that the NGS becomes positive, then the median time to relapse is approximately 5 months. So that gives you enough time in order to set up an allogeneic stem cell transplantation to rescue the patients. And finally, I will close with this. This is my final slides. We can, and this is only for patients that they receive 4-1BB constructs. So if you have a patient who have less than 5% of bone marrow blasts and he didn't receive blina before, then this patient has an event-free survival above 50%. So you can close monitor this patient with a sensitive MRD assay. However, if you have a high-risk patient, like patients who have bone marrow blast above 5%, or those patients who had blinatumomab before and they didn't respond, these patients, they have a very high possibility to relapse. So these patients should, you should consider for an immediate allogeneic stem cell transplantation after achieving CR with CAR T cells. And finally, for those patients with other potential risk factors, you can choose one or the other. Now, for those who are monitored with MRD and for B-cell aplasia, if the patients become MRD positive, if they lose B-cell aplasia, then they are a very high risk for relapse. The event-free survival for these patients is below 10%, and then the only salvage for this patient is immediate allogeneic stem cell transplantation. And with this, I finished, and thank you very much for your attention.
Thank you, Dr. Tsirigotis, for your excellent presentation. And now I invite Dr. Laszlo from Croatia, from the management of side effect of novel drug on ALL. Thank you, Doctor.
Hello, and thank you for the introduction. I have an honor to have the last lecture of this meeting. My subject is management of side effects in novel drugs in ALL. Since this is a regional meeting, I have to address the topic of unavailability in the region of most of these novel drugs. My interest developed in this subject when we wrote Croatian guidelines in 2021 with the goal to get these drugs reimbursed for our patients. Here are my disclosures. There are, of course, major advances in understanding pathogenesis of ALL and therefore a development of multiple novel drugs. As we all know, the area of bispecifics, CAR T cells, is upon us in hematology, and so we have some of those available for the treatment of ALL. First of all, the blinatumomab, the bispecific T-cell engager, the monoclonal antibody drug conjugate of inotuzumab ozogamicin, the CAR T-cell therapy, and some of the new TKI inhibitors such as dasatinib and ponatinib. The important thing is that these drugs have different toxicity profile compared to classical chemotherapy. One additional subject I would like to address is a pegylated asparaginase treatment, because it still has a very important role in the treatment of ILL. It's still a backbone of almost all treatment regimens, but clinical practice in administration and management are inconsistent since we don't have strong data. So mostly are consensus based. I will show our Croatian consensus on treatment with pegylated asparaginase. The learning goals are, of course, to review most important side effects of novel drugs in ALL, to learn the management of common side effects, and to address current Croatian guidelines for administration of PEG asparaginase. With the blinatumomab, as we said before, it's important to do the cytoreduction to below 15,000 white blood cells in peripheral blood, usually with corticosteroids and a pre-medication with dexamethasone at the start of treatment and the dose escalation. Neurotoxicities present in about 50% of patients, ranging for grade 1 to 4, but mostly lower grade, at the median of 7 days from treatment start. Cytokine release syndrome also all the grades, but usually lower grade at the median of 2 days from treatment start. Some of recommendations that we agreed on is that, of course, and based on SMPC, in case of more than one convulsion, neurotoxicity or CRS grade 4 and liver toxicity, to stop treatment permanently. In case of grade 3 CRS, liver toxicity, or ICANS, the drug should be stopped and restarted in lower dose and then increased after 7 days. Some of our recommendations are to daily monitor for signs of neurotoxicity with some of the, as you know, questionnaire, size questionnaire, and similar, and also for the development of CRS with the monitoring of vital signs, temperature, and liver enzymes for liver toxicity. CRS signs and symptoms are ranging for mild flu-like symptoms with a fever, headache, mild arthralgia, myalgia, and to fully develop grade 4 CRS, which is life-threatening condition and is managed usually in intensive care units with a systemic inflammatory response syndrome with a hypotension, hypoxia, need for ventilatory support with a capillary leak syndrome, cardiac dysfunction, and multi-organ system failure. This slide is, as we all know, only Tisa-cell is registered for ALL treatment. Axis-cell is currently in research. As far as I know, Lysa-cell is not being developed for treatment of ALL. This is on the table. You see the prophylaxis and treatment for the CRS and ICANS. As you can see with Tisa-cell, this time to onset of CRS is median of 3 days, and with ICANS it's longer, 6 days. The difference in management of those two adverse events is in anti-cytokine therapy. And of course, both are treated with corticosteroids. ICANS can also be treated with anti-seizure medication, cyclophosphamide. The time to resolution is in the bottom of the tables. With inotuzumab ozogamicin, as we said, it's a monoclonal antibody drug conjugate. It's also recommended to perform a cytoreduction to below 10 white blood cells. It can be done with hydroxyurea, corticosteroids, and vincristine. Antimicrobial prophylaxis is recommended. As we said before, the myelosuppression is frequent, and the development of sepsis is also adverse event of interest. As we also said before, there is a risk for renal-occlusive disease of the liver, and we suggest prophylaxis with ursodeoxycholic acid with the dose that is shown. And I would like to address the particular patients at risk for VOD. Those are those that in whom conditioning is carried with double alkylator therapy, and in whom the use of veno continues after 2 cycles of therapy. Those are the patients who are not candidates for allo transplantation, or those patients that we still don't have a donor after 2 cycles of veno. An interval between the last dose of inotuzumab and stem cell transplantation of about 6 weeks is recommended. Our recommendation is also to, in patients that are receiving inotuzumab, monitoring of bilirubin transaminases twice a week, and strict monitoring for clinical signs of VID is recommended. This is the EBMT criteria for grading of VOD in adults. The VOD should be graded to clinical symptoms and according to the revised EBMT criteria. As we all know, VOD is a clinical condition with a painful hepatomegaly, weight increase above 5%, and ascites. In the table, you see the parameters that we are monitoring during the hospitalization and grades of VOD. One important drug that we would like to get in Croatia is a defibrotide. It's still unavailable, and it is of course only drug that has that is potent in treating VOD. But we are still not getting it on the list as reimbursed by our insurance company. Of course, other things that are important is the monitoring of clinical signs and fluid balance. For the TKI inhibitors, I would just like to say that grade 3 to 4 myelosuppression is class effect, and ponatinib has more vascular adverse events, so you should be careful in the patients that have risk factors for vascular disease. And a last subject that I would like to address in this lecture is pegylated asparaginase treatment. These are the most important side effects and our recommendations that are mostly consensus-based, but of course after the review of literature. Pancreatitis, we suggest that the drug should be stopped only in a clinical pancreatitis, not in a biochemical pancreatitis. That is when we have only high values of amylase and lipase, but without clinical signs or radiological signs of pancreatitis. Hypertriglyceridemia should be addressed before treatment. Liver lesion should be managed with a temporary stop of the drug until it is resolved. And you should be especially careful in obese patients, the patients with the liver disease, and in older patients when you should apply the reduced dose of pegylated asparaginase. Allergic reaction is fortunately rare in adults, but we suggest pre-medication with a standard of corticosteroids, antihistamines, and paracetamol before each application. The area that we had the most debate of was thrombosis. As we know, sometimes the drug is stopped with a lower grade thrombosis, uncomplicated DVT permanently, and that is a bit of not so easy because we know that the drug is important for the outcomes. So we suggest that in the event of uncomplicated DVT, you should continue with treatment while treating thrombosis. In a complicated VTE, the drug should be temporarily stopped, and then when the thrombosis resolves, to re-administer pegylated asparaginase. Of course, as we know, coagulation disorder is also present in the treatment with this drug. We agreed that cryoprecipitate or fibrinogen should be used when the fibrinogen is below 0.8. Freshly frozen plasma is contraindicated, and antithrombin 3 supplementation is in accordance with the recommended protocol or institutional practice, usually in the case of antithrombin 3 below 50%. In conclusion, I would like to say that novel drugs in ALL have promising therapeutic benefits, but with different toxicity profile. Blinatumomab and CARDS have some shared adverse event with CRS and ICANS. Inotuzumab has unique adverse event of SOS-VOD. Pegylated asparaginase remains the backbone in ALL treatment, but adverse events are challenging to manage. And tyrosine kinase only, I would like to address that ponatinib is associated with increased incidence of vascular events. Thank you.
Thank you. I don't know. We have time for discussion. Okay. It's time for discussion. Yes, Professor Koru, please.
I have a question for Professor Mansour. Thank you very much for your very nice presentation. We are all agree in this T-cell acute lymphoblastic leukemia. We have very small progress. Unfortunately, the prognosis is still bad, very bad. I'm going to ask you about using venetoclax. I saw some reports about this one. What is your opinion and about using it in clinical practice?
That's a really good question. And we have had some experience with using venetoclax in relapse disease. And so we have used it in about 6 patients now. And the ones that tend to respond are the early T-cell progenitor ALL cases that seem to be most BCL2 dependent, so much more sort of myeloid-like. When the more mature TALLs are also dependent on BCL-XL, so it may be more appropriate to use navitoclax for those cases. But there's a lot of definite activity with venetoclax, which is actually on the UCAL15 adult trial that is being just designed at the moment. It's going to be testing the addition of venetoclax and/or nabitaplax at the end of induction therapy for patients with high-risk disease. So hopefully we'll get an answer in a prospective way, but for sure it has a lot of activity. The other side to that, though, is obviously the myelosuppression, which we are obviously wary about. And I say when we moving drugs into adults is much easier because the outcome is so poor. The pediatricians are still very reluctant to instigate these sort of therapies early in disease because the outcomes are still actually remarkably good in most children.
Other question? Yes.
I actually have a question to Dr. Blaslow. Regarding PEG asparaginase, you recommend pre-medication with steroids. So in pediatric protocols, we really worry about masking and inactivation. For example, if a patient is allergic, in our protocols, it generally says do not pre-medicate, so that you will, if you mask the allergic reaction, then you might not be aware of the inactivation of L-asparaginase. So we generally do not give any pre-medication unless we're all moved up to anemia. Then we just give all patients pre-medication just because we don't have any more options. I wonder if it's any different for adults or any other center. Thank you.
We are aware of the thing that you addressed, but we had more problems with premature stopping of asparaginase. In Croatia, we have a problem that a lot of patients are stopped on asparaginase with difficult to assess was it allergic reaction or not, was it infusion reaction or not, and we made a consensus, of course, on the available data that suggested pre-medication, to recommend it in our consensus.
I think that you should measure the activity of asparaginase because there are also the so-called silent inactivators. So you can, there are some people that they are inactivated without any allergic reaction.
Thank you. Now, I'm sorry, my needs to close. Very good day, but the good things have the end. So thank you very much, everyone, for your presentation and the meeting. Thank you. Thank you, organizer.
I think that all of us are very exhausting, but I'm very happy. I think that we made a good job today and that we covered the most of all fields due to diagnosis and therapy of acute leukemia. And I would like to thank for all participants, especially for their professor state-of-the-art lectures. And I will kindly ask Professor Constanza Donner to come and make closing remarks. Thank you so much.
Yeah, I think we are at the end of a very exciting scientific day. I really enjoyed it very much. I think that we have heard and seen really excellent presentations. What I liked was that we have included young presenters, young hematologists. I really appreciate that. Excellent contributions. I'm really happy about that. And I think this meeting was more than fruitful, very constructive, because we had an exchange in our knowledge and our expertise. And this is, I think, really important to see at what kind of levels we are at the moment treating our patients with acute leukemia, and not only treating, but also to diagnose. And I think there are still gaps between the different countries, between the different, I think, regions in the countries, and also between the different institutions in one country. And I think to bring the national societies together so many national societies that we have here today. I think this is the prerequisite that we can homogenize our work with acute leukemia patients and improve this. So I was really impressed by this exchange of knowledge. I've learned a lot today. I've learned a lot yesterday when I saw the new hospital, the new department. I think it's a high quality standard that you have now. So you have all the prerequisites, but I mean, we have to deal with these regulatory issues, and I think this is something we have to overcome, and this is one of our major goals. I'm really happy that I was invited here, and it's not over yet, Anna, I think. Yeah, so thank you again to all of you, and I hope to see you quite soon again, wherever, in which region I'm coming. Yeah, thank you.
Su bili koncerti? Dobro. Im sastanak u 5, to pozdravimo salu, nešto, da ne završi.
Maybe we will all should have a group picture.
Stavi ono. Stavi malo. Iner. Trči.
I will ask all speakers to come to have a group picture and chairpersons, okay?
Šta bi se?
Medical email.
Šta medical email?
što ste svi ostali posle jednog dosta napornog dana i na ovom simpoziju kompanije Medical Linea. Moje današnje izlaganje ima neobičan naslov koji nisam sigurna kako bih prevela na srpski. What fits to unfit AML patient. Zapravo zašto danas imamo ovaj simpozijum? Razlog je izuzetno važan zato što je venetoclax konačno dobio i novu indikaciju pre mesec dana i danas je on u kombinaciji sa hipometilišućim lekom indikovan za terapiju novodijagnostikovane akutne mieloidne leukemije kod odraslih pacijenata koji nisu podobni za intenzivnu terapiju. Prema tome, ovaj lek bi danas, ako ja dobro razumem, preko člana 9 mogao da se koristi za lečenje naših pacijenata sa AML-om. Danas smo puno slušali o akutnoj mieloidnoj leukemiji, uopšte o leukemijama, ja neću praviti neke duge uvede. Ono što svakako ostaje jeste da se terapija, kao što smo čuli, mnogo popravila, ali da je uprkos tome preživljavanje pacijenata izuzetno nisko i da, gledajući od pozadija, akutna mieloidna leukemija jeste 7. malignitet u svetu po preživljavanju, pri čemu od hematoloških maligniteta ona ima najlošije preživljavanje. Svetski podaci pokazuju da posle 5 godina je živo samo 30% pacijenata sa akutnom mieloidnom leukemijom, a kada govorimo o grupi starijih pacijenata, zapravo posle 5 godina živo je samo 10% naših pacijenata. Akutna mieloidna leukemija je bolest starije životne dobi, prosečan pacijent na dijagnozi ima 69 godina, bolest se najčešće dijagnostikuje između 80. i 85. godine života. Tokom vremena, pre svega zahvaljujući prvo napretku u transfuzijnoj terapiji, pa onda lečenju infekcija i antigljivičnim lekovima, a sada i primjenom molekularne terapije, prognoza ove bolesti, odnosno preživljavanje, se donekle popravilo. U grupi koju vidite ovde, to su svi pacijenti, međutim ako pogledamo drugi dijagram u kome su pacijenti starije životne dobi, starije od 60 godina, preživljavanje je i dalje ispod 20%, što su zaista veoma loši rezultati. Zašto je to tako? Ono što svaki hematolog odmah kaže, zato što je akutna mieloidna leukemija starije životne dobi drugačija bolest, odnosno na mlađu životnu dobi, pacijenti imaju veće frekvencu nepovoljnih genetskih mutacija, pre svega TP53, koje vode i lošijem preživljavanju. Međutim, godine same za sebe i komorbiditeti predstavljaju poseban faktor rizika, odnosno najintenziviji prediktor ishoda u lečenju akutne mieloidne leukemije i zbog toga je adekvatna procena spremnosti našeg pacijenta za terapiju najkritičniji stepen u samoj terapiji. Sa druge strane, izuzetno je važno i ne preterati u toj proceni pa da onda precijenite značaj komorbiditeta i da ne lečite vašeg pacijenta. Ferrara je, dizajnirajući svoj skor, želeo da vodimo računa o nekoliko stvari, pre svega da samom terapijom, kao što vidimo na dijagramu, ne pogoršamo komplijantnost pacijenta za terapiju, da primjenom terapije ne narušimo njegov ukupnu spremnost, odnosno fitness, da naravno ono o čemu mi mnogo mislimo primjenom same terapije ne pogoršamo neki komorbiditet i da na kraju ne primenjujemo terapiju u situacijama u kojima je očekivani životni vek zbog komorbiditeta izuzetno nisak. Kako mi danas ili kako smo u toku vremena procenjivali spremnost pacijenta za terapiju? Prvo smo to radili na osnovu godina, ali je to dosta relativan parametar. Potom smo negde 80. godina razvili ECOG performance status kojim smo merili ukupnu sposobnost pacijenta da funkcioniše, a onda su došli čitavi nizovi različitih skorova kojima smo procenjivali uticaj komorbiditeta na preživljavanje. Naravno, danas prema našem vodiču se primenjuje Ferrara skor i na gornjoj tabeli možete videti zapravo kriterijume za sposobnost pacijenta za intenzivnu terapiju. Kao što vidite, svi oni koji su stariji od 75 godina više nisu kandidati za intenzivnu terapiju, a potom brojne komorbiditete. Donja tabela prikazuje vam pacijente koji nisu kandidati ni za neintenzivnu terapiju. I to se uglavnom radi o pulmološkim bolestima, kardiološkim komorbiditetima, bolestima jetre, bolestima bubrega, koje mogu doprineti tome da naš pacijent nije spreman za terapiju. Međutim, danas je trend da se komorbiditeti ne posmatraju zasebno u odnosu na godine i na samu bolest. I Soros skor ili HCTC i svi mi smo počeli da koristimo kao skor kojim smo procenjivali sposobnost pacijenta da bude kandidat za transplantaciju. Međutim, sa razvojem ovog modela, autori su zapravo u sam skor koji je uključivao sve pobrojane malignitete uključili i neke biomarkere, kao što je, na primjer, LDH ili hipoalbuminemija, a osim toga su uključili i životnu dob pacijenta, također su uključili i osobine same bolesti, dobijajući jedan kompozitni model koji ništa od ovoga neće ni preceniti, ni podceniti i kao što vidite na donjem dijagramu izuzetno će dobro razvrstati pacijente prema ukupnom preživljavanju, tako da danas mi na klinici uglavnom u proceni spremnosti pacijenta koristimo, znači, Sororov indeks ili Ferraru. Ovo je zapravo izvod poslednjih iz našeg registra institucionalnog. U periodu od 2009. do 2021. kada smo napravili poslednji presek, u našoj klinici lečeno je 626 pacijenata sa akutnom mieloidnom leukemijom. Bilo bi, pošteno reći, lečeno je bar ovoliko pacijenata i 166 njih su bili stariji od 65 godina. Ovako smo ih mi lečili u tom periodu. Samo da bismo razjasnili, kada primenjujete intenzivnu terapiju, to je terapija sa kojom imate cilj da postignete kompletnu remisiju i 43% naših pacijenata su bili kandidati, lečeni su intenzivnom terapijom. Niskodozna terapija koju podrazumevaju niske doze citozara primenjivana je u 30% pacijenata. To je terapija koju primenjujete sa ciljem da promenite tok bolesti, ali znajući da nećete postići kompletnu remisiju. I na kraju, palijativnom terapijom nećete promeniti tok bolesti, nećete uvesti pacijenta u remisiju, samo ćete smanjiti njegove tegobe, popraviti kvalitet života i ona je primenjivana u 27% pacijenata. Potpuno logično. Preživljavanje je naravno bilo najbolje kod pacijenata koji su lečeni intenzivnom terapijom, ali su preživljavanja dramatično loše. Zamislite nekoga kome treba da saopštite da zapravo što god da učinite bit će živ negde oko 6 meseci. Naravno, postoji druge terapijske opcije koje se sada smatraju istorijskim i koje pre svega podrazumevaju primjenu azacitidina i decitabina. Ovi lekovi veoma retko mogu uvesti pacijenta u kompletnu remisiju i znači delovati na tok bolesti, ali mogu produžiti preživljavanje, tako da preživljavanje sa primjenom azacitidina iznosi negde oko 10 meseci. Opet ćemo se vratiti na onog pacijenta kome treba da saopštite da će živeti 10 meseci, to baš i nije neki veliki uspeh i čini se da ovaj terapijski pristup u kojima sve lečimo isto baš možda i nije najadekvatniji, nešto bi nam verovatno novo trebalo u tom pristupu. Ovo je jedan konceptualni slajd o tome kako bi trebalo da izgleda lečenje akutne mieloidne leukemije kod pacijenta starijeg od 60 godina. Svaki pacijent na dijagnozi mora da prođe naravno ispitivanje svih svojih komorbiditeta, ali sa druge strane i jedan komprehensivni sveokupni mutacioni status. Ako je pacijent kandidat, ako je on u fit formi i njegov fitness je dobar, on će naravno biti lečen intenzivnom hemioterapijom i transplantacijom ako je moguće. Međutim, šta sa pacijentima koji nisu u tako dobroj formi, koji su unfit? Izuzetno je važno da li kod njih možemo detektovati neku mutaciju koja može poslužiti kao target za lekove kao što je, na primjer, KIT mutacija, FLT3 mutacija, IDH mutacije ili pacijent nema takvu mutaciju pa ga moramo lečiti nekim drugim terapijskim modalitetima. Nove molekule, znači sve ono što nisu citostatici, da tako kažemo, i što nije 3+7 i 2+5, se mogu svrstati u nekoliko grupa. Već pomenuto su genetski inhibitori genetskih mutacija. Imamo iskustvo sa FLT3 inhibitorima kao što je midostaurin, takođe. Uskoro će u zemlji biti dostupan i inhibitor IDH1 ivosidenib. Dosta se radi na ispitivanju reaktivacije TP53. Ako pacijent nema mutaciju koja može biti target, onda se mogu primeniti ne-target terapije. I pre svega, nadamo se da će uskoro biti dostupan i lipozomalni oblik hemioterapije, kao što može biti dostupan i Hitchcock inhibitor, ali danas pričamo o BCL2 inhibitorima koji su u našoj zemlji u ovom trenutku dostupni kao ne-target terapije. I naravno postoje imune terapije, inhibicija PD1, odnosno CD47 i gemtuzumab ozogamicin. Kada smo upoznali donekle nove lekove koji će nam biti dostupni u nekom narednom periodu, postavlja se pitanje kako zapravo da lečimo pacijenta. ILN preporučuje da u obzir uvek uzmemo celu sliku, znači godine, performans status, komorbiditete, kakve su mutacije kod našeg pacijenta i ono što često zaboravljamo što zapravo pacijent želi. Ako je pacijent mlad i u fit formi, ići će na intenzivno lečenje i naravno transplantaciju, a znači ako imamo starijeg pacijenta koji nije u tako fit formi, onda je naš cilj da ostvarimo kontrolu bolesti i poboljšamo njegovo preživljavanje. Na osnovu prošle godine publikovanih preporuka, Osnovni terapijski modalitet za takvog pacijenta je azacitidin sa venetoklaksom. Takođe se venetoklaks može kombinovati sa niskodoznim citozarom. Ako pacijent ima IDH1 mutaciju, može se koristiti azacitidin sa ivosidenibom. Ako pacijent zaista je unfit, onda možemo lečiti samo ivosidenibom i naravno u izvesnoj grupi pacijenata koji nisu ni za neintenzivno lečenje možemo primijeniti najbolju suportivnu terapiju. Američke preporuke nisu zapravo u ovoj grupi veoma neobično revidirane još od 2018. ali želim da naglasim da zavisno od zemlje i od registracije postoji i drugi lekovi koji se mogu primenjivati kao što je gemtuzumab, ozagamicin ili IDH2 inhibitori. Danas je jedan od dostupnih metoda lečenja akutne mieloidne leukemije promjena apoptotskog ciklusa u samoj ćeliji. Kao što svi znamo, kada dođe do citotoksičnog efekta, dolazi do povećane sinteze proteina smrti i apoptoze ćelija. Maligne ćelije svojim mutacionim statusom dovode do toga da se poveća proizvodnja proteina života koje u ovom trenutku nisu dobri za naše ćelije jer inhibiraju proteine smrti, uvodeći ćeliju praktično u besmrtnost. Ako bismo mogli da inhibiramo sintezu tih proteina života kao što je BCL2, mi bismo mogli ćeliju ponovo da vratimo u trenutak kao da nam može imati apoptozu. To upravo radi venetoklaks jednim složenim mehanizmom oslobađajući BIM i BAX protein koji ulaze u mitohondrije, odakle oslobađaju citohrom C, aktiviraju kaspaze i dolazi do apoptoze. I negdje je pitanje zapravo na kraju mog predavanja šta mi možemo danas da koristimo od svega što smo pomenuli u Srbiji. Mi možemo da dajemo azacitidin. Naše iskustva sa ovim lekom traju nekih 1 do 2. Mi smo lečili 10 pacijenata sa akutnom mieloidnom leukemijom. Mislim da je to mali broj da bismo prikazali neke rezultate, ali nam se čini da je preživljavanje produženo. Naravno, postoje klasične metode lečenja 2+5, 1+5, niske doze citorazara, purinetol ili suportivna terapija i sada dobijemo još jednu mogućnost za lečenje o kojoj će rezultatima i mogućnostima zapravo dalje nastaviti profesor Savić. Izvolite, profesore.
Poštovane koleginice i kolege, da ću prvo reći samo par reči nekih praktičnih podataka od kako se daje lek. Znači, čuli smo koje je odobrenje, znači odobrena indikacija sada i u Srbiji je venetoklaks u kombinaciji sa azacitidinom za lečenje onih pacijenata odrasli koji su nepodobni za primjenu intenzivne hemoterapije. Znači, kod novodiagnostikovanih bolesnika. Doziranje ide tako što se u prvom ciklusu prvi dan da 100 mg, drugi dan 200 mg i treći dan se ide na 400 mg, a azacitidin ide od 1. do 7. dana onim standardnim dozama 85 mg po metru kvadratnom. Venetoklaks se uzima jednodnevno u približno isto vreme uz obrok i vodu i izuzetno je bitno voditi računa o sindromu, o smanjenju u stvari rizika za nastanak sindroma lize, tumorskih ćelija, leukemijskih ćelija, znači i odgovarajućom profilaksom i praćenjem biohemijskih pokazatelja ovoga sindroma, citoredukcijom pre početka terapije ispod 25.000 leukocita. Ako je teška eterna lezija, smanjuje se doza najmanje 50%, ako je bubrežna lezija teška, ne smanjuje se u principu doza, ali se vodi računa da je povećan rizik od ovog sindroma tumorske lize. I još jedno samo praktična informacija, preporuka, ako pacijenti primaju inhibitor citohrom P450, ovaj CYP3A, recimo vorikonazol, posakonazol, moramo voditi računa da je onda povećana ekspozicija venetoklaksa i da možemo očekivati viši nivo, veći rizik od sindroma lize tumorskih ćelija i verovatno i od drugih toksičnosti. Kantarion ulje, preparate ne treba uzimati, to su ovi St. John's Wort kapi. Sad prelazim na studiju VIALE-A, to je ta registraciona studija ovako ukupno rečeno, kratko rečeno, to je ovo što je zvanična indikacija, novo dijagnostikovani pacijenti sa AMML koji su bili nepodobni za lečenje, intenzivnom hemioterapijom su randomizovani 2:1 ili da prime venetoklas ciljna doza 400 mg ili placebo u 28-dnevnom ciklusu plus AZA 1. do 7. dana u navedenoj dozi. Ovo je malo detaljnije. Poenta je da se lečenje nastavlja do progresije bolesti ili neprihvatljive toksičnosti. Ili neki, u konkretnom studiji bili su i drugi studijski razlozi za prekid lečenja, ali to je ono što zapravo mi treba da vodimo računa kad krenemo da dajemo ove lekove, ne prekidamo rano, je li tako, nego to što nismo postigli remisiju ne znači da ne nastavimo lečenje, nego je ta progresija bolesti u stvari je razlog za prekid. Glavni kriterijumi uključivanja su bili odrasli, znači pacijenti sa dokazanim AML-om koji su nepodobni za standardnu indukcijsku terapiju i posebno je bilo da pacijenti 75 i više godina bez obzira na komorbiditete mogu biti uključeni, kao i ovi mlađi pacijenti odrasli koji imaju komorbiditete. Ti komorbiditeti, to je ono što je navedeno i praktično je prepisano iz ove studije u ILN preporukama. To su ti kriterijumi, ne znam, da sad ne pričamo o svim tim kriterijuma, recimo prethodna podatak o dekompenzaciji, angini pectoris, ekcijna frakcija ispod 50% i tako dalje, respiratorni ili neki drugi komorbiditeti. Isključene su poboljna citogenetika i APL. Primarni cilj studije je bilo ukupno preživljavanje i kompozitni kompletni odgovor, kompletna remisija. Znači kompletna remisija plus kompletna remisija sa nepotpunim hematološkim oporavkom. I išlo se s ovim postepenim titriranjem doze, tako da sve što je u ovoj studiji je na neki način prepisano u ove zvanične indikacije i preporuke. Ove dve grupe, znači pacijenti lečeni sa venazom i ovi što su lečeni placebo, azacitidin, su bili potpuno uporedive, znači po godinama, medijana je bila 76 godina, po tipu, po polu, po tipu leukemije de novo sekundarna, kao i po svim ovim drugim parametrima, performance status recimo je bio dozvoljen do 3, znači ne 4, to je bila, znači ti pacijenti nisu uključeni, tako da je postojala jedna potpuna uporedivost po podgrupama i ovim citogenetskim i ovim molekulskim i svim drugim kliničkim podgrupama. Ovo je glavni rezultat studije, znači preživljavanje kod bolesnika koji su lečeni venetoklaksom i azacitidinom je bilo značajno duže u odnosu na pacijente koji su lečeni samo sa AZA, odnosno placebo. Azacitidin 14,7 meseci, nasuprot 9,6 meseci. Rizik je smanjen za 34% u ovoj grupi lečena eksperimentalnom terapijom i medijana trajanja lečenja je bila 7,6 meseci nasuprot 4,3 meseca. Ovo su rezultati dugotrajnog praćenja gde je zapravo to isto i pokazano i dokazano i još veće smanjenje ovog rizika od umiranja. Drugi primarni cilj to je bio ovaj nivo odgovora i vidimo da je nivo odgovora bio značajno veći i kad govorimo o kompletnoj remisiji, ovoj kombinovanoj kompletnoj remisiji CR plus CRI, je bio značajno veći kod pacijenata koji su primali venetoklassazu u odnosu na pacijente koji su primali samo vidazu, znači kompletna remisija 36,7 nasuprot negde 18%, kompozitna kompletna remisija 66 nasuprot 28%. I ovde je prikazano vreme do prvog odgovora. Znači, ovde su prikazani samo pacijenti koji su postigli taj kompozitni kompletni odgovor, tako da je 65% pacijenata postiglo taj odgovor nakon prvog ciklusa. onda još 10% pacijenata nakon drugog, 6% nakon trećeg, 12% nakon četvrtog, ali se neki mali nivo dodatnog odgovora postiže sve do praktično 7. i posle 7. meseca, 7. ciklusa terapije, što je praktično 7. meseca terapije. Tako da je ovo neka poruka da ako nema progresije, lečenje se nastavlja, tako. I event-free survival, preživljavanje bez tog događaja koje ovde možete videti, je isto bilo produženo. I kad govorimo o nekom sažetku ovog rezultata vezano za efikasnost, znači jasno je produženo preživljavanje, produžen nivo, povećani nivo kompletnih odgovora i to u relativno kratkom vremenu od gde je vreme do prvog odgovora medijana je bila samo 1,3 mesec, a postignuti ono što nismo prikazali rezultate, postignuti viši nivo nezavisnosti od transfuzije eritrocita i trombocita. To je posebno vidljivo kod nezavisnosti od transfuzije eritrocita 60 nasuprot 35%. Što se tiče odgovora o podgrupama, ovim različitim podgrupama, dobnim, performance statusa, tipa AML, citogenetski rizik, molekularne karakteristike, po molekularnim markerima, vidimo ovo plavo, to su ti stubići, to je venaza, ovo zeleno je placebo aza, znači u svim ispitivanim podgrupama postiže se bolji odgovor. Pri čemu je verovatno veoma interesantan odgovor kod bolesnika koji imaju IDH1 i IDH2 ili kombinovano, gde recimo kod IDH2 je 85 nasuprot 11% nivo odgovora, kombinovani IDH1 i 2 75 nasuprot 11%, ali kao što vidimo čak i kod mutacije P53 opet postoji odgovor 55:0 i to se vidi u preživljavanju. Ono sve što je na plavoj strani, to je u korist kombinacije venetoklaksaza i vidite da su praktično da je sve na toj strani, da bez obzira na podgrupu preživljavanje je bolje ili postoji tendencija boljeg preživljavanja kod bolesnika koji primaju venetoklaks plus azacitidin. To se vidi i ovo je prikazano dugotrajno praćenje, znači dugotrajno preživljavanje. Ovo su sad već rezultati izdvojeno je za IDH1, 2 podgrupu sa mutacijom ovih gena i kao što vidimo ponovo, znači odgovor značajno bolji, preživljavanje značajno bolje, 24 nasuprot 6 meseci. I ovo je ovo dugotrajno preživljavanje, znači gde se efekat se održava. Isto i u FLT3 podgrupi takođe su značajne razlike i u nivou odgovora i u dužini preživljavanja. U intermedijalnoj citogenetici takođe značajno bolji odgovor, u nepovoljnoj citogenetici, čak i ovoj sa P53 mutacijom postoji bolji odgovor, ali to se u preživljavanju se baš i ne vidi, ali to je verovatno jedina grupa koja je, svi znamo, pacijenti koji imaju kombinovanu nepovoljnu citogenetiku i P53 mutaciju, to do sada nijedan lek nije bio u stanju da leči i izleči. I ovde ovo je zajednička jedna analiza i VLA i one prethodne 1B studije gde je zapravo to pokazano i vidimo da ako primenjujemo venetoklak sa azacitidinom u pacijenata koji imaju nepovoljnu citogenetiku, ali imaju wild type P53, da je odgovor je značajan. Ali ovi koji imaju i mutaciju P53, tu dugoročno, bez obzira na onaj odgovor što je bolji, dugoročno ne možemo očekivati neke rezultate. Isto je i u sekundarnoj AML, da se ne bi zadržavao što tiče odgovora, i u preživljavanju sekundarne AML, bez obzira da li je vezana za terapiju ili je iz MDS-a ili iz MML-a. I kad govorimo, znači, ja bih samo ovaj zaključak. Znači, sve podgrupe koje su lečene kombinacijom VNA-AZA su pokazale produženi benefit u ukupnom preživljavanju u odnosu na monoterapiju azacitidina. Ovde su prikazani pacijenti koji su postigli kompozitni kompletni odgovor i u toj grupi su prikazani nivo MRD negativnosti, znači nivo postizanja negativnosti merljive rezidualne bolesti. I opet se može videti da jedan značajan broj pacijenata postiže MRD negativnost i ono što smo i danas čuli ranije u predavanjima vezano za nukleofozmin, 88% pacijenata postiže MRD negativnost svakako u onoj grupi koja je postigla taj kombinovani odgovor. I preživljavanje što je za očekivati ukoliko pacijenti postignu MRD negativnost, oni značajno duže žive u odnosu na one pacijente koji ne postižu. Ovde opet govorimo o grupi pacijenata koji su postigli kombinovani odgovor. To je ovde i ovo produženo praćenje, to je na AŠU je objavljeno prošle godine. Takođe, znači, se održava taj efekat. Ja mislim da ovo i ne komentarišem, jasno je šta je zaključak. Sad prelazimo na bezbednost. Što se tiče bezbednosti, zapravo ovi pacijenti imaju problem sa hematološkom toksičnosti i sa nehematološkom toksičnosti su imali. Nehematološka toksičnost nešto veći nivo mučnine, ali generalno uporedive je bila ova nehematološka toksičnost u ove dve grupe. Što se tiče hematološke toksičnosti koja je svakako značajnija, trombocitopenija i neutropenija su na prvom mestu i da izdvojimo febrilnu neutropeniju. Znači, febrilne neutropenije su u ovoj grupi bolesnika koji su lečeni venetoklas-azom su bile češće. To je jasno i to se vidi u ovim ozbiljnim neželjenim događajima, znači febrilna neutropenija 30 nasuprot 10. To znači da, mada mi imamo i ozbiljnih infekcija kod vidaze smo imali, mada ne tako često, ali smo imali, ali ovde ipak je to češće. Interesantno da pneumonije i sepse uopšte nisu češće u toj grupi, nego čak je pneumonija bila nešto češća, to je vjerojatno čisto ne znači ništa, ali jednostavno ne postoji povećanje pneumonije kod onih koji primaju venetoklas-azom. I kod dugotrajnog praćenja ostaje isti bezbednostni profil. Znači, jednostavno slične su nivoji neželjenih događaja sa izuzetkom hematoloških događaja, ja bih rekao febrilne neutropenije, koja je češća u grupi pacijenata lečeni sa venetoklaks i sa azacitidinom. Znači, prekid lečenja je bio dosta sličan, 24 nasuprot 20%. Prekid davanja leka, znači prekid ne lečenja, nego odlaganje doze je bio češći kod onih koji su primali venetoklaks 72 nasuprot 57%. Mortalitet nakon 30 dana, mortalitet nakon 60 dana, kao što vidimo, je bio veoma sličan, nije bilo razlike. I febrilna neutropenija i neutropenija, trombocitopenija su bili najčešći razlog da se nešto odloži terapije ili da se smanji doza. I ja bih rekao samo da u dugotrajnom praćenju nema novih bezbednosnih signala kod ovog lečenja, da su utvrđeni u ovom lečenju kombinacijom VNA-AZA ili AZA, znači jednostavno ovi neželjeni događaji su u skladu sa onim što znamo i što se očekuje kod primjene ovih lekova. Hvala. Zatvaramo onda priču. Je li ima pitanja ili nema pitanja? Umorili smo se malo. Jeste, malo više.